गजवदन वक्रतुंड महाकाय हे गजवदन वक्रतुंड महाकाय
तुमचेच पाय हे
गजवदन वक्रतुंड महाकाय हे गजवदन वक्रतुंड महाकाय हे गजवदन वक्रतुंड महाकाय वक्रतुंड महाकाय वक्रतुंड महाकाय सुखकर्ता दुःखहर्ता माता विघ्नाची नुर्वी पूर्वी प्रेम कृपा जयाची सर्वांगी सुंदर सिंदुराची कंठी झळके माळ मुक्ता फळाची जय देव 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 रत्न खचित फरा तुझ गौरी कुमरा चंदनाची उडी कुंकुम केशरा हिरे जडिता मुकुट शोभतो बरा गुंजुडती नुपुरे चरणी आगर्या जय देव 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 जय देव
लंबोदर कृतताण विघ्नेश्वर कृतताण धाकट देखिट कनक देखिट कनक देखिट कृतताण धाकट देखिट कनक देखिट धाकट देखिट कृतताण कृतताण कृतताण
स्तवितो तुम्हा संकट अमुचे विलयाला जा
स्तवितो तुम्हा संकट अमुचे विलयाला जाओ
स्तवितो तुम्हा संकट अमुचे विलयाला जाओ हे गजवदन वक्रतुंड महाकाय हे गजवदन वक्रतुंड महाकाय हे गजवदन वक्रतुंड महाकाय वक्रतुंड महाकाय वक्रतुंड महाकाय लंबोदर पीतांबर परिमल वंदना सरळ सोंड वक्रतुंड त्रिनयना दास रामाचा वाटा हे सदना संकटी पावावे निर्वाणी रक्षावे सुरवर
Good morning, all. On behalf of Pune branch and organizing committee, I welcome you all for the day 2 of most awaited BOB 2021. I know yesterday's session was quite busy and full of academic, and cherry on it was JAMA session. I hope you have enjoyed yesterday's JAMA session, and today also we expect similar type of the live interaction with our available international faculties. So don't miss today's JAMA session at 4:30. So with this short introduction, I will start today's session. The first topic is the sepsis. I know sepsis is one of the most hot topic and related to us, and it was sponsored by the Alkem Hospicare. So the first speaker is Dr. Marvin Singer. He's a professor of intensive care medicine, and he has authored various papers, textbooks, including the Oxford textbook of critical care. And his primary research interest is related with the sepsis and multi-organ failure, also with the infection, shock, and hemodynamic monitoring. He's going to speak on one of the most hottest topic of the critical care, antibiotic therapy, and when to start and when to stop. It's regarding the antibiotic. Over to Dr. Marvin Singer.
Hello, my name is Mervyn Singer. I'm delighted to speak to you today on antibiotic treatment and how urgently should we administer it. It's a shame I can't be here in person in Pune, but I send my best regards from London in the UK. So there's been a lot of propaganda over the last number of years. Every second counts, need for speed, etc. But is this actually true? And I wrote this article a few years ago called, "Does every hour really count, or is it incestuous amplification?" This is groupthink, when there's a reinforcement of ideas and or beliefs that occur when the people thinking the same thing come together in a room. So on the one hand, we should be striving for utopia. Give the right antibiotic to the right patient at the right time for the optimal duration. That will help minimize antimicrobial resistance. It won't poison patients who won't benefit. I'll show later on there's a lot of harm associated with antibiotics, and we can remove the fear factor. We'll be litigated if we don't come in quickly with an antibiotic, even when it's not indicated. On the other hand, do we want a dystopian society where there's indiscriminate, rushed antibiotic prescribing? It will cause an increased rate of antimicrobial resistance. It stops the doctor thinking about non-infectious diagnoses. It poisons patients who don't have a bacterial infection, who can't benefit, and there is this ongoing litigation fear, trial by media for doing the right thing. And I don't know what it's like in India, but certainly in the UK, we get lots of these tabloid scandal front pages highlighting alleged failures of doctors, nurses to miss cases of sepsis, and people die as a consequence. So I'm not condoning bad practice, but on the other hand, we don't need to scapegoat doctors unnecessarily. As I mentioned, there's many causes of harm associated with antibiotics. We've got the obvious side effects, toxicity. The patient develops a rash or liver dysfunction, renal dysfunction, diarrhea. We're familiar with the fact that there's overgrowth of multi-drug resistant bacteria, Clostridium difficile, fungi. However, what's less well appreciated are other effects. They are immunomodulatory. They can, especially with the bactericidal antibiotics that destroy the cell wall, initiate a Yarish-Herxheimer reaction. So here you have a large amount of release of bacterial products, such as endotoxin, which engenders an accelerated and enhanced inflammatory response. Antibiotics can compromise mitochondrial function. They have effects on our healthy gut microbiota. And there is, for example, evidence that they compromise the efficacy of certain cancer therapies, such as the PD-1 inhibitors. And we often get it wrong. In the rush to diagnose or overdiagnose sepsis, we often get it wrong. This is a nice study from the United States where they looked at patients coming through the emergency department. More than 50% had negative culture results. Does that mean the microbiology department couldn't find the bug, or perhaps they didn't have infection in the first place? In this trial, 18% of patients initially treated as if they had sepsis turned out to have a non-infectious diagnosis: autoimmune disease, diabetic ketoacidosis, pancreatitis, etc. This is a study from the Netherlands, patients being admitted to 2 university hospital intensive care units with a label of sepsis, and there was a post hoc adjudication after a number of days when the diagnosis became more apparent. And here they looked at nearly 2,600 patients. However, of these, 13% had a post hoc infection likelihood of none. In other words, they definitely did not have an infection. A further 30% had only a possible likelihood of being infected. So only about half of the patients were definite or probable in this post hoc adjudication. Now we should ask the question, how strong is the evidence for immediate therapy? Or perhaps I should change the question around to, how weak is the evidence? If you look at the allegedly positive studies supporting this each hour counts argument, they're virtually always retrospective, using databases collected for other reasons, for example, administrative databases. But these databases often lack vitally important data. Did the patient actually have an infection? Did they get the right antibiotic? Did they get adequate source control? What was the cause of the delay? Was it apparent at the outset that they had an infection? And this is much more difficult, especially in small children or in elderly patients. These studies mainly use complex and rather poorly explained statistical adjustments. The unadjusted mortality, the real mortality, shows little or no effect. These studies often incorporate very delayed treatment, so patients who don't get antibiotics for 6 or 12 hours or even later into the analysis, and there are major plausibility issues with many of these studies. This is one example about meningitis. This is the delay in starting therapy from the time of admission to hospital. And you can see over the first 4 hours, it's only perhaps a small increase, but the confidence intervals are very broad, so there's no clear impact. It's only when you go beyond 4 hours and you stretch it out to 10, 12, 14 hours is the impact on mortality much greater. This nice review came out recently from Thierry Calandra and colleagues in Switzerland, and they looked at all of the papers looking at time to antibiotics and outcome. And they recognized that 2/3 of these studies did find an association. However, the time metric, the duration, varied considerably. It could range from 1 hour to 6 hours or even longer before there was an impact of the delay in antibiotics impacting on mortality. And they noted that those studies showing an increase in mortality usually had very long stretched out intervals, and they were linear models. So they were looking at 6 to 12 hours, and clearly the linear effect is greater if you delay for a long period of time. They made the point that the largest studies did not find an association between early antibiotic delivery and patient outcome, and so therefore they felt you couldn't make recommendations. Of note, every prospective study I'm aware of that specifically looked at antibiotic impact could not show this every hour saves lives signal. And we have a number of before-after observational studies, large quality improvement studies, and there's one prospective randomized trial in the literature, an emergency room study from the Netherlands, where they compared it against antibiotics being given by the paramedics. I was involved in this narrative review with some other intensive care doctors and some infectious disease doctors. And again, looking at the literature, as we concluded, for patients presenting with suspected bacterial infection, withholding antibiotic therapy until early diagnostic tests are available and the diagnosis has been established seems acceptable in most cases, unless the patient has a very severe illness such as septic shock or bacterial meningitis. And this approach, supported by the literature, promotes the use of ecologically favourable antibiotics in the emergency department, reducing the risk of side effects and selection of resistance. What about real world? This came out fairly recently from Johns Hopkins and some other hospitals associated, and they looked at electronic alerts, patients with SIRS and when they got the antibiotic. And as you can see, some patients, 17% got the antibiotic within an hour, 21% there was a delay of more than 48 hours. However, if you look at time to mortality, the relationship to mortality, there was no relationship seen. There was a trend over time, over 6 hours, increasing over 48 hours, but at no point was this statistically significant. And this study concluded that across this 5-hospital study, patients identified with a best practice alert, look at them, treat them for sepsis, they couldn't find an association of timing of antibiotic and mortality, even when they accounted for the severity of illness. We had, and I'll talk later on about the 2021 Surviving Sepsis campaign, but in 2018, the leadership of the campaign put out this recommendation that giving early antibiotics was an essential aspect of high-quality sepsis management, and they argued that antibiotics should be given immediately for patients presenting with sepsis or septic shock. They argued that the compelling nature of the evidence demonstrating an association between bundle compliance and improved survival led to adoption of measures, and therefore they gave a strong recommendation that antibiotics should be given within an hour, and they argued there was a moderate quality of evidence. So remember that. I'll come back to that later on. However, a lot of learned societies did not agree with these recommendations. The Infectious Disease Society of America felt that the interpretation of the studies they felt were very different. They drew different conclusions and different perspectives, so they did not endorse the Surviving Sepsis campaign guidelines. And they argued that, yes, antimicrobials should be initiated as soon as possible to patients with severe infection. However, they were worried that stipulating an aggressive fixed time period from the time of recognition may lead to unintended consequences, throwing antibiotics around to uninfected patients in the rush to meet this time deadline. This recently came out again from the Infectious Disease Society of America. They were worried about antibiotic overuse, overdiagnosing sepsis. They argued against this mandate encouraging aggressive use for every patient, regardless of how sure the clinician was of the diagnosis or the illness severity, overlooking treatment of non-infectious conditions, the lack of a good evidence base, and what does time zero mean? And so they argued that perhaps let's put the focus more on the really sick patients who are more likely to benefit, even though the evidence base isn't particularly strong. And this is how they concluded their position statement. And as you'll see, it was endorsed by many other societies, including, the American College of Emergency Physicians, who themselves came out with a report. And you'll see here, the Society of Critical Care Medicine also endorsed the view. This came out a few months ago. They argued once the diagnosis of sepsis is established, yes, it's good to treat the patient, not just antibiotics, but whatever else the patient needs, fluid, source control, etc. However, again, they argued against this time target because there wasn't a strong evidence base. Yes, the sicker the patient, the septic shock patient, you should perhaps be more aggressive. Otherwise, the relationship between time and outcome is less clear. So they recommend prompt administration of antibiotics, but the very short time thresholds should be reserved for those who are severely ill, and they couldn't offer a specific time. There's nothing new here. A similar argument was had 20 odd years ago about pneumonia. There was a quality improvement measure instituted in the States to try and drive antibiotic use for pneumonia to 4 hours, and all it did was just increase antibiotic use without improving outcome. And I've written quite a lot on this problem, and this is from an editorial we wrote, that you've got to take a nuanced approach. The need to treat patients rapidly and aggressively ought to reflect on how sick they are and how sure you are the diagnosis, rather than a one-size-fits-all philosophy. And I'm delighted to say that the just published Surviving Sepsis Campaign Guidelines has endorsed this view. They now say if shock is present, administer antimicrobials immediately, ideally within 1 hour of recognition. If shock is present and you're worried that there may be underlying infection, the patient may have sepsis, then again, give the antibiotics immediately, empiric treatment. However, if the patient isn't shocked, if the patient has obvious sepsis, there's no point in delaying unnecessarily. You may need to get some microbiology advice about best antibiotic to administer for that patient, but generally speaking, you should give antibiotics promptly. On the other hand, if you're not certain of the diagnosis, the patient is less sick, you should do a rapid assessment for what is the cause, infectious or non-infectious, and administer antimicrobials within a 3-hour window if you're still worried that the patient may have an infection. So in terms of their recommendations, interestingly, you'll remember before 3 years ago, they gave a tag of moderate quality of evidence. Now they've downgraded it. Low quality of evidence for septic shock, very low quality for sepsis without shock. And in terms of the time window, again, a very low quality of evidence, in general. So it's a sad indictment that after so many years of giving antibiotics, we still don't know what constitutes best practice. So this is my schema to finish up. On the y-axis is certainty of bacterial infection, the x-axis illness severity. So clearly, the sicker the patient, the more likely you need to jump quickly if you're worried the patient has an underlying infection. So if they're shocked, jump in quickly within an hour with your empiric therapy. On the other hand, if they're not very sick, if you're not certain, you don't need to treat them. Watchful waiting, observe them, do appropriate tests if need be. Clearly, the more certain you are about the infection, then you've got time to run tests, seek advice. You've got a longer window, but avoid unnecessary delay. And clearly, if the patient's ill, you're not sure that there might be an underlying infection, then it's reasonable to start empiric therapy, and you can always stop it once a non-infectious diagnosis or a non-bacterial diagnosis becomes apparent. So the message is timely, but not rushed. I'll finish here with this book from Lance Armstrong, Every Second Counts. Whatever happened to Lance Armstrong, the famous cyclist, perhaps every second doesn't count. I thank you very much for listening.
Thanks, Professor Singer, for giving us such a brief, concise, and precise overview of when to start antibiotic. And it will remain topic of controversial in which set of class of the patients we should use antibiotic, what is the role of the broad spectrum antibiotic in an emergency department, how to prevent abuse or overuse of the higher antibiotic in non-infectious setting. So I think this debate will go on. We'll move to the next topic. Next topic is the golden hour in sepsis. Does it make sense or does not make sense? And it will be delivered by Professor Vincent. No need to introduce. Please proceed. Professor Vincent, please proceed with the topic. Thank you.
Absolutely. We are all the same, right? A patient is a patient, and, you know, don't worry. I hope my slide will appear. And now I'll discuss the golden hour in sepsis. And indeed, as an introduction, I hope my slide will appear. I hope my slide will appear. I hope my slide will appear. Fantastic! Thank you, merci. Just to be clear and avoid confusion, we all agree that time is very, very important. But the point is that we should never waste time. We should try to do things as effectively as possible, and usually as soon as possible. But the 1 hour delay doesn't make much sense. And indeed, I fully agree with what Dr. Bouza said. We could already look at various types of situation. But to me, for the antibiotic therapy, it could be variable. And for other elements, 1 hour is much too long. Too long. It's a waste of time. I have no conflict of interest, except that I have been in the committee of the Surviving Sepsis campaign, and I have never liked the bundles and the golden hour concept. And yet, these three good friends published this short list of items without discussing it with the committee. And they thought, you know, people will be pleased with that. I am very displeased. And I think it doesn't help, really. Well, first of all, but that's my bias, I like to separate in my mind the infection control and the hemodynamic stabilization. So, of course, they need to be addressed at the same time, of course. But in my mind, I discuss the infectious aspects here, the hemodynamic aspects there simultaneously, but it's two parts of my brain that work together. So here you start with lactate, and then you go to the antibiotic aspects, and then you go back to the hemodynamic aspects. But that's a minor point. Okay, let's move now into the infection control aspects. Of course, we need to obtain blood cultures prior to administration of antibiotics, yes. Perhaps we could add that we could take some other samples, although other samples may not be that urgent. So no discussion there. But administer broad-spectrum antibiotics within 1 hour in every single septic patient. That doesn't make so much sense after all, because indeed, situations can be quite different from one patient to another. If we have meningococcemia, if we have septic shock, 1 hour is too long. It's too long. If we have a patient with some degree of heart failure and some alteration in tissue perfusion and perhaps a lung infection, maybe it's not that clear, and maybe we would like to get maybe a BAL to get a good microbiological sampling. Maybe if it's a complex case, we would like to invite the infectious disease, the ID person, to communicate with us. In our institution, they are immediately available 24 hours a day, so it's not an issue. So if we look at the pyramid of sepsis, going from infection to sepsis and septic shock, of course, as we go up, the urgency in antibiotic administration increases. If you like, we can look at this kind of scheme, a conceptual relationship between the disease severity and the degree of certainty about an infection. Of course, if you are certain about an infection, we need to give antibiotics. But, you know, sometimes even when we have a relatively low degree of certainty, when the patient is very, very ill, in shock, it may be septic shock, we go ahead and give antibiotics early. But there are situations when it's not that clear, not that severe, where we could do some additional tests. And indeed, perhaps consult an ID consult if the situation, an ID person, if the situation is complicated. And I was pleased to see this meta-analysis supporting that concept. Actually, Professor Einav was supposed to be with us. She is from Israel and she could not travel. We had to take her out of the program. But it's a very nice meta-analysis about antibiotic therapy in the emergency department. First of all, there is no doubt about the fact that globally delayed antibiotic therapy is associated with higher mortality. We have plenty of studies showing that, and it's not surprising. If we think that antibiotics are effective, of course, we need to give them early. But look here, a delay in the initiation of antibiotics for 8 hours has not been shown to be associated with worse outcome in patients with mild to moderate disease. This is not septic shock, no, with mild to moderate disease. If uncertain diagnosis, wait for results of biomarkers, we'll speak about that tonight, radiology, rapid microbiological analysis, and clinical reassessment. That's very wise, I believe, because in the US in particular, there is such a pressure in emergency departments to give broad-spectrum antibiotics to every patient coming in with what could be a sepsis. Of course, we have the wide use of broad-spectrum antibiotics with the risk of microbial resistance, so that later on, we need to use even stronger antibiotics or more or broader spectrum antibiotics. Actually, one of our chairmen will certainly agree that there is nothing magical in this 1 hour delay. As he wrote this editorial with Thierry Calandra, who is here too, and Michael Klompas, the time has come to balance the recommendations for early and aggressive antibiotics for all patients with possible sepsis with the diagnostic uncertainty regarding sepsis and the possible harm associated with unnecessary antibiotics. Okay. Let's move now to the hemodynamic aspect. Measure lactate levels. Yes, of course. Lactate levels are not sepsis markers, as we will discuss in other sessions. But they are markers of altered tissue perfusion. They are markers of shock, but it could be septic shock. Now, remeasure if initial lactate is more than 2, where does it come from? Shouldn't we remeasure it in every single patient who may be in trouble? The lactate levels do not always come high and then go down. Some people like to speak about the lactate clearance. That doesn't make sense. There is no, we don't calculate lactate clearance. We look at the trends. We look at serial lactate levels. We look at kinetics. But sometimes the lactate levels are normal and they go up as the patient is in front of us. So don't say that we need to remeasure lactate levels only when they are above 2. Why? No, remeasure it whenever you think that the patient may be in trouble. We should not forget that there is a continuum of severity from the normal value around 1 to 1.5, that's the orange zone, 2, and then indeed above 2, it's compatible with the shock state. Again, we'll discuss it later. But if you go back to the huge data provided by Australians here, you can see that there is a continuum of mortality in relation to the lactate levels, and when it's 1.5, the mortality rate is already close to 20%. This is not only in septic patients, that is in general. So, next, begin rapid administration of 30 cc's per kilogram of crystalloids for hypotension or lactate above 4. Where does it come from, lactate above 4? We just said that any increase in lactate levels is an alarm signal. Of course, lactate levels may come down when the patient is getting better. Okay. But otherwise, the higher the lactate, the more severe the situation. And you have 1 hour to start IV infusion. 1 hour? What, to put the line in? 5 minutes, not more. We have the initial phase of salvage. We need to give fluids rapidly. We open the bottles, and then we should quickly have something to optimize fluid administration. We had this discussion at a session this morning. How could we do a fluid challenge? How can we perhaps use just an echo to evaluate the changes in cardiac output as we give some fluids? That's already the optimization phase. So don't give 30 cc's per kilogram to every patient. That does not make sense at all. Apply vasopressors if patient is hypotensive during or after fluid resuscitation to maintain mean arterial pressure at 60. Why 65? Where does it come from? Do you know? There was a French study showing that if it's 65 or more, it doesn't matter. There is another study from Canada, etc. You could say that you could have it as an initial target. That's fine. But then you reassess. Can't you examine the patient? Can't you take into account that the patient has perhaps a history of hypertension, is elderly, with atherosclerosis? What about the diuresis, the consciousness, the skin perfusion? Yes, indeed, personalized medicine. And that's where I put the vasopressor challenge. I don't like to ask the nurse to select a blood pressure that I think is valuable. I want the nurse to know what the optimal blood pressure is for that particular patient, because we have excellent nurses and they are capable of increasing the doses of noradrenaline and tell us, I see that when I am at 70, there is some diuresis coming back. Whereas if I aim at 65, it does not. Or perhaps more importantly, there are patients who could make urine with a mean arterial pressure of 60. Jan Bakker loves to speak about it and say we should not always raise the blood pressure to 65, and he is right. So altogether, oh my gosh, you have got it all wrong. There is nothing good in there. So the risk is, as for the golden hour in trauma, we have not done much in the last 55 minutes. I still have 5 minutes. I can still measure lactate, put the line in, correct hypotension for 55 minutes, no fluids for 55 minutes. That's absolutely unacceptable, even if you are within your golden hour. And indeed, going back to what our friend Dr. Bouza said, the golden hour was proposed in 1975, he mentioned that, but I like already this editorial in 2015, The Golden Hour in Trauma, Dogma or Medical Folklore. Very good. And then you could see a number of papers addressing the issue and saying, you know, it may be too long. People may rely on the fact that they have 1 hour to stabilize the patient. And I like what Derek Wheeler wrote here, is the golden age of the golden hour in sepsis over. And indeed, perhaps we are finally leaving the golden age of the golden hour and entering a new age in which we are able to use a more personalized approach to fluid management for patients with septic shock. So, yes, indeed, in the trauma field, there is this 10-minute principle that has been proposed by some. So I'll give you 10 minutes for the hemodynamic, for starting the hemodynamic resuscitation, giving fluid, vasopressors if required, measuring lactate levels. The comparison with the trauma field actually is not bad, because there is a continuum of care, because we need a trauma team with a captain giving orders to others, and coordinating all the efforts, because there is a lot to do. Well, the 5 tubes, that applies to sepsis as well, and many other things. Diagnostic techniques, the blood tests, the microbiology, the monitoring, the drugs, and the antibiotics. Indeed, we should not waste time to give antibiotics, and sometimes the nurse has no time to do it. No, sorry, I'm so busy. You give me so many orders. I still have to give the antibiotics. So we need to have a sepsis team. And that's a very important message for every single institution in the world. Should it be a sepsis team? It should be a team, definitely, but sepsis dedicated to sepsis, I'm not so sure, because time is crucial in trauma, in myocardial infarction, in stroke, in sepsis, as rapidly as possible. So, I am finishing my presentation. There is quite a bit to do in sepsis management, and we could have checklists that we could develop. That's my checklist, not very complicated, separating infection control and hemodynamic stabilization. What we could do is to have some form of benchmarking, where we would look at our time delay for measuring lactate levels, and we compare to other institutions, for starting IV fluids, for correcting hypotension, for giving antibiotics. And indeed, we could have, if you like, a 1 hour limit there, but it's not the golden hour that will really predominate. But we can compare our institution to others, and these are mean values, so we can see where we are. Thank you very much.
Thank you, Professor Vincent, for giving us a brief about the golden hour concept, which remains the always we try to understand what is mean by golden hour. No need to go by word-to-word meaning of the golden hour. As early in selective patient and as personalized approach will work in a sepsis patient rather than following any guideline. And usually your energetic way made it simple to understand. Thank you. Now we'll move to the next session. Next session is a keynote lecture. It will be delivered by Professor Ranieri. Professor Ranieri is from the Rome, and he's headed the anesthesia department. And also he carries out his research in the field of the intensive care. And his core area of interest is always related with the different forms of the acute respiratory failure. Yesterday we have heard about whether COVID change our practices, ICU practices by Professor Vincent. Today we are going to have this keynote session, particularly on the whether COVID affected or change our practice of the air-based ventilation. So let's hear Professor Ranieri.
Thank you very much. It's really a great pleasure for me to be here with you today. Unfortunately, it's through a computer, but I really hope that in a very near future, we will be able to share idea, comments, and slides and discuss in person, sharing a cup of tea. It's really always a great pleasure for me to be in India at this meeting, and I really hope that in the near future we will be able to do it in person. But for the time being, let's deal with the computer through the web. Now, as you certainly remember, a number of years ago, the European Society of Intensive Care Medicine, the American Thoracic Society, and the Society of Critical Care Medicine put together the panel that you see here in this slide that I had the pleasure and honor to chair with Taylor Thompson and Gordon Rubenfeld to revise the definition of ARDS. Now, the starting point of this process was the fact that ARDS was originally described in 1967 by Ashbach and co-workers on Lancet. They reported 12 patients with severe hypoxemia refractory to conventional oxygen therapy, but that responded to positive end expiratory pressure. Autopsy in the patients that died showed widespread inflammation, edema, and hyaline membranes. It took 25 years before we end up with the formal definition of ARDS that was presented in 1994 as the American European Consensus Conference, also in this case led by the European Society of Intensive Care Medicine and the American Thoracic Society. What was proposed was a definition that identified two subsets, acute lung injury and ARDS, both characterized by the timing, acute onset, by the presence of bilateral infiltrates at the chest radiogram, and characterized by having a normal wedge pressure as a meaning of evidence or no evidence of left atrial hypertension. Acute lung injury was characterized by a PF ratio lower than 300, regardless of PEEP, and ARDS by the worst degree of PF worsening, with a PF ratio lower than 200, regardless of the level of PEEP. What was the limitation of this definition? First of all, the timing was not precisely defined. The idea that the PF ratio between 200 and 300 was identifying a category less severe from ARDS. There were some inconsistency in terms of PF ratio because PEEP was not considered into the algorithm to evaluate the severity of the worsening of oxygenation. There is a well-known poor inter-observer reliability of the interpretation of chest X-ray. Wedge pressure is known that a wedge pressure higher than 18 millimeter of mercury may coexist with ARDS. And more recently, we have less and less use of this Swan-Ganz catheter, and only in few centers we have this measurement available. And the definition did not include any formal risk factor. Now, a definition of a syndrome, in order to be presented to the clinical community, needs to be validated in comparison to a gold standard. ARDS, as other syndromes in medicine, such as COPD, depression, has to be defined without a gold standard, and therefore indirect approach should be used. The indirect approach that the Berlin definition group used was the validity approach, that is normally evaluated, again, in comparison to a gold standards in terms of sensitivity or specificity, but in case of lack of a gold standard, can be evaluated in terms of phase validity, that is the conceptual model that describe how clinicians, using their gut feeling, recognize the syndrome, and the predictive validity, that is the ability of the definition to predict outcome and or response to therapy. So the consensus conference in Berlin identified the conceptual model of ARDS, a form of acute diffuse lung injury characterized by inflammation with an increase in pulmonary vascular permeability, characterized from the clinical standpoint by severe hypoxemia and bilateral X-ray opacities, associated with an increased pulmonary right to left venous mixture, increased death space, and decreased respiratory system compliance. And that is morphologically characterized by edema, inflammation, alveolar hemorrhage, and Yali membrane. And this is the definition that we adopted since 2012. So a syndrome that is characterized by 4 variables: timing, occurring within 1 week of a known clinical insult, characterized by bilateral opacities at the chest X-ray, not fully explained by effusion or collapse or nodules, that has an origin that is not related by cardiac failure and fluid overload, and that is associated to a number of clinical conditions. When the clinical conditions are not present, such as pneumonia, sepsis, we have to exclude hydrostatic edema if the risk factor is not present in order to make the diagnosis of ARDS. And then characterized by severe impairment of oxygenation, evaluated by PF ratio with PEEP or CPAP, meaning 200 and 300 mild ARDS, 100 and 200 moderate ARDS, lower than 100 severe ARDS, both on mechanical ventilation with at least 5 centimeters of water of PEEP, invasive or non-invasive. For mild ARDS, even spontaneously breathing subject, but with at least 5 centimeters of water of PEEP. Now, this definition has been challenged immediately after the publication in several aspects. Jesus Villar pointed out the fact that a time has to be allowed to the clinician in order to make the diagnosis of ARDS. In other words, ARDS should be confirmed after at least 24 hours with a predefined ventilator settings, an FiO2 at least of 0.50%, and with at least 10 centimeters of water of PEEP. Another criticism that was raised immediately after is the fact that this definition best fit for high-intensity, high-resources hospitals, but in geographic area where ICUs are not immediately available, the Berlin definition does not allow to identify a patient as having or not having ARDS. And therefore, the so-called Kigali modification of the Berlin criteria proposed the use of oxygen saturation / FiO2 to replace the PF ratio when lower than 350, does not require PEEP in order to make the diagnosis, because in many places there are no mechanical ventilators, does not require bilateral infiltrates at the chest radiograph, because you may not have a standard X-ray, and you may therefore use, for example, ultrasound, and so on. Confirming the relevance of bilateral versus non-bilateral infiltrates in the definition of ARDS is this paper published on the European Respiratory Journal by Taifam very few months ago that clearly show that there is no difference in terms of mortality whether the patients have a unilateral infiltrates or a bilateral infiltrates, therefore challenging the line of the definition of ARDS that requires bilateral infiltrates. And another important criticism is the fact that the definition of ARDS, since it is related to the presence of mechanical ventilation, does not allow to include into this high severity category patients at the very beginning of the natural history of acute lung injury. And this is probably the first paper that reported this aspect by Michael Mathey group. Now, because of the COVID, because of the huge number of patients we had to deal with, patients that were all characterized by a very severe, dramatic impairment in oxygenation, requiring high levels of FiO2 and requires high level of PEEP. Often, because of the lack of resources, even in extremely rich countries, these patients were treated with less intensity in terms of support of the organ function. And many of these patients were treated with high flow, non-invasive ventilation, prone positioning during spontaneous breathing. And because of the use of high flow, of the successful use of high flow in the context of the care of patients with COVID-19 induced ARDS, Michael Mathey, Taylor Thompson, and Lauren Ware proposed to update the definition of ARDS, allowing patients treated with high flow to be defined as having ARDS. Is that an appropriate approach? In order to answer this question, we analyzed this subset of patients with COVID-19 induced ARDS that were treated with, at the very beginning of the clinical history of their acute lung injury, with high flow nasal oxygenation. And we wanted to see in this subset of patients two clinical variables. First, did they confirm the criteria for ARDS after intubation? And was the mortality of these patients that were initially treated with high flow with similar to the mortality that you would observe in patients intubated on mechanical ventilation? And here you have the severity of high flow before intubation and after intubation. And you see that you have a vast majority of patients had moderate and severe ARDS that after intubation lost only in the 7% of the cases the oxygenation criteria for ARDS. But I mean, there was a significant reduction in the incidence of severe ARDS that went from the 50% before intubation down to the 13% after intubation. It's also important to see the mortality in the subset of patients that remained on high flow nasal oxygen for the entire clinical course. It was very low, 4%, versus the mortality of the patients that were transitioned from high flow to invasive mechanical ventilation that had a mortality rate of about 28%. So what is the conclusion? That revising the Berlin definition of ARDS in order to allow inclusion of patients with high flow nasal oxygen may actually permit identification of patients at the very early stage. And does allow to identify patients that maintain the PF ratio, the oxygenation criteria that identify patients that are severe enough to be classified as having ARDS. However, allowing patients that are initially treated with high flow nasal oxygen may select a subset of patients that has a much lower mortality. And this may have an important impact in terms of recruitment of patients into future clinical trials. And therefore, if you want to change the definition of ARDS in order to allow recruitment of patients with high flow nasal oxygen, we have to change the conceptual model of ARDS that is characterized by a syndrome characterized by severe hypoxemia and high mortality. If we change the definition allowing inclusion of patients with high flow, we should keep the severe hypoxemia criteria, but we should expect a much lower mortality. Thank you very much.
Good morning, everybody. Welcome you all to our virtual Best of Brussels Symposium. Those who have missed yesterday's lectures and a very interesting JAMA session, I will give a quick review since we have almost 10 minutes in our hands till we start our next session. Before that, this morning, if you have missed very provocative lectures by Professor Marvin Singer and Professor John Vincent. It is just the summary of these two lectures. And then we had a keynote address by Marco Ranieri. We all know Surviving Sepsis Campaign guidelines are well published. And in 2021, we have got a recent edition of Surviving Sepsis Campaign guideline. And the bundles are quite popular amongst many practitioners in India as well as in the world. Marvin Singer actually challenged the approach of giving antibiotic within 1 hour or within a stipulated period of time, and he showed an excellent data, and the evidence is very low to suggest that antibiotics or broad spectrum antibiotic should be given within 1 hour except septic shock. The only exception is the septic shock. If you are treating a patient with diagnosed septic shock, then antibiotic or broad spectrum antibiotic should be given as early as possible, should not wait for even 1 hour. But if you are not treating septic shock patient or bacterial meningitis patient, then it's worthwhile to wait for a few hours in emergency department or in ICU, evaluate the patient for non-infectious reasons for fever or its pathophysiology, understanding pathophysiology or understanding disease process, and then move ahead with antibiotic if we suspect sepsis or infection. This has got a significant importance because all over the world, especially in India, we are facing a huge challenge of antimicrobial resistance. In the last 20 years or so, we have actually changed the ecology of our ICU flora or hospital flora. 20 years back, the colistin was not available in India. I still remember the days when the company called Kane Pharma used to import colistin from UK, and we used to give in very select class of patient in whom we saw resistance in gram-negative infection. Today, colistin unfortunately has become our second line agent in the ICUs. So if we want to improve this state and go back to our old bacterial flora of our hospital and ICU, we must spare broad spectrum antibiotics in our practice. And the way to go is preserve this antibiotic or higher antibiotic or broad spectrum antibiotic only for those patients to be given without proof of bacterial culture, only dire emergency like septic shock or acute meningitis. In other patients, we can still wait for a few hours and appropriately decide the therapy. And Marvin Singer showed an excellent data and even a position statement from IDSA that IDSA does not support the use of broad spectrum antibiotic within 1 hour as suggested by Surviving Sepsis Campaign bundles. And in 2021, Surviving Sepsis Campaign guideline actually took notice of this objections of 1 hour antibiotic and broad spectrum antibiotic and has now changed the guidelines that only in case of septic shock, you should give antibiotic as early as possible. And in other cases of infection and sepsis, evaluate the patient in more deeper sense. Maybe you involve radiologist, surgical colleague, infectious disease specialist colleague, think over it, send various samples, come to conclusion and give a narrow spectrum antibiotic depending upon the site of infection and possibility of bacteria or possibility of microbiological status. Then Professor Jolly Vincent, in his usual way of presentation, we call him as Amitabh Bachchan of critical care. Truly, he's of same age actually. He gave an excellent overview of golden hour in sepsis. All of us have learned a golden hour idea, which came from actually trauma from battlefield medicine. is army medicine, that within 1 hour, you should give maximum support to survive to therapy to treat the patient. This golden hour concept was borrowed from battlefield medicine to sepsis, and it's been quite popular for last 10-15 years. But again, Vincent, in his provocative talk, challenged this concept of golden hour, and he actually quoted one interesting article that golden hour in sepsis, is it a dogma or a folklore in modern medicine? So the golden hour concept is not very valid, and the Surviving Sepsis Campaign bundles has showed about measure lactate, give fluid for 30 ml per kg, start vasopressors if lactate are more than 4. And he actually showed the flaw of all these statements and give a more precise approach of personalized medicine and coined a term which is relatively new for many of us, called as a vasopressor challenge. All of us know about the fluid challenge. The concept of vasopressor challenge has been coined by Vincent in this lecture, that titrate vasopressor therapy for best perfusion for individual patient. And the best number, or one size fit for all, of 65 millimeters of mercury of arterial pressure, mean arterial pressure, may not be true for all patients. And he elegantly showed the data that the titration of blood pressure for best tissue perfusion of individual patient may be the way to go, and a fixed number of 65 may not be the correct. Then we had a keynote lecture from Professor Marco Ranieri. You may be knowing this. Marco Ranieri was a chairperson of a group who published ARDS definition in 2012, which we all know as a Berlin definition. It was first presented in 2011 ESIC Congress and then subsequently published in JAMA in 2012. And he took an overview of ARDS for the last 52 years since Ashback published or coined the term ARDS in 1967. He talked about 1994 AECC definition of ARDS, American European Consensus definition, showed its limitations, and that why Berlin definition was coined in 2011. And the COVID had changed or actually challenged the Berlin definition. And Marco Ranieri elegantly showed that even Berlin definition has got limitation, and we must establish a new definition of ARDS. In this presentation, he showed an excellent modification of ARDS definition called Kigali modification, which is particularly important for a resource-limited setting ICU where arterial blood gas analysis is not available round the clock or may not be available at all, or a radiological investigation may not be available, but still doctors all across the globe who are from resource-limited setting have to treat patients with respiratory failure. So the Kigali modification of Berlin definition was mentioned, and probably it is well endorsed for low-income countries or resource-limited settings. And this Kigali modification talks about SF ratio, that is saturation FiO2 ratio, than PF ratio. And it talks also about no need for positive end expiratory pressure or CPAP to fulfill the criteria for ARDS. And it also talks about involvement of the chest on clinical grounds. You may not have the X-ray, but if you, by simple auscultation or by percussion method, if you prove that there is some consolidation and there is some abnormal lung, either unilateral or bilaterally, then it should fulfill the definition of ARDS. And now in last 1.5 years, COVID has literally challenged the definition of ARDS, because a lot of patients were treated all across the globe, not only in India, but all over the world, been treated by high flow nasal oxygen. So where we should put these patients who have got severe hypoxemia, maybe PF ratio or SF ratio much below 300 or PF ratio much below 300, but still they were treated with high flow nasal oxygen or by awake prone positioning with NRPM or oxymizer therapies. So where do we put these patients in the standard definition of Berlin ARDS? So Marco Ranieri elegantly talked about the need for new definition of ARDS, which should encompass the patients who are treated with HFNO. And soon the new definition of ARDS will come into existence, and COVID has probably given this, I won't say gift, but COVID has probably challenged the Berlin definition, and the new universal definition which is applicable to most settings and applicable to most ICUs and most doctors in the world will be available soon under the leadership of Professor Mathur Ranieri. So this was the summary of 3 excellent lectures in the morning, and still we have 3-4 minutes to go. So I would like to summarize yesterday's event. Those who missed yesterday's events or yesterday's excellent lectures, of mention, please go and visit our website. All these lectures will be available on ISSM Pune website soon. When the technical formalities are completed, we will make these lectures available on our website. So you can see those lectures at your leisure time. The JAMA session was quite interesting. As we know that Just Ask Me Anything, in the short form, we call it as the JAMA, which is a very popular session in Best of Brussels. And in the usual physical format of Best of Brussels, all the eminent faculties sit together on a dais, and as a delegate, we ask anything, really anything about critical care to all the faculties. And we usually get an excellent response, and a lot of our doubts are cleared in this JAMA session. So yesterday JAMA session was not exception to that. We had eminent faculty in the form of Professor Samir Jaber, Alec Holmes, John Damien Reichard, and Professor Marley Osterman from UK. And they talked many good things about which were not discussed in a standard lecture. So of note, important question was when to give bicarbonate therapy in ICU was well discussed in our JAMA session. You must go and listen to our recording of JAMA session. Then another question was asked about immunomodulatory therapies in COVID. Fortunately, in India, as of now today, there are very few patients in ICU all over the country. But our French colleagues, especially Samir Jaber and Alec Holmes, were worried about the 4th or 5th wave in France because they are seeing many new patients in community. Fortunately, the vaccination has done very well all across the world, including India. So most of us believe that even though the number of cases in the community of COVID increase, they may not get admitted in hospital or may not get admitted in ICU as we face the challenge in first wave in 2020 and second wave in April, May 2021. But still, COVID is still not over. We will have to treat some patients coming to our ICU. And all these 4 faculties give an excellent overview and tips from their own practice about use of drugs, especially in COVID, like remdesivir, tocilizumab, or other immunomodulatory agents, colchicine, steroid, anticoagulation. So we talked almost 5 to 6 minutes on anticoagulation in COVID, and this anticoagulation practice is now getting changed in our ICU because we saw many patients with thromboembolic complications in COVID. So COVID anticoagulation or prophylactic heparin or prophylactic medication for COVID has really put a new question on our routine practice of anticoagulation or prophylactic anticoagulation. So I'll hand over the mic to my colleague, Dr. Sandhya Tawekar, and we will start our new session soon. Stay tuned with us, and just to know that we will have another JAMA session at 4:30 p.m. today. And today we'll have exciting faculty with us, including Professor Daniel Debakar, Professor Yandavel, Professor Nino Stocchetti, and we will like to get questions from you. Put the questions in the chat box of our platform, and we will incorporate as many questions as we can, because these questions really give us a good insight or idea about what to do in our individual patient. So I will hand over the mic and presentation to Dr. Sandhya Tawekar. Thank you very much.
Good morning once again, all of you. Moving on to the second session for this morning, we will, I'm sure you're enjoying all the talks this year, and we are really going to make it more and more interesting, lots of interesting topics being covered. we will now be dealing with topics in, managing gastrointestinal critical care. This often poses a lot of problems in ICU, and we have some really good talks lined up for you. So our first speaker for this morning is Professor Craig Coopersmith. He is a national leader in designing, testing, and implementing innovations in critical care. He is a member of the Cancer Immunology Research Program at the Winship Cancer Institute. He has served as a president of the Society of Critical Care Medicine and is a member of the American Society for Clinical Investigation. In 2020, he was inducted as a Master of Critical Care Medicine of the American College of Critical Care Medicine. He's a board-certified surgeon. He specializes in surgical critical care and in the surgical treatment of sepsis and multi-organ failure. Dr. Coopersmith will talk to us on how to protect the gut in ICU.
Hello, my name is Craig Coopersmith, and I am very, very honored to be asked to give this talk, How Can We Protect the Gut in Critical Illness? My disclosures are here. I'm an author on the recent Surviving Sepsis Guidelines and co-chaired Conflict of Interest on the just released version, as well as co-chairing the research arm of Surviving Sepsis. My other disclosures are above. So the healthy gut contains three major components. There's an epithelium with a surface area of somewhere between 30 to 300 square meters, which is somewhere between half the size of a badminton court and a tennis court, an adaptive immune system with more lymphocytes in the gut than any other place in the body, and a microbiome with 40 trillion microorganisms, which is at least as many cells as the host has. The gut is often referred to as the quote-unquote motor of the systemic inflammatory response syndrome and critical illness. And our understanding of how the gut serves as the motor of multiple organ dysfunction has evolved significantly over the past 30 years. And I'm going to talk about some ways in which we might be able to use this at the bedside. So we can first ask the question, how do we measure gastrointestinal dysfunction in the intensive care unit? This seminal paper shows that we can measure absent bowel sounds, diarrhea, bowel distension, vomiting and regurgitation, high gastric residual volume, GI bleeding, intra-abdominal hypertension. And the number of simultaneous GI symptoms is higher in non-survivors than survivors in the ICU. Although none of the GI symptoms alone are an independent predictor of mortality, gastrointestinal failure, defined as 3 or more symptoms, on day 1 is independently associated with a 3-fold increase in mortality. So we might ask, are there biological markers of gut dysfunction we can use at the bedside? And so things we might be able to do at the bedside are use plasma citrulline as a marker of enterocyte mass and plasma IFABP, which stands for intestinal fatty acid binding protein, as a marker of enterocyte damage. There's actually a number of relatively small studies looking at citrulline, showing that it's decreased in multiple different states, in cardiac arrest, in septic shock, and critical illness. Simultaneously, there's multiple studies showing an increase in IFABP in critical illness, in surgical critical illness, in abdominal sepsis, in trauma, in cardiac arrest, and septic shock. Unfortunately, studies in animals and patients outside the ICU, while they support the rationale for the biomarkers, evidence that critically ill patients is not yet convincing, and several specific aspects need to be clarified and the methodology and interpretation to be refined. And so there's a conclusion that there's a good physiologic rationale for studying citrulline and enterocyte and IFABP for enterocyte function and intestinal injury, but further studies are actually needed before we can use this in daily practice in caring for patients in the ICU. So how might the gut serve as the motor of MODS? This is a slide that I love that was shared with me by Paul Wishmeyer. That is actually better than this slide that was published in the final paper in MSphere. And this is taking 1,200 healthy patients and 115 ICU patients and taking their entire microbiome, all 40 trillion microorganisms, and bringing it down to a single dot. And what you can see is that ICU patients, the microbiome, looks fundamentally different than healthy patients. Similar results are seen in children. So right here we see patients in the pediatric ICU, blue we see patients on the pediatric floor, and black are healthy children. Once again, you see a fundamental difference between critically ill patients and healthy patients. So what causes the change in the microbiome? Well, the host response changes in response to critical illness. So just by being critically ill, your microbiome senses what's happening and changes into a pathobiome. In addition, there's unintentional side effects of the treatment of critical illness. We give antibiotics. Antibiotics kill bacteria. That changes the microbiome. We give opioids. They're beneficial for pain control, but they have this unexpected side effect of changing the microbiome. Proton pump inhibitors change the pH, and that in turn changes the environment, which changes the microbiome. And in theory, although it hasn't really been studied much in the ICU, tube feeding also changes the microbiome. So a combination of just being critically ill plus what we do to patients changes the microbiome. Which leads to the question, can we alter the microbiome at the bedside? Well, there's multiple things we theoretically can do. We can increase the so-called good bacteria. We could do this by probiotics, by prebiotics, by symbiotics. We could transplant bacteria by fecal microbial transplant. And we can decrease the so-called bad bacteria by selective decontamination of the digestive tract. And although it's complicated, each of these has potentially been shown to work to some degree. So the first concept is, can we increase the so-called good bacteria? So probiotics are exogenous live organisms. Prebiotics are non-digestible nutrients that stimulate commensal bacterial growth, like fiber. Symbiotics are a combination of probiotics and prebiotics. And when I gave this original lecture at ISI-CEM a few weeks ago, you see the number of references in PubMed for each of them, as well as the specific references for them combined with sepsis. So there's a fairly robust literature for them. One might ask, are probiotics effective? Well, these are two studies that have been published in the last couple of years, a meta-analysis of 13 randomized controlled trials of nearly 2,000 patients, showing a reduction in the incidence of ventilator-associated pneumonia, albeit no effect in mortality, length of stay, or diarrhea, and a different meta-analysis of a slightly different 13 patients, also showing a reduced ventilator-associated pneumonia, albeit not in double-blind studies, and shorter antibiotic uses for ventilator-associated pneumonia, but no effect on length of stay, duration of mechanical ventilation, mortality, and diarrhea. And these studies, which importantly have about 2,000 between 13 different studies, were limited by low quality evidence, heterogeneity, study design, and outcome measures. And this is the slide that I presented just a few weeks ago. But just after I presented this at ISICEM, this study came out in JAMA. The effect of probiotics on the incidence of ventilator-associated pneumonia in critically ill patients. So this is the effect to evaluate the effect of lactobacillus rhamnosus on preventing ventilator-associated pneumonia and other infections in the ICU. A randomized placebo-controlled trial in 44 ICUs in Canada, the United States, and Saudi Arabia, where patients were either given probiotics or placebo twice a day, with a primary outcome of ventilator-associated pneumonia and secondary outcomes of other ICU infections, including C. diff, diarrhea, antimicrobial use, ICU and hospital length of stay, and mortality. And large study, 2,653 patients randomized, And ultimately, among critically ill patients requiring mechanical ventilation, in this much larger than ever before done study, the administration of probiotics compared to placebo showed no difference in the development of ventilator-associated pneumonia, suggesting the findings do not support the use of probiotics. And here's a subgroup analysis for ventilator-associated pneumonia. And you'll notice that no matter which group we look at, every single group crosses one. Surgical patients, there was actually a trend towards harm with probiotics, but there's no group that favors probiotic use. And importantly, here's adverse and serious adverse events. And you'll see these were identified as the isolation of lactobacillus in a culture from a sterile site as the sole or predominant organism cultured from a non-sterile site. And what you see is the serious adverse events occurred in 15 patients who got probiotics and only 1 who got placebo. And you see the odds ratio of 14 with a very wide confidence interval, but not crossing 1, suggesting that not only are probiotics not beneficial, at least this specific probiotic in preventing ventilator-associated pneumonia, there is actually an increased risk of serious adverse events. This doesn't mean that other probiotics could not be beneficial, but this is certainly, I would make the argument, more important than the meta-analysis of multiple, much smaller single-center trials. In addition, this study came out, this is highlighting 2 studies that came out in the basic science literature a couple of years ago in in Cell, suggesting that taking probiotics to counterbalance antibiotics could actually delay the return of normal gut bacteria and gut gene expression. So this has nothing to do with sepsis or critical illness, but just suggesting that just giving probiotics is not as simple as we think, that could actually prevent us from colonizing our own guts. On the other hand, this is an important randomized trial. While I don't take care of infants, this is a randomized trial of symbiotics to prevent sepsis among infants in rural India. So nearly 5,000 infants of at least 2,000 grams of birth, 35 weeks of gestation, were randomized to oral symbiotics and its lactobacillus plus an oligosaccharide or placebo. And there was a significant reduction in sepsis and death with a relative risk of 0.6 and significant reductions in culture-positive lower respiratory tract infections. Another way of targeting the microbiome is fecal microbial transplant. And that's taking in healthy intestinal microorganisms from a healthy donor via infusion of liquid suspension or stool, with the goal being restoring the normal microenvironment in a person with altered gut bacteria. So while this might sound disgusting, fundamentally, this became important when this paper was published 8 years ago in the New England Journal of Medicine. Duodenal infusion of donor feces for recurrent C. diff. Patients got oral vancomycin followed by nothing, bowel lavage, or bowel lavage with donor stool, with a primary endpoint of cure without relapse in 10 weeks. And the study was stopped early because of efficacy in the infusion population, 30% versus 23% versus 94% cure, with minimal adverse effects and restoration of microbial diversity. This is a relatively recent meta-analysis of 37 studies, including 7 randomized trials and 30 case studies, demonstrating fecal microbial transport is significantly more effective than vancomycin, with a relative risk of 0.23 in resolving recurrent and refractory C. difficile colitis, with resolution of 92%. One might say, well, oral vancomycin is actually probably not the best treatment for C. diff. Fidaxomicin is better. And so this more recent study came out showing a stool transplant is superior to fidaxomicin for treatment of recurrent C. diff infection. Small groups, 24 patients in each group and 16 patients in the vancomycin. But what you'll see here at the bottom is, in fact, that fidaxomicin is better than vancomycin, and stool transplant is significantly better than fidaxomicin. So stool transplant is actually standard of care if you have the capacity for recurrent C. diff infection. What are barriers to doing stool transplant in the ICU? Well, the impact of giving bacteria to a patient who already has an altered microbiome, who likely is immunosuppressed, is unknown, and the majority of critically ill patients receive antibiotics at some point. an initiation or continuation of antibiotics will almost certainly alter the microbiome just after giving the stool transplant. So there has to be a commitment to stopping antibiotics prior to and after fecal microbial transplant. There's also this report, which is very concerning, that came out in the New England Journal of Medicine, drug-resistant E. coli bacteremia transmitted by fecal microbial transplant, in which two patients, small number, but two patients had the same stool, same bacteria in their bloodstream that they got from a stool transplant. And one of them actually died, showing that we should be careful with this therapy. But in select cases, this is the largest case series that's out there. Should fecal microbial transplantation be used in the ICU? Again, right now there's simply case reports, but this is a case report of 5 different patients who did not have C. diff, who had intractable diarrhea, who stool transplant cured them. So this is something which is experimental, but still assuredly interesting. The final thing I'd like to talk to you about is selective decontamination of the digestive tract, or SDD. SDD aims to prevent or eradicate oropharyngeal and intestinal carriage of pathogenic microorganisms without adversely impacting the remaining microbiome of the patient or the ICU at large. It's actually not that selective because it targets both normal and abnormal flora, although it does not cover low-level pathogens such as anaerobes, strep viridans, coag-negative staph, and enterococci. So this meta-analysis came out just a few weeks ago, looking at SDD, looking at 41 trials with 11,000 patients ventilated for at least 48 hours. Reporting quality of the majority, unfortunately, was poor. And SDD, which is actually topical plus systemic antibiotics, decreased mortality with an odds ratio of 0.84, translating to 48 fewer deaths per 1,000 patients. SDD also significantly reduced respiratory tract infections with a very impressive odds ratio of 0.43, going to 238 fewer infections per 1,000 patients. There's also the question about do topical antibiotics alone work? So topical prophylaxis may decrease mortality, has an odds ratio of 0.96, although the confidence interval does cross 1, and it may reduce respiratory tract infections. You see an odds ratio of 0.57. And while the odds ratio does, once again, the confidence interval does not cross 1, there is very low certainty of evidence, which is why it gets the may reduce respiratory tract infections as opposed to does. So that's really impressive. That's a large number of studies with impressive relative risk factors. However, essentially all of these trials were done in ICUs with low baseline antimicrobial resistance, most of them in a single country, in the Netherlands. And so this paper came out relatively recently in JAMA, Decontamination Strategies in Bloodstream Infections with Antibiotic-Resistant Microorganisms in Ventilated Patients, a randomized controlled trial. So patients were randomized to receive either chlorhexidine mouthwash, SOD, that's mouth paste with colistin, tobramycin, or nystatin, or SDD, the same mouth paste and gastrointestinal species with the same antibiotics, 4 times a day. A very large trial, nearly 9,000 patients. And ultimately the conclusion was, amongst patients receiving mechanical ventilation in the ICU with moderate to high antibiotic resistance, use of chlorhexidine mouthwash, SOD, or SDD was not associated with reductions in ICU-acquired bloodstream infections caused by multiple drug-resistant gram-negative bacilli compared with standard care. So in conclusion, gut dysfunction is common in the ICU. The microbiome is converted to a pathobiome in the ICU by a combination of critical illness plus things that we do to the patient to treat other things. And although I didn't have time to talk about it today, the microbiome and the pathobiome mechanistically plays a role in mortality from sepsis in preclinical studies. Data from our laboratory shows definitive proof that the microbiome alone causes changes in mortality and critical illness. And although the microbiome can be targeted in the ICU in multiple different ways, none is currently standard of care. Again, I'd like to thank the organizers very much for inviting me. It truly is a great honor to be here.
Thank you, Dr. Cooper-Smith. I think that was an excellent talk on gut failure in ICU. And one of the valid points that he made is just by being critically ill and some unintentional effects of the things we do in ICU to treat these patients play a major role. We can't take questions at this time, but we would really like to request the audience to post your questions in chat boxes for the JAMA session this afternoon. That will make it very interesting. Coming to our next speaker, Dr. Valentin Furman. He's a professor at the Clinic for Intensive Care Medicine, University Medical Center in Germany, Hamburg, Germany. He's a specialist in internal medicine and gastroenterology, additional training in special intensive care, internal intensive care. He has 500 publications in international peer-reviewed journals with over 5,000 citations. His main areas of interest are namely in liver failure, extracorporeal therapies, organ interactions, and multiple organ failure and pharmacokinetics. He will be talking to us on the management of liver failure. Dr. Furman.
Dear friends, dear ladies and gentlemen, I'm very happy to contribute to this interesting meeting. My name is Valentin Furman from Germany, and I'm happy to talk on acute liver failure and clinical management for the intensivist. So let me just share my screen and start my presentation. So, acute liver failure management in the ICU. This is my conflict of interest. For intensivists, the main question is, what is acute liver failure? Because we see different types of acute liver failure at the intensive care unit. For instance, we see people like this guy here who is hemodynamically stable, he's respiratory stable, but he's totally confused and quite yellow. Yeah, this is a patient with kind of primary acute liver failure in this special circumstance due to acute hepatitis B virus infection. He's totally confused. As you can see, he consumes a lot of personal resources. 2 nurses try to keep this guy in bed, and this guy has to be treated at the intensive care unit. On the other hand, we know people like this person here. This person is a patient with severe shock. You can see he's intubated, mechanically ventilated. There's a lot of medical support, a lot of vasopressors, has acute kidney injury, requires renal replacement therapy. And this patient is suffering from acute myocardial infarction and cardiogenic shock, and has aminotransferase levels dramatically increased up to 20,000 units per liter and even higher. This patient is suffering from secondary acute liver failure, also known as ischemic hepatitis or hypoxic liver injury. And this is one of the most common causes of acute liver injury or failure at the intensive care unit. Another person who can suffer from kind of liver impairment or liver injury is this person here. This patient is also severely ill, suffers from multi-organ failure, and this person has acute on chronic liver failure. This patient is suffering from liver cirrhosis and has an acute infection, severe septic shock. You can see here, assume here a lot of ascites, and the patient suffers from septic shock due to spontaneous bacterial peritonitis with multi-organ failure. So all of these kinds are kind of liver failure and have to be diagnosed and treated in a totally different way. Going one step back, a large European study comparing the kind of organ failure and the number of failing organs between 2012 and 2002 assessed also liver failure. And liver failure is over time dramatically increasing in intensive care units. For instance, on hospital admission, the number of liver failure on admission increases from almost 3 to almost 10%. And during the stay at the ICU, up to 20% of patients suffer from any kind of liver failure. That means every fifth patient at our ICU is suffering from kind of liver failure. So this is a problem. This is treated on a daily basis at our intensive care units. For sure, we have to be aware that we have different kinds of liver failure, as mentioned previously. On the one hand, we have acute and chronic liver failure, the patient with liver cirrhosis and multi-organ failure. Its prevalence is about 2 to 5%, depending on the kind of ICU. Organ transplantation, liver transplantation is principally an option. And this kind of liver failure is associated with extremely high mortality rates, depending on the number of failing organs. On the other hand, we have the classical, typical kind of primary acute liver failure. That means acute viral hepatitis B and acute liver failure, paracetamol intoxication, acute viral hepatitis E, for instance, or amanita intoxication, or other kinds. In Western regions, at least in Middle Europe, for instance, this is a very rare kind of liver failure, and in Germany, less than 10 cases per million persons per year suffer from this kind of severe primary acute liver failure. However, mortality is high in this population, 20 up to 50%, depending on the time and the kind of study that was assessing this disease, and liver transplantation is an option in this population. On the other hand, the most frequent cause of liver failure in our critically ill patients is secondary acute liver failure. And we can differentiate two kinds of secondary acute liver failure. On the one hand, hypoxic liver injury with the dramatically increased aminotransferase levels and also high mortality rates, more than 50% usually. And this kind of liver failure has a prevalence up to 15% of all critically ill patients, depending on the kind of unit that you are working on. If you're working on a unit with mainly cardiovascular diseased people, cardiac care unit or cardiothoracic ICU, you will find this kind of liver failure very frequently. In contrast, if you're working on a mainly traumatological ICU, it's not so frequent. And this other kind of secondary acute liver failure is the cholestatic liver injury. This is a consequence of frequently septic shock, abdominal surgery, severe ARDS, prone position, extracorporeal therapies like ECMO, and so on. And this is also an extremely frequent alteration in our critically ill patients that is found in 10 up to 30% of critical patients, and is also associated with high mortality rates. The last two kinds of liver failure, the secondary acute liver failures, are usually no indication for acute liver transplantation. Therapy is focused on the treatment of the basic disease. All in all, liver failure is a typical kind of multi-organ failure. If the liver is not working, usually you have alterations in almost every organ. The brain can be impaired, all hepatic encephalopathy, the circulation is impaired, the endocrine system is impaired, the kidney is the most frequent failing organ in patients with any kind of liver failure. You have an alteration in inflammation, you have a systemic inflammatory response, the pulmonary vascular bed can be altered. So liver failure is the classical kind of multi-organ failure, and just summarized here the typical number of organ failures, of extrahepatic organ failures in patients with liver failure at the intensive care unit. Up to 70% suffer from acute kidney injury, 20 to 30% from ARDS, more than 50% from vasopressor dependent. Hepatic encephalopathy is a very frequent finding. Coagulopathy is also very frequent present, and interestingly also severe acidosis is a really clinical relevant issue in this population. Everybody is talking about COVID. This is my only COVID statement. We also observe acute liver injury, acute liver failure in up to 30% of critical ill patients suffering from COVID infection. The viremia, the virus load in the blood is a significant predictor of severity of liver injury and onset of liver injury, apart from severity of disease, as we could demonstrate this year in a publication. So liver injury is also present in patients with COVID infection, on the one hand, due to a consequence of the multi-organ failure, on the other hand, maybe I think also due to the virus load. From clinical point of view, it's important to differentiate between severe acute liver injury and acute liver failure. On the left hand, you see the criteria for severe acute liver injury: elevation of aminotransferase levels that 2 to 3 times the normal, liver dysfunction defined by jaundice, coagulopathy, or ANR above 1.5, and an exclusion of chronic liver disease. On the other hand, acute liver failure is defined as presence of jaundice, INR about 1.5, and this is the main difference, presence of hepatic encephalopathy. And this is an important issue because if you fulfill this criteria, you can get the term acute liver failure. And in many countries over the world, this is one of the basic principles where you are going to be evaluated also for liver transplantation. From a classificational point of view, we have several timely classes of acute liver failure. We have the hyperacute acute liver failure with insets from jaundice to hepatic encephalopathy within less than 1 week. Acute, the acute form with duration jaundice, hepatic encephalopathy 1 to 4 weeks, and subacute with onset of hepatic encephalopathy within 4 up to 12, or in some definitions also 26 weeks after onset of jaundice. The typical hyperacute form is the paracetamol intoxication or ischemia with severe impairment of coagulation, high risk of intracranial hypertension. And in contrast, the subacute liver failure has mainly the problem in jaundice and the lack of regeneration of the hepatic function. And this is mainly caused, for instance, by idiosyncratic drug reactions or also interdimet etiology. And usually in patients with acute liver failure, liver transplantation, liver biopsy is not necessary, but in patients with subacute liver failure, this may be helpful to exclude presence of cirrhosis, because from a transplantational point of view, you have some different approaches in this population if they are suffering from cirrhosis. So, by summarizing which forms of liver failure do we have, I focus on the statement by the European Society of Association of Studies of the Liver, the practices guidelines for ALF. We have, on the one hand, primary acute liver failure. This can be caused by drugs, by acute viral hepatitis, can be toxin-induced, can be also autoimmune disease or coagulation alteration like Budd-Chiari syndrome, or can be pregnancy-related. On the other hand, we have the secondary forms. They can be caused by most frequently acute ischemic hepatitis, but also some systemic diseases can contribute to acute liver failure. And on the other hand, we have chronic pre-existent liver diseases. Usually you do not talk about acute liver failure in this population. You talk usually on acute and chronic failure, liver failure, but you have some exclusions that can be autoimmune liver disease if it's present less than 6 months, Budd-Chiari syndrome or an HBV reactivation, but this is some special circumstances. If you have a look over the world map, we see different prevalences of different etiologies of liver failure. Middle Europe and Germany, we usually have 3 main issues of acute liver failure: viral hepatitis, drug-induced issues, and the third one is unknown issues. Yeah? And about 1/4 we have other issues that are not so present. In the United States, United Kingdom, we have a little higher rate of acetaminophen intoxications, and in India and in Asia, frequently acute viral infection is the most underlying cause of acute liver failure: hepatitis B virus infection, hepatitis E virus infection, and so on. So that a lot of regional differences in the frequency of different kinds of acute liver failure. What should we do from a diagnostic point of view? For sure, it's important to assess the medical history, to perform examination like ECG, abdominal ultrasound, transthoracic echo, chest X-ray, assess microbiology, and for sure it's important to perform monitoring, at least pulse oximetry, blood pressure, urine output, and daily neurological assessment. From lab testings, we should assess full liver blood tests, including also coagulation parameters, including factor V. We should assess the renal function, always perform arterial blood gas analysis, including lactate levels, assess arterial ammonia levels, and for the underlying etiology, you should perform a tox screening, including paracetamol. You should assess the presence of virus infection, serological screening, hepatitis A, B, E, herpes simplex, and so on. You should assess autoimmune markers for presence or exclusion of autoimmune hepatitis. And you can also assess, according to guidelines, lipase and amylase for exclusion of other complications. For us intensivists, one of the main questions is which patient should be treated at the intensive care unit. Usually the recommendation is patients with presence of acute hepatic injury and presence of coagulopathy, that means INR above 1.5, should be admitted and monitored in hospital. And as soon as hepatic encephalopathy is present, already starting with HE grade 1 or 2, this patient should be admitted to the intensive care unit, and he should already get in contact with the transplantation center, because we know the situation can deteriorate quite quickly. Screening and repeatedly assessment of the organ functions is of central importance. We have a lot of scores in the intensive care unit for daily assessment of our critical ill patients. In patients with acute liver failure, the most frequently used scores are the King's College criteria and the Paul Bruss, the Clichy criteria, where you can perform a risk stratification if the patient has poor prognostic survival rates without liver transplantation, and you can assess if this patient should be considered for liver transplantation. We do not have the golden score that tells you always the truth, so try to incorporate many scores in your clinical experience, try to interact with colleagues from the surgical department, gastroenterologists, and perform repeatedly an interdisciplinary reevaluation of these patients. What are our therapeutic options? We have three main cornerstones to treat these patients. On the one hand, we have the options of targeted therapies. The main issues are organ-specific measures, and for sure we have the option of liver transplantation, and these are the 3 points that I will talk with the next slides. What are potential targeted therapies? We have for different underlying diseases different therapies. For paracetamol intoxication, we have classically N-acetylcysteine. This is the most established and best assessed therapeutic option in this population. For other kinds like acute viral hepatitis B, we have some therapeutic options. For autoimmune disease, we can administer prednisolone, also for drug-induced liver injury, and for other diseases you can find here some suggested potential targeted therapies. However, the evidence is mainly based on retrospective case series, so there's a lack of randomized controlled trials in this field, and the best assessed treatment option is if suspicion of paracetamol intoxication exists in patients with acute liver failure, you should initiate N-acetylcysteine as early as possible in this dosing regimen as mentioned here. In general, what can we offer our patients? What should we look on? We should administer isotonic crystalloid fluids, and our sodium goal should be between 140 and 150 millimoles per liter. So high normal or even slightly elevated sodium levels for to avoid the presence or the progression of hepatic encephalopathy and intracranial hypertension. We should assess the hemodynamics and should administer norepinephrine if the systolic blood pressure is below 90 millimeters of mercury. We should use short-acting agents for sedation and short-acting opioids, mainly propofol is recommended. If a patient deteriorates regarding his cognitive function, we should intubate and mechanically ventilate this patient if hepatic encephalopathy grade 3 or more is present. We should also consider and administer N-acetylcysteine in early non-paracetamol ALF patients. There's one smaller randomized control study that early administration seems to improve the outcome in patients with also non-paracetamol ALF, but in the contrast, if we administered it late, there were worse outcome data. So if you use also N-acetylcysteine in which is non-paracetamol ALF, use it early. From a nutritional point of view, stay basic. The practice of nutrition in patients with ALF should not differ significantly from other critical illnesses because there's no randomized controlled study that demonstrates any difference in outcome in patients with ALF depending on the nutritional regime. I think you mainly should try to avoid complications, have a special focus on blood glucose levels because spontaneous hypoglycemia is a feared complication in this population. Otherwise, try to provide nutritional supply as you do it in every critical ill patient. Patients with ALF are of markedly increased risk of sepsis. So in any circumstances, the patient is worsening of HE, impairment of hepatic regeneration, worsening of blood pressure, should always consider as infection as a cause of deterioration. And as severe infection and septic shock are considered as contraindications for liver transplantations, you should perform an active surveillance with repeated cultures and should also live a low threshold for antimicrobial use in this population. Bleeding is no big issue in these patients usually, and these patients have no higher bleeding risk, interestingly. So coagulation should only be corrected in case of active bleeding and more invasive procedures at intracranial pressure monitoring, for instance, but not on a routinely basis. Therapeutic aspects of hepatic encephalopathy should incorporate quiet surrounding, head of bed elevated 30 degrees, low threshold of empiric antibiotics, ensure normalized biochemical levels of the electrolytes, avoids fever. You should not use prophylactic drugs against seizures. As mentioned already, intubation in HA grade 3 and 4. From a medical point of view, you should use lactulose. There's no evidence for other drugs. L-ornithine aspartate was associated with worse outcome. In case of pressor surges, mannitol can be used, and extracorporeal therapies, I will talk about this in the next slides, is a therapeutic option in this population. In resistant scenarios, you can use a short period of hyperventilation. What about extracorporeal therapies? I think this is a cornerstone of therapy in patients with acute liver failure. About 70% of patients with ALF suffer from acute kidney injury and about 30% require extracorporeal therapies. Interestingly, most of these patients recover from their acute kidney injury during the course of the disease. Usually, most of the centers use renal replacement therapy. There are some centers that have experience with advanced liver support therapies like the MARS system, and some studies demonstrated that MARS system was associated with improved transplant-free survival. On the other hand, we have a randomized control study, a French study, that could not observe advantage in the patient that received MAS therapy in patients with acute liver failure. However, this study has a lot of limitations. Most of the patients were transplanted within 24 hours after randomization, and this is a very short period of time to assess an advantage of a device in this selected population. On the other hand, we have data from high volume plasma exchange in acute liver failure, multi-center European study that could clearly demonstrate a significant survival advantage in patients that received high volume plasma exchange with acute liver failure, and the most benefits were observed in patients that did not undergo liver transplantation. So this seems to be a very interesting and helpful therapeutic option. The main cause may be that plasma exchange dampens the response, the inflammatory response in acute liver failure. Here I present a meta-analysis incorporating, I think, 25 or 26 randomized control studies using liver support therapies. And in this meta-analysis, a sign of improved survival in the group with liver support therapies was observed. And I just want to mention that currently there's a lot of research ongoing with new devices. There are some new kits on the block, like for instance the ATVOS system, a new liver support device that is already approved in the European Union for clinical use. And I think the story is still going on here. So we summarized this in a recent publication. What is the current status of extracorporeal therapies? About 30 to 40% of patients with acute liver failure require extracorporeal therapies. therapies. We have two options. We have the conventional renal replacement therapies. Many centers are using this. However, there's a lack of randomized controlled studies in this field. On the other hand, we have liver support therapies, and we have 25 RCTs in patients with liver failure, and you have both options. I think we need more data. We need specifically more data with conventional RRT in this population, but I think it's a necessary tool that we need during our daily clinical practice treating patients with acute liver failure. What about liver transplantation? This is one of my last slides. Acute liver failure is frequently, in about half the patients in Europe at least, contributes to liver transplantation. We should evaluate patients for liver transplantation early, should transfer them to liver transplantation centers in case of HA grade 1 or 2. We should always consider contraindications for liver transplantation, like hypoxic liver injury or malignant diseases. And the patient selection is based on fulfilling poor prognostic criteria, as mentioned previously, on consideration of relative and absolute contraindications. And this is always a clinically interdisciplinary evaluation. And over time, we learned a lot, and outcome improved dramatically. I like this slide. This is my final slide from the King's College in London. That demonstrates clearly the development of our knowledge in treating patients with acute liver failure. They started with 2 beds in the 70s and initiated hemodialysis thereafter. And you can see in the 70s, mortality rates were more than 80%. In the King's College treating patients with acute liver failure. And during incorporation of hemodialysis, during increasing the number of beds, increasing the number of the intensivist staffing, increasing therapeutic options like the administration of N-acetylcysteine, mannitol, high concentrated sodium chloride, and also liver transplantation, outcome improved dramatically from 20% survival up to 70–80% survival in the last decade. And I think this is a really impressive story, not only due to liver transplantation, but mainly also due to improvement of intensive care medicine. And I think this is one of the most important basic supports measures that we can offer our patients. So I conclude, acute liver failure, critical illness is associated with high mortality, and treatment is very challenging. We have considered always, we have different kinds of liver failure: primary acute liver failure, secondary acute liver failure, as cholestasis and hypoxic liver injury, and acute and chronic liver failure, the patient with cirrhosis. Liver failure is a typical form of multi-organ failure. The liver is a trigger of organ failure, but on the other hand, it can be also a victim of extrahepatic organ failure, mainly in secondary acute liver failure. And the treatment of liver failure is treatment of multi-organ failure and can include treatment of the underlying problem contributing to liver failure, symptomatic treatment, bundle of care, medical and also extracorporeal therapies, and for sure, liver transplantation. Thank you very much for your attention.
Thank you, Dr. Furman. That was a very lucid talk. Unfortunately, we can't take any questions now, but I do request the audience to post any questions you have for our JAMA session. Coming to the next talk for this morning, Dr. Jan de Wiel. He will be talking to us on intra-abdominal hypertension management in 2021. His specialty has been surgery, intensive care in this intensive care unit at the Ghent University Hospital. He works in the Department of Critical Care Medicine in Belgium. Professor Wiel works as an intensivist in the surgical ICU of the Department of Critical Care Medicine. His scientific focus is on optimizing antibiotic use in the critically ill. His research activities currently focus on optimizing antibiotic therapy in severely ill infected patients to improve outcome, combat resistance development with specific interest in PKPD. He also is interested in therapeutic drug monitoring of antibiotics as well as antimicrobial stewardship. His clinical interests also include abdominal infections, source control, sepsis management, and trauma. Professor Wiel.
So, hello everybody. Greetings from Ghent, Belgium. My name is Jan de Wiel. I'm an intensivist working at the Ghent University Hospital, and it's a pleasure for me to talk today to you on the management of intra-abdominal hypertension. As you know, of course, in the past decades, we made significant advances. We learned to recognize the disease. We learn to measure the pressure and to treat the condition. So in the next 20 minutes, I would like to review with you what we've learned and also explore on how we can further improve the treatment of these patients as well as the outcomes. These are my disclosures, none of them in fact relevant for this particular presentations. Now, paradigms may have changed in the past years, but the patient essentially hasn't, although improvements like in fluid management has greatly impacted intra-abdominal hypertension and abdominal compartment syndrome. So this is a picture from the early 2000s. You could recognize this massively swollen abdomen in a patient admitted after ruptured aortic aneurysm surgery. So what I would like do with you today is first review some basics regarding intra-abdominal hypertension, then focus on new treatment paradigms, and then in the end, end with some tips and tricks for managing the open abdomen. So let's get back to the basics. What are the mechanisms involved in intra-abdominal hypertension and compartment syndrome? Well, there's two elements essentially. There's the intra-abdominal volume that can expand, many different reasons for that, but also it's about the abdominal wall compliance, the stiffness of the wall. And if the compliance is very low, then your pressures will rapidly increase. And it's very important to keep this in mind to better understand how to best treat patients with intra-abdominal hypertension. So two elements, the volume and abdominal wall compliance, keep that in mind. Definitions haven't essentially changed. Intra-abdominal hypertension is when the pressure goes above 12 millimeters of mercury, which is not a lot and which is still a level where many of us are really not very much concerned. And I admit that, especially at these lower levels, the organ dysfunction may not be very pronounced or even subclinical only, but it may start to set in. Compartment syndrome is defined as a sustained pressure above 20 millimeters of mercury associated with new organ failure. And organ failure, that is, of course, caused by that intra-abdominal pressure increase. And that may be sometimes difficult to recognize. This grading system has been suggested with lower grade 1 and 2 being, of course, more frequent and associated with some degree of organ dysfunction. But it's only when you get to the higher grades that you will get overt organ dysfunction. Measuring the intra-abdominal pressure, we've done a lot of research on that. And actually, it's quite simple. We use the transbladder approach. As you can see here, the pressure is measured through a catheter that is in the bladder catheter. The pressure in the abdomen exerts its pressure on the bladder. And then when you connect the transducer, after, of course, clamping the urine bag, then you can measure through this transducer, which is placed at the mid-axillary line, you can measure the intra-abdominal pressure using any monitor you have. So quite easy, quite straightforward. What is a normal pressure? Normal pressure is probably around 5 to 7 millimeters of mercury in most patients. In the ICU, pressures may be higher, of course. There is some effect of body weight, and we've seen that patients with higher body mass indexes do have higher baseline pressures, as you can see here. Although even with these higher BMIs, it rarely gets above 15 millimeters of mercury. But again, it is an important consideration that we may need to consider more as more and more of our patients are in fact obese. This is a very important slide to really understand the importance of intra-abdominal hypertension, and especially this dose-dependent relation between organ dysfunction on the one side and the intra-abdominal pressure, whereas we like to think of it as a certain threshold above which you have intra-abdominal hypertension or compartment syndrome. It's actually, there is this gray zone between a normal pressure and full compartment syndrome with this dose-dependent relationship between organ dysfunction and pressure. Very important to keep this in mind when treating patients with intra-abdominal hypertension. It is a multi-system disease. Let this be very clear, although probably the most pronounced effects are on respiration, kidney and hemodynamics. Intra-abdominal hypertension will affect to some extent, or can affect to some extent, every organ system, from the brain, from the adrenals, the intestinal blood flow, of course, but even the blood flow of the abdominal wall, abdominal muscle wall. It's very important to consider this as a multi-system disease. Now, in the past, a lot of risk factors for intra-abdominal hypertension have been described. It is not always easy to memorize all of them, but I like to use these three main categories, and I like to use this clinical construct to recognize patients at the highest risk. First of all, there's the abdominal catastrophes, pretty straightforward. This is probably where most of us have seen the first cases of abdominal compartment syndrome, abdominal trauma, pancreatitis, infections, and often surgery is involved here. But also in patients with severe organ dysfunction, and especially when combined with this third element, this massive fluid resuscitation, should also point you to the possibility of intra-abdominal hypertension. So organ dysfunction, fluid resuscitation, if you have a patient who ticks any of these boxes, it's probably advisable to go out and measure the pressure when you see a patient deteriorating. This is the management of abdominal compartment syndrome and intra-abdominal hypertension in the ICU. It has many different aspects. It's, of course, about measuring the intra-abdominal pressure, but also preventive strategies in the operating theater mainly, but also in the ICU, for instance, by being very careful with fluids is something to consider. And when it develops, when intra-abdominal hypertension develops, there's a number of medical and surgical. And I'll zoom in on that in the next slides. You may recognize this. This is the Abdominal Compartment Society's treatment algorithm. It has been published already years ago, and it summarizes, it gives you a lot of different options to choose from to treat these patients. I consider this to some extent to be the old paradigm because it starts with a pressure and then gives you a number of options, but it's not really patient specific and you don't get really clear recommendations. But the main issue I have with this is that it's based just on intra-abdominal pressure measurements and it ignores the dynamics that are often present. Also, we should add that for many of these recommendations, the scientific evidence behind it is quite low. Dynamics are important because I think depending, of course, on the course, some patients with evident compartment syndrome may need to be managed non-operatively, where in some other patients, even lower levels of intra-abdominal hypertension may require strategies as invasive as decompressive laparotomy. So it's not really about 12 you do this and 25 you do that. You may need to consider these interventions at different stages of the disease. But therefore, you need a new paradigm. And in the rest of my presentation, I would like to give you this, I would like to review with you this conceptual framework on how to translate these guidelines into a practical approach, taking into account, well, patient physiology to start off with, clinical experience and current evidence we have. In fact, we summarized this in this recent article that was published in the annual update last year. A clinician's guide. This is the it's open access, and this is the QR code if you want to have a direct link to this article. So what is it about? And a very important concept here is this triangle approach. It's important to understand that in intra-abdominal hypertension, that there is a continuum from maybe subclinical to subclinical symptoms associated with elevated intra-abdominal pressure to an immediate life-threatening condition. So it can be anything in between that. It's also possible that you move from one side to another and then back. So the dynamics is definitely something that we need to consider more. So the idea here is that the optimal treatment choice for a specific patient should be based on three elements, should take into account three elements. The measured intra-abdominal pressure for one, including the degree, the magnitude of the increase, the organ dysfunction characteristics or the impact, that's the second one. And the third one is the cause of the underlying intra-abdominal pressure. What is the cause? So it's pressure, impact, and cause. And all of this will determine intra-abdominal hypertension management. So first, the intra-abdominal pressure, of course, this is something that we know that we've been considering very often. The measurement should be reliable, and especially in patients who are breathing spontaneously, we should be very careful. The baseline value is also important. We know in patients with ascites, obesity, the baseline level can be higher. So if you go from 13 to 16, the impact may be different when you go from 6 to 16. Although in many situations, of course, we have to acknowledge we don't know the baseline value. And also the duration of intra-abdominal hypertension, the elevation of the pressure. Has it been only a few minutes or hours, or has the pressure been high for a number of days? Second one is the impact. Organ dysfunction is, of course, what we need to consider. Initially, it can be subclinical, but often it will be pronounced once you hit 15 or higher. The severity of organ dysfunction, and again, especially organ dysfunction, needs to be there, because if not, then you need to recheck the intra-abdominal pressure measurement. The organ dysfunction that is present is most often respiratory and kidney, but also duration, dynamics, and speed are important. And thirdly, the etiology, cause and context, very important. In a patient who has just had hernia surgery, for instance, a level of 18 may be tolerated by the surgeon, whereas in a patient with burn resuscitation, this may have completely different implications. But finding the cause, identifying the cause, what is contributing to the intra-abdominal hypertension is critical. It's the clue to directed treatment. So from this triangle, there's a number of questions that come out of it. Pressure and impact will determine the need for intervention and in what time frame it is required, plus also the level of invasiveness. The need for the intervention is therefore the first question. You need to have organ dysfunction present, caused by this relevant increase in intra-abdominal pressure. So these two elements together will identify the need. Next question is, when do we need to do the intervention? How urgent is this? And this is where the value, as well as the severity, the value of the intra-abdominal pressure and the severity of organ dysfunction will actually determine this. A rapid increase with fast deterioration requires an urgent intervention. When you're not able to ventilate a patient, when the patient is hemodynamically unstable despite whatever you do, then you need to act quickly. And then the final question is, what is the best method? And this is where the cause comes in. You need to identify the cause and then actually identify the best treatment option based on what is causing the increase in intra-abdominal hypertension. So when you've identified this, there's a number of things you can do, reducing the intra-abdominal volume with kinetic, with prokinetics, enemas, etc., nasogastric tube. Many situations, it does take some time for the effect to be there. Reducing intra-abdominal volume, percutaneous drainage or needle decompression in case of air. This can have a more quick effect depending on the extent of the volume that is contributing to the intra-abdominal hypertension. Improving abdominal wall compliance, sclerotomy, sedation, or muscular blockers, again, can help to improve abdominal wall compliance and definitely need to be considered. A definitive therapy is opening the abdomen. Of course, this does have implications and is something that we would try to avoid and only use when there's no other options or in case of a dramatic increase that can only be treated in this way. So this is a summary of the 4 treatment targets you have and the different strategies. And then it's important to identify, to select the correct method. Just to give you a few ideas, this is a patient with severe acute pancreatitis on his 4th day into admission, admitted to the ICU because of respiratory failure, intra-abdominal pressure 24 hours later, the pressure was 18 and the patient is oliguric. So when we use this paradigm, the first question is, do we need to intervene? And the answer would be yes, because you have a pressure that is higher, respiratory and kidney insufficiency. When to intervene is more difficult. The intra-abdominal pressure only increased slightly, moderate organ dysfunction, and there are other contributors because pancreatitis per se also contributes to organ dysfunction. So in this case, we didn't go for abdominal decompression. We check for ascites and drain some and put in a nasogastric tube. If the pressure would have been 28, the situation would have been different, particularly if the patient would be hemodynamically unstable or unable to ventilate. And in that case, if the pressure increased rapidly in the past hours, with intra-abdominal pressure as the main contributor, then you need a quick intervention, and then decompression would be the solution. In another situation with the same patient, if the patient would have 19 of pressure and it would be clinically okay and no organ dysfunction at all, then the first thing would be to check the intra-abdominal pressure. In this case, pressure may be lower, and it was just because the patient was in pain that he was that he had increased tension in the abdominal wall muscles. So in these patients, you may want to treat this, but not in a very aggressive way. And another patient, another example, in this patient after GI surgery with an ileus and gastric distension, he came in with hypertension, and his first measurement was 26. So 26, a high pressure with organ dysfunction. We need immediate action. There's no doubt. And whereas decompressive laparotomy would be an option, of course, nasogastric decompression is a more efficient way to treat this specific cause of intra-abdominal hypertension. So great advances have been made. I just want to end with a few thoughts on the open abdomen, because when you see this in the OR, the abdomen cannot be closed. These are the ways we used to do it in the past, the upper left, the upper part of the slide. And now we will mainly be using negative pressure assisted wound closure, such as this one. It's, I think, become the standard in many institutions, and this shows you how it is done in the OR. Still, if you can avoid this, of course, this is a better thing to do. Supportive management in the ICU remains very important. Patients do require mechanical ventilation. We need to have higher than average PEEP levels, although setting the PEEP at the level of the intra-abdominal pressure is not a good idea and will make the patient worse. Hemodynamics is very challenging because if you give fluids, you will make the situation often worse. So it's balancing giving fluids versus overloading the patient. But do mind again that intra-abdominal hypertension affects all organ system and may even mimic a fluid responsive state. So don't be fooled there. In case of an open abdomen, there's no reason to sedate open abdomen patients. Encourage spontaneous breathing when possible, and do mobilize after checking with your surgeons. Do mobilize these patients. The same holds true for nutrition. There's no evidence that you can that you should withhold enteral nutrition in these patients. Some studies have even reported better outcomes by providing enteral nutrition to patients with an open abdomen. The only thing to consider is that there is considerable protein loss through the abdominal fluids lost. So definitely something to take an eye on, and also take the management of open abdomen patients very seriously. So in conclusion, dear colleagues, I'm very happy to say that intra-abdominal hypertension and compartment syndrome have been well described. We know about the risk factors, and we know that they can significantly contribute to organ dysfunction. Probably the incidence and severity are decreasing because we learn to recognize the disease, we learn to prevent the disease, and particularly fluid management does make the difference. Management of intra-abdominal hypertension is often complex. I will admit that, of course, but I hope that this triangle perspective, considering not only the pressure, but also the impact and the cause, is the clue to a targeted, personalized, individualized treatment. So new paradigms, trying to tailor the treatment to the patients, are definitely the way to go for the next decade, I think. And with this, I would like to thank you very much for your attention and end this presentation. Thank you very much, and bye-bye.
Thank you, Dr. Jan de Wiel. That was really an extensive and a very, very important talk. Unfortunately, we're running a little behind time. Any questions should please be asked during the JAMA session. Coming to our session 10 for this conference, which is on nephrology. Our first speaker is Professor Dr. Alexander Arbach. He's a senior staff member of the Department of Anesthesiology and Intensive Care Medicine in Münster, Germany. He studied medicine at the Heinrich Heine University, Düsseldorf, and graduated in 2003. In May 2003, he began his clinical training in the Department of Anesthesiology and Intensive Care in Münster, Germany. Scientific work focuses on the molecular mechanisms of leukocyte activation and recruitment in the context of systemic inflammatory disease and acute kidney injury. Professor Arbach.
Hello, everybody. Thank you very much for the kind introduction. I will talk in the next couple of minutes about prevention of acute kidney injury. Acute kidney injury is a syndrome and it's not a disease. Acute kidney injury can be triggered by different causes, and we cannot compare this syndrome with a disease, for example, myocardial infarction, because myocardial infarction has one pathophysiological mechanism, whereas pathophysiology of AKI might be very heterogeneous. Acute kidney injury is a common complication in hospitalized patients, especially in critically ill patients. Here, the AKI incidence can go up to 50%. AKI can be triggered by different causes, for example, sepsis, ischemia, surgery, and so on. On the right side, you see that the most common cause of acute kidney injury is sepsis, whereas the second most frequent cause is surgery. There are a couple of risk factors for the development of AKI, for example, age and different comorbidities, including chronic kidney disease, cardiovascular disease, and diabetes mellitus. Nowadays, we use the KDIGO criteria to diagnose and stage an AKI. The definition is based on changes of the serum creatinine and or urine output. However, we have to keep in mind that both functional parameters have several limitations. So the serum creatinine has a very low sensitivity because the serum creatinine levels only increase if we lose more than 50% of the GFR. And the urine output has a low specificity because this functional biomarker can be influenced by several factors. For example, the application of diuretics or hypovolemia. Here you see that acute kidney injury is a continuum that starts with an increased susceptibility and ends with an organ failure. An increased risk and kidney damage are clinically silent, so we cannot use the functional biomarker serum creatinine and urine output to diagnose these stages. If we have a disease progression and the GFR goes down, then we can use the serum creatinine and urine output to diagnose and stage an AKI. However, to identify the golden hour of AKI, that means an increased risk and kidney damage, we need new biomarkers. And this is a landmark study by Michael Haas and colleagues, and they divided more than 2,000 patients into 4 groups based on the serum creatinine levels and the biomarker level. Here in this case, they used NGAL as a biomarker. First of all, they divided the patient based on the serum creatinine. In patient with an elevated serum creatinine, the 2 groups on the right side, but I want to focus on the 2 groups with a normal serum creatinine. And in the second step, they divided them based on the biomarkers in biomarker negative patient and biomarker positive patient. And here you see that patients who have a normal serum creatinine and a negative biomarker have a low mortality and dialysis rate. However, patients with a normal serum creatinine and an elevated biomarker level reflecting a kidney damage without a loss of function had a significantly increased dialysis and mortality rate, suggesting that a kidney damage without a loss of function impacts patients' outcome. And based on this landmark study, a new term was introduced, and this was subclinical AKI. And here in this 2x2 table, you nicely see the relationship between kidney damage on the x-axis and kidney function on the y-axis. So normally we are in the upper left panel, so our kidneys are doing fine. If there is a damage, we move to the upper right part, so the biomarkers, the damaged biomarkers increase, but the function is normal. So the serum creatinine is normal and the urine output is also normal. If we have a disease progression, then we move to the lower right panel. So the biomarkers are elevated and the serum creatinine is increased or the urine output is decreased. Based on all these data, the ADGI group proposed a new definition of AKI, as you can see here. You know the left part of the definition here. You see the functional biomarkers, serum creatinine and urine output, but damaged biomarkers were added to these functional biomarkers. There is actually one new stage, that's the first stage, stage 1S. This is actually subclinical AKI. Here the functional biomarkers are normal, but the damaged biomarkers are elevated. And all the other stages are divided in damaged biomarker positive and damaged biomarker negative stages, because patients who have positive damaged biomarkers have a worse outcome. However, we cannot use all biomarkers to detect a subclinical AKI as shown in this study. So Claudio Ronco and his group showed that TIM2 and IGF-BP7 cannot be used to detect a subclinical AKI. TIM2 and IGF-BP7 were identified as new biomarkers back in 2003 in the context of the SAPPHIRE trial. Both biomarkers are involved in the cell cycle arrest. What does it mean? So normally the cells, also tubular epithelial cells, are in the cell cycle. Once they get damaged, they can leave the cell cycle and go into the cell cycle arrest. Here, they are protected from further damage and they have enough time to recover from the damage. And once they have recovered, they can enter the cell cycle again. And in the SAPPHIRE trial, the authors performed a large observational trial and looked whether these two cell cycle arrest biomarkers can predict a moderate or severe AKI after ICU admission. And here you see that the performance of TIM2 and IGF-BP7 was significantly better compared to other biomarkers, for example, urine NGAL, cystatin C, and so on. And in this trial, they identified two cutoff values. The lower cutoff value is the cutoff value below 0.3, and this rules out a moderate or severe AKI within the next 12 hours. The negative predictive value is very good, it's 0.94. That means that 94% of the patients who have a biomarker levels below 0.3 don't develop a moderate or severe AKI within the next 12 hours. And on the other side, there is a high cutoff value, values above 2.0, and these values have a very good positive predictive value in predicting a moderate or severe AKI within the next 48 hours, and the positive predictive value here is 0.86. The beauty of these biomarkers is that they are not influenced by comorbidities like other biomarkers. So patients who have a chronic kidney disease have elevated NGAL levels, and this will, of course, influence the predictive value. But this is not the case for TIM2 and IGF-BP7, as shown in this post-hoc analysis of the SAPPHIRE and TOPAZ trial. Here, the authors demonstrated that TIM2 and IGF-BP7 levels only increased in patients who subsequently developed an acute kidney injury, but not in patients who didn't develop an acute kidney injury. And as you can see here, the biomarker levels were not influenced by different comorbidities like chronic heart failure, CKD, or COPD. We wanted to know whether the two biomarkers can also be used in patients undergoing cardiac surgery. And here we focused on high-risk patients for high risk for AKI. And in order to identify these patients, we used the Cleveland Clinical Foundation score. So we only included patients with a score equal to or higher than 6. And here in this table, you see that for each risk factor, you get a certain amount of points, and the number of points you get correlates with a dialysis-dependent AKI after cardiac surgery. That means if you have a score between 6 and 8, you have a 10% probability to develop a dialysis-dependent AKI after cardiac surgery. And we measured the biomarkers before surgery as baseline for 8, 12, and 24 hours after cardiac surgery. And here on the left side, you see the results. So we looked for the composite value. That means that we took the highest TIM2 and IGFBP7 value within the first 24 hours. And you see that the area under the curve is excellent. It's almost 0.9. But if you only want to measure the biomarker once, you should measure it 4 hours after cardiac surgery. Here, the area under the curve is still quite good. It's 0.805. And this was significantly better compared to the area under the curve of ENGA, which was only 0.679. This is a meta-analysis by John Callum and colleagues, which was published 2 years back, and they looked for the predictive value of the cell cycle arrest biomarker and whether they can predict the cardiac surgery associated AKI. So they also focused on cardiac surgery associated AKI. They identified 10 studies, and they demonstrate that the overall area under the curve is 0.83, and that the area under the curve was not influenced by different factors, for example, age, other criteria, or time of measurement. But we can also use the biomarkers to predict an adverse long-term outcome. These are data from the Sapphire trial. So the authors followed the patient for almost 1 year, and here they looked for a composite endpoint of death or dialysis, and they demonstrated that patients who had an AKI and initially low biomarker levels had a better outcome compared to patients who had an AKI and had initially high biomarker levels. So in 2012, the KDIGO guidelines were published, and the guidelines recommend to implement a bundle of different measures in patients at high risk for AKI. And these patients can be identified by biomarkers. And the bundle consists of different measures, including discontinue all nephrotoxic agent when possible, ensure volume status and perfusion pressure, consider functional hemodynamic monitoring, monitoring serum creatinine and urine output, avoid hyperglycemia, and consider alternatives to radio contrast procedures. And we wanted to know whether the implementation of this KDIGO bundle in high-risk patients identified by biomarkers can prevent the development of acute kidney injury after cardiac surgery. And this was the PREVACI trial. This was a single center trial which we performed in Münster from 2014 to 2016. And here you see the study flow. So we measured TIM2 and IGFBP7 in all patients undergoing cardiac surgery. High-risk patients were defined as patients who had a biomarker level equal to or higher than 0.3. These patients were randomized into a control group. Here they received the standard of care therapy. We kept the mean arterial pressure above 65 millimeter of mercury and the center of the venous pressure between 8 and 10 millimeter of mercury. And in the intervention group, we implemented the KDIGO bundle. So we discontinued all nephrotoxic agents when possible. We also discontinued ACE inhibitors because it is known that these drugs can cause perioperative hypotension, and this is associated with an increased risk of AKI. We optimized the hemodynamic situation. I will show you the algorithm on the next slide. Monitor serum creatinine and urine output, avoid hyperglycemia, and consider alternatives to radio contrast procedures. Here you see the hemodynamic algorithm we use to optimize the patient. So first of all, we looked for the volume status by using the stroke volume variation. If this was too high, we gave volume. In the next step, we looked for the cardiac index. If this was too low, we gave positive inotropes, mainly dobutamine. And in the last step, we looked for the mean arterial pressure. If this was too low, we gave norepinephrine. If we achieved the goal, the algorithm was checked every 3 hours up to 12 hours. If not, we started from scratch. First of all, we looked for the performance of the biomarkers. And here you see that 72% of the patient with an elevated biomarker developed an acute kidney injury, in contrast to patient who had a low biomarker level. Here, only 21% of the patient developed an acute kidney injury. We calculated the negative and the positive predictive value. The negative predictive value was 79% and the positive predictive value was 72%. Here you see the measures during the intervention period. More patients in the intervention period received positive inotropes, mainly dopamine, 30% in the intervention group compared to 10% in the control group. The incidence of hyperglycemia was significantly lower in the intervention group compared to the control group, and less patients received ACE inhibitors and ARBs in the intervention group compared to the control group. We were able to demonstrate that the implementation of the KDIGO bundle in high-risk patients identified by biomarkers significantly reduced the occurrence of AKI after cardiac surgery. If you look for all AKI, this was significantly reduced from 72% to 55%. But if you only look for moderate and severe AKI, this was also significantly reduced from 45% to 30%. John Callum wrote a really nice editorial. He wrote, AKI, the myth of inevitability is finally shattered. Now that the evidence demonstrates that AKI can be prevented, it's our duty to find more ways to do it. Of course, you can criticize our study because it was a single center study and we focused on one specific patient population, patients after cardiac surgery. But at the same time, the Big PEG trial was published, which was performed by Ivan Gökce and colleagues, and they used exactly the same approach. They identified patients at high risk for AKI by using biomarkers. They also used TIM2 and IGF-BP7, but they haven't looked at cardiac surgery patients. They looked at 121 patients after major abdominal surgery. A patient who had an elevated biomarker level reflecting a high risk for AKI, they were randomized into a control group. They received the standard of care therapy, and in an intervention group here, the fluid administration was guided by the CVP, and a nephrologist was consulted. He or she was supposed to maintain the perfusion pressure and discontinue all nephrotoxic agent. The primary outcome was AKI within the first 7 days, and the authors demonstrated that the implementation of the modified KDIGO bundle significantly reduced the occurrence of AKI. This was also true for all AKI, but also for moderate and severe AKI. And this was associated with a significantly shorter length of ICU and hospital stay, as you can see here in the intervention group compared to the standard of care group. These are data from a quality initiative program led by Dan Engelman. He's a cardiac surgeon. So they did the same approach, but they didn't measure the biomarkers immediately after surgery. They measured the biomarkers on the first post-operative day, and they also combined this with the KDIGO bundle, as you can see here. Dan and colleagues demonstrated that in their patient cohort, 50% of all patients had a biomarker level equal to or higher than 0.3. And here you can see that if you combine the biomarker measurement with the KDIGO bundle, that this significantly reduced the occurrence of moderate and severe AKI also in their patient cohort. Now you can ask the question, why do you only want to implement the bundle in patients at high risk for AKI? Why not applying the bundle to everybody? And here, this observational trial from France gives you the answer. They investigated evaluating the compliance with a bundle of 13 ICU guidelines, and on the right side you see the different ICU guidelines. They included 625 patients, and they demonstrated that only 34% of all septic patients received the full sepsis bundle. Now you can argue, okay, implementing the sepsis bundle is quite difficult because it consists of different measures. But they also demonstrated that only 37% of all ventilated patients received a low tidal volume ventilation. And I think these data are really intriguing because they demonstrated that the compliance rate is quite high, above 70%, when you only have to implement 1 or 2 bundles in one patient. But if you have to implement more than 2 bundles in one patient, then the adherence rate goes down below 10%. When we published our Prevaki 1 trial, a lot of physicians told me that they apply the bundle to every patient. And I couldn't believe this because for us it was quite difficult to implement the bundle in the context of a randomized controlled trial. And that's the reason why we performed an observational study, and we included 100 patients, and we demonstrated that only 5.3% of all patients received the full bundle. And we combined this observational trial with an interventional trial. This was a Prevaki 2 trial. This was a feasibility trial. We wanted to investigate the compliance rate in the intervention group compared to the compliance rate in the control group. We included 278 patients in 12 centers across Europe, and we demonstrated that the compliance with the complete care bundle was only 65 in the intervention group versus 4% in the control group. But this was associated with a significantly lower rate of moderate and severe AKI in the intervention group compared to the control group. We wanted to know in the next step which measure is really important to prevent the development of AKI. And for this, we combined the Prevaki 1 database with the Prevaki 2 database and looked for this, and we identified that you have to avoid a hypotension and a low cardiac output to prevent the development of AKI, and you should avoid the use of nephrotoxic drugs. In addition to this, we also performed a small meta-analysis here. We looked whether urinary TIM2 and IGFBP guided implementation of the KDIGO bundle can prevent the development of acute kidney injury. We identified 4 studies, 3 in the OR, 1 in the emergency department, and we were able to demonstrate that biomarker-guided implementation of the KDIGO bundle couldn't reduce the overall AKI rate, but this approach significantly reduced the rate of moderate and severe AKI, as you can see here. So in summary, I can say AKI is a common problem in surgical and critically ill patients. The development of AKI increases hospital costs and mortality. Functional biomarkers have several limitations. Damaged biomarkers can detect a kidney damage without loss of function, and implementing the KDIGO bundle in high-risk patients might reduce the incidence of AKI in surgical patients. Thank you very much for your attention, and I'm happy to answer your questions. Thank you very much.
Thank you very much, Dr. Arbok. The questions will be taken during the JAMA session. That was a very lucid talk on use of biomarker-guided interventions to prevent acute kidney injury. And though it may not fully prevent kidney injury, at least try and reduce the number of cases developing moderate and severe AKI. Coming to our next talk, Dr. Marlies Osterman will be talking on RRT in ICU, when I stop it. She's a consultant in critical care and nephrology at Guy's and St. Thomas's Foundation Trust, London, and she's an honorary senior lecturer at King's College, London. Professor Osterman is an active member of the European Society of Critical Care and is deputy chair of the AKI working group. She's also actively involved in the Renal Association and the Intensive Care Society in UK and is a fellow of the Faculty of Intensive Care Medicine. Her clinical and research interests include acute kidney injury in the critically ill, including biomarkers and long-term complications, and all aspects related to acute kidney injury. Dr. Austin.
Good morning, good afternoon, good evening, wherever you are in the world. It's a great honor to contribute to this exciting meeting, and I would like to thank the organizers for inviting me. In the next 20 minutes, I will talk about renal replacement therapy and address the question, when to stop. These are my disclosures. They have not influenced this presentation. Renal replacement therapy is an integral component of modern critical care. It has many advantages and benefits and helps us controlling electrolyte disorders, metabolic acidosis, and management of fluid overload. But it comes at a price. Renal replacement therapy clearly has potential complications and adverse effects, ranging from complications related to line insertion to bleeding and the risk of hemodynamic instability. And for the clinical team at the bedside, renal replacement therapy represents a step up in complexity. It makes drug dosing challenging, it increases the workload of the nurses, and it also contributes to healthcare costs. So ideally, patients should have renal replacement therapy when they need it, but only for as long as absolutely necessary. The decision when to stop is closely linked to the decision when to start. And there are obviously many reasons for initiating renal replacement therapy. Renal replacement therapy may be triggered by severe acute kidney injury with fluid overload, hyperkalemia, and severe metabolic acidosis. When considering renal replacement therapy, it's also important to assess the impact of acute kidney injury on other organs, in particular heart and lungs. And renal replacement therapy may be triggered by significant non-renal dysfunction. The decision is also influenced by the potential risk of complications and the question whether patients could potentially tolerate these complications if they occurred. And lastly, the decision is influenced by non-clinical factors, including availability of staff, availability of kit, and then clearly the overall goals of therapy. These are the factors that may trigger the decision to start, but they also influence the decision when to stop. In practice, renal replacement therapy is stopped for several reasons. Sometimes it's stopped because kidney function has truly recovered. It may also be stopped because of a change in overall goals of therapy and goals of care. And sometimes renal replacement therapy is stopped in an unplanned manner because the filter clots or the patient has to go to the operating room. And in these situations, clinicians may adopt a wait and see approach and await renal recovery. Ideally, we would like to discontinue renal replacement therapy when renal recovery has occurred. But that's sometimes difficult to judge because we don't have good, reliable markers of renal recovery. Essentially, we depend on urine output and serum creatinine. Serum creatinine obviously is only useful if we see a trend in patients in whom the renal replacement therapy dose has not changed. Many researchers and clinicians are waiting for new biomarkers of renal recovery, but at present, new novel biomarkers of renal recovery have not been integrated into clinical practice. So we are relying on our traditional markers, in particular urine output and, if necessary, creatinine. Professor Wang and colleagues explored the existing literature to identify predictors of successful discontinuation from renal replacement therapy. Now, successful discontinuation means that renal replacement therapy was stopped and did not have to be started again. And in this meta-analysis, they identified 10 studies. As shown here, they are all case control studies. And importantly, they looked at different patient populations and also used different timeframes to define success, from 7 days up to 30 days. In 9 out of these 10 studies, urine output was identified as a predictor of successful weaning. And as clearly shown here, patients who successfully discontinued renal replacement therapy had a larger urine output compared to patients in whom renal replacement therapy had to be started again. But there was quite a lot of variation between the different studies. And studies also varied in the use of diuretics and the use of other measures to support urine output. In this meta-analysis, led by Professor Bagshaw and colleagues, they tried to determine parameters indicating optimal timing for liberation from renal replacement therapy. They identified 23 articles and identified these various different parameters that were used to describe and define optimal timing. They range from creatinine to creatinine clearance, urine output, but also 24-hour urine creatinine concentration and urine urea concentration. And in some studies, new biomarkers had been used. 10 of these 23 studies identified urine output as a trigger to predict successful discontinuation. As you can see here, these 10 studies identified different cutoff values for urine output and described them differently, from mils per kilo per hour to an absolute urine volume in 24 hours to an increase in urine output from the day before, as demonstrated here in this study by Katayama and colleagues. So different urine output criteria and cutoff values have been described, but there is a lot of inconsistency and heterogeneity between these studies. And based on the existing literature, it is difficult at the moment to recommend a particular urine output trigger for clinical practice. Professor Gibney and colleagues addressed this question in an editorial. And using the existing information from the literature, they provided some guidance for clinical practice. And they proposed and encouraged clinicians to ask themselves the question, can this patient be safely weaned from RRT on every ward round? And they suggested that clinicians should ask the question, has the original precipitant for acute kidney injury resolved? Knowing that kidneys may recover once the major precipitating condition has improved. As a second question, they proposed that clinicians should ask whether there was evidence of some degree of recovery of renal function in the form of either urine output increase or fall in serum creatinine in those where the renal replacement therapy dose had not changed. And then lastly, clearly it's important to ask whether any fluid overload has resolved. And if the question is yes to all, if the answer is yes to all three questions, then a break or stop of renal replacement therapy could be considered. A similar approach was taken by Professor Mendu and colleagues, but they went further and integrated these questions into an algorithm. Using a urine output volume of 500 as their cutoff, they suggested that clinicians should ask themselves on every ward round whether patients were passing more or less than 500 mL of urine. And if the patient was passing less than 500 mL of urine, then they would suggest that renal replacement therapy was likely to be needed for longer. However, in patients with a urine output of more than 500 mL, it was reasonable to consider the discontinuation of renal replacement therapy. Now, they acknowledged that urine output alone was not sufficient to make the final decision, and therefore it was obviously possible that patients in whom renal replacement therapy was potentially advised to stop may need renal replacement therapy for longer because the patient may still be fluid overloaded or may still have electrolyte abnormalities or hyperkalemia necessitating discontinuation. Similarly, in patients with a urine output of less than 500 mL, it may be reasonable to stop for reasons related to futility or changes in goal of therapy. As part of this quality improvement project, they suggested to use this form of algorithm on a daily basis. And in subsequent analysis, they showed that adherence to this algorithm meant that mortality was 42%. And this is interesting because for patients where clinicians did not use this algorithm, mortality was significantly higher. In this case, 63%. They concluded that this structured, formalized approach to renal replacement therapy was beneficial for patient outcomes, but also beneficial for overall care. The next question is whether new biomarkers have a role in deciding whether to stop renal replacement therapy. This was a question approached by Professor Yang and colleagues. And they collected urine and serum samples one day after the last session of renal replacement therapy to analyze and identify predictive biomarkers. And as shown here, serum cystatin C and again urine output were independently associated with successful discontinuation. But clearly, as I've already said, these markers were taken the day after the event, so the day after renal replacement therapy had already been discontinued. So it's less useful for clinicians at the bedside contemplating discontinuation. Professor Kim and colleagues took a similar approach and also looked at biomarkers. Looked at the role of biomarkers to predict successful weaning. And in this study, 950 patients were initially screened, of whom 112 patients were enrolled. And of these 112 patients, 89 patients successfully discontinued renal replacement therapy, whereas 21 patients had to be started again. And when they looked at biomarkers at time of cessation of renal replacement therapy, in particular cystatin C, NGAL, and urine output, there was a lot of overlap between patients who had successfully discontinued and patients in whom renal replacement therapy had to be started again. But there was a significant difference in the mean values of cystatin C. And so the investigators suggested that serum cystatin C may potentially have a role in predicting successful discontinuation. But as I already mentioned, and as you can see, there is a lot of overlap between the successful patients and patients in whom it was started again. And with that in mind, it's no surprise that this expert committee looking at biomarkers concluded that the existing evidence at the moment did not support the use of any individual biomarkers for predicting successful cessation of renal replacement therapy. What about other means? The question is whether furosemide could help us identifying those in whom renal replacement therapy could be stopped. This question was addressed in a randomized controlled trial, which is now more than 10 years old. And the investigators enrolled 71 patients who were on renal replacement therapy and were then randomized to either furosemide infusion versus placebo. And the furosemide infusion was continued until the measured creatinine clearance was more than 30 mL per minute. 36 patients were randomized to furosemide infusion. And as you can see here, of these 36 patients, 9 patients developed full renal recovery, but 13 patients had to be restarted on CRRT after it was stopped. 35 patients were randomized to placebo, and of these 35 patients, 17 recovered kidney function, and only 7 patients had to be restarted on CRRT. And so the authors concluded that furosemide by continuous infusion did increase the urine volumes and sodium excretion, but it did not lead to a shorter duration of renal failure, and it did not result in more frequent renal recovery. And it certainly did not reduce the risk of restarting renal replacement therapy. So in conclusion, discontinuation of renal replacement therapy is an important component of the management of renal replacement therapy. And it should, the chances of stopping renal replacement therapy should be evaluated on a daily basis. At present, we do not have any reliable markers of renal recovery. So the decision is really left to the assessment, or the decision should be based on the assessment of traditional renal markers, a clinical assessment, and potential trajectories. We're hoping that novel biomarkers will help us in future, but at the moment, they still remain under research and investigation. Thank you very much for your attention. It has been an honor to contribute.
Thank you, Dr. Osterman. That was really a very, very lucid talk. We'll move on to the last talk in this session. We're running a little bit behind schedule. Our next speaker is Professor Jacques Duranto. He's going to talk to us on what's best for the kidney, norepinephrine or vasopressin. Professor Duranto is a professor in anesthesiology and intensive care. He's head of the neurosurgical and surgical intensive care unit in Paris. His research focuses on assessment of tissue perfusion and oxygenation in critically ill, management of trauma and brain injured patients. In his laboratory, he has developed animal models of trauma and brain injury, hemorrhagic and septic shock with powerful means for analyzing tissue oxygenation. Professor Durant.
A great pleasure to be with you to talk about vasopressor and kidney. And so what is the best for the kidney? Is it norepinephrine or is it vasopressin? So we know that it's important for the kidney to avoid tissue hypoperfusion and to maintain glomerular filtration. So it's important to maintain blood pressure and stroke volume to prevent acute kidney injury. And we have to do this in an individualized approach. For example, to take in account the fact that we deal with an hypertensive patient. And so are vasopressor useful in this strategy, and which vasopressor are useful in this strategy? So are vasopressor useful for preserving kidney function? In this study, it's a study performed in a high-risk patient undergoing major surgery. And in this study, it has been clearly demonstrated that the use of norepinephrine to target blood pressure was beneficial to decrease post-operative acute kidney injury. So in this study, there is an individualized treatment group where systolic blood pressure was targeted to maintain systolic blood pressure within 10% of the reference value using a continuous infusion of norepinephrine. They also optimize stroke volume by a successive free challenge. And the primary outcome was a composite of systemic inflammatory response syndrome and at least one organ system dysfunction. What they observe that in the individualized treatment group, they observe a decrease in acute kidney injury at day 7. It was 33% versus 49% in the standard treatment group. So clearly a beneficial effect of continuous infusion of norepinephrine to maintain systolic blood pressure, a beneficial effect to prevent acute kidney injury. So we know that norepinephrine and vasopressin have different effects at the kidney microcirculation. Norepinephrine induces vasoconstriction at the preglomerular arteriole with an improvement of blood flow in renal cortex and medulla. But there is a debate on the dose-dependent distribution between the cortex and the medulla. And vasopressin induces a preferential vasoconstriction of the postglomerular arteriole, inducing an increase in glomerular filtration. So, which vasoconstriction is the best for kidney? I want to show you two experimental studies. The first one that we perform in rat rats, we induce an hemorrhagic shock. It was a pressure control hemorrhage in these animals. And we test resuscitation with fluid alone, or fluid plus norepinephrine, or fluid plus arginine vasopressin. What we observe for the same mean arterial pressure, we observe a similar recovery of aortic blood flow when we use norepinephrine or when we use arginine vasopressin, with a similar decrease in lactate. So we test the effect of these two vasopressors at the level of the kidney by using contrast-enhanced ultrasonography to explore microcirculation. What we observe that during resuscitation and after transfusion, when we use norepinephrine and when we use arginine vasopressin, we observe a similar recovery of microcirculation at the cortex and at the medulla level. So norepinephrine and vasopressin have similar effect at the renal, the cortex or the medulla. And there is no difference between the two vasopressors in terms of recovery of kidney microcirculation in this model of hemorrhagic shock. The second model is it's a septic model in sheep, where they give E. coli obtained from septic patient to induce a septic acute kidney injury. And so they perfused E. coli during 24 hours, and after they give vasopressin or norepinephrine. What they observe that at 24 hours, they observe they induce a decrease in mean arterial pressure with a decrease in stroke volume, with an increase in blood lactate. And at the level of the kidney, they observe an increase in renal blood flow. When they compare arginine vasopressin to norepinephrine, they observe that with norepinephrine, they observe that norepinephrine induce a decrease in medullary tissue perfusion in comparison to arginine vasopressin, and with a decrease in medullary tissue PO2 in comparison to arginine vasopressin. So a deleterious effect of norepinephrine in terms of perfusion and in terms of PO2 at the medullary level. In terms of kidney function, norepinephrine once again induce a decrease in creatinine clearance in comparison to arginine vasopressin, with a decrease in fractional sodium expression with norepinephrine. So in this model of ovine septic acute kidney injury, restoration of mean arterial pressure with vasopressin induce a more sustained improvement in renal function than norepinephrine without exacerbating renal medullary ischemia and hypoxia. In human, this first study where they compare vasopressin versus norepinephrine infusion in a patient with septic shock, the VAST study. It's a multicenter randomized double-blind trial. So they include patient receiving a minimum of 5 micrograms of norepinephrine per minute and they use low dose of vasopressin, 0.01 to 0.03 unit per minute. The primary goal was mortality. They observed no difference in mortality with vasopressin. And vasopressin, when they use vasopressin, they was able to decrease the rate of norepinephrine, but without effect on mortality. And when they compare two groups, a severe septic shock versus a less severe septic shock, they observe that in the less severe septic shock, so it was patient receiving 5 to 14 microgram of norepinephrine per minute, they observe in this group a decrease in mortality when they use vasopressin. So in the less severe patient, vasopressin was capable to decrease the mortality. So in a post-hoc analysis of this study, when they look at patient in the referral risk category, they observe a beneficial effect of vasopressin in terms of mortality, and a very interesting result, they observe that vasopressin was capable to limit the progression to renal failure or lost over the 28 days study period in comparison to norepinephrine. And they observed that vasopressin was also capable to decrease the rate of use of renal replacement therapy. In the other referral category, they observe no beneficial effect of the arginine vasopressin. The second study is the VANISH study. It's a study where they compare the effect of early administration of vasopressin versus norepinephrine on kidney failure in patients with septic shock. And they use vasopressin titrate up to 0.06 unit per minute. And the primary outcome was kidney failure 3 days during the 28 days period after randomization. They observed no difference between arginine vasopressin and norepinephrine, so no beneficial effect of vasopressin at 28 day, but they observe that serum creatinine level were lower and urine output slightly higher over the first 7 days in the vasopressin group compared with the norepinephrine. And also they observe with vasopressin a lower rate of renal replacement therapy in comparison to norepinephrine. The limit in this study is that the use of renal replacement therapy was not controlled in this trial. In this other study, so it's once again a comparison of vasopressin versus norepinephrine, but it's in patients with vasoplegic shock after cardiac surgery. And vasopressin was used at the rate of 0.1 to 0.06 unit per minute versus norepinephrine at a rate of 10 to 60 microgram per minute to maintain arterial pressure. And this study is very interesting because the primary endpoint was a composite of mortality or severe complication within 30 days. And what they observe that when they use vasopressin in this kind of shock, they observe a decrease in the primary outcome, so a decrease in this composite of mortality and severe complication, with a decrease in the number of acute kidney injury in the group of the vasopressin group. The decrease was very impressive because it was 35% in the norepinephrine group versus 10% in the vasopressin group. The strength of this study, in my point of view, is that this effect was mainly on AKIN 2 and 3. The more severe acute kidney injury, with a nice decrease in the rate of renal replacement therapy in the vasopressin group. So very impressive result. In addition, they observed that vasopressin was capable to decrease the number of atrial fibrillation, whereas also the vasopressin group, they observe a decrease in the length of ICU stay and the length of hospital stay. And they observe no deleterious effect of vasopressin, so no additional digital ischemia, no additional mesenteric ischemia or hyponatremia, and no additional post-operative acute myocardial infarction. The same group test the effect in a similar design, the effect of vasopressin versus norepinephrine as first-line vasopressor therapy in patients with cancer and with septic shock. And the primary outcome was all-cause mortality at 28 days. And they observed no beneficial effect of vasopressin in terms of mortality, but also in terms of acute kidney injury. It's interesting to see that in this study, it was very severe patient with a high rate of mortality. And it's also important to see that in the vasopressin group, there is a very important number of patients who need norepinephrine use as open label. So in my point of view, very severe patient needed very high rate of vasopressor. And when we look at the, for example, the rate of norepinephrine in this study, you can see that after, for example, 7 days after randomization, the patient receive a very important rate of norepinephrine. So there is no decrease in the rate of norepinephrine in this patient. So a very severe patient with a high mortality and needed during 7 days rate of norepinephrine. So the question is in this study, to know if there is the sepsis was controlled in this patient. So if the patient was so severe with an absence of control of sepsis with a high mortality, maybe these patients were too severe to see a beneficial effect of vasopressin. So I don't know if it's the good way to see the study, but I think it's important to highlight this point. And for me, it's really a question, and I am not sure that this study was capable to show a beneficial effect of vasopressin because the patient was too severe with an uncontrolled sepsis. So in conclusion, early administration of vasopressor must be used to maintain arterial pressure and renal pressure, renal perfusion, in addition to optimization of stroke volume. Vasopressin may be preferable to norepinephrine as a first-line vasopressor agent in the management of vasopressic shock after cardiac surgery. And in septic or hemorrhagic shock, the potential benefit of vasopressin on renal function should continue to be tested. Thanks a lot, and it was a pleasure to have this presentation with you.
Thank you, Professor Duranto. We will conclude this session here and move on to the next session. I would like to invite Dr. Jignesh Shah, moderator for this session. Okay. Dr. Jignesh Shah works at the Bharati Vidyapit Deemed University Medical College and Hospital. He's a gold medalist for standing first in MD anesthesiology exams in University, ICCM, and Meher Chand Makni Devi Memorial Trust Award for standing first in IDCCM. Dr. Vijay Lakshmi Award winner for the best outgoing diploma candidate, that's for IDCCM, and few other awards. I won't go into that. So he will take up the next session. Thank you.
Now we welcome you all to this session on hemodynamic monitoring. We have 3 lectures in the series. Without taking much time, I'll introduce the speaker, Professor Bernhard Saugel. He's a professor in anesthesiology from Hamburg, Germany. He's got a lot of publications, more than 190 original research publications, and he's served as an editor in cardiovascular section for Journal of Clinical Monitoring and Journal of Critical Care. His main research areas are hemodynamic management of high-risk patients, and he focuses on personalized hemodynamic management. He's going to get us through the topic of perioperative hemodynamic monitoring and management. Over to you, Professor Saugel.
I'm working in the Center of Anesthesiology and Intensive Care Medicine at the University Medical Center in Hamburg, Germany. Of course, I would have preferred to travel to your beautiful country and to join you in person during the Congress, but it is also a pleasure and honor to contribute to your Congress virtually with the talk on perioperative blood pressure management. These are my conflicts of interest. So first of all, why is blood pressure important? Systolic blood pressure is determined by left ventricular stroke volume, vascular compliance, and backward reflected waves, and it reflects the left ventricular wall tension and therefore is a measure of left ventricular afterload. Diastolic blood pressure is mainly determined by systemic vascular resistance, and it is the pressure that the left ventricle must overcome to start ejecting blood into the aorta. And finally, mean arterial pressure is the average pressure over the cardiac cycle, and it is the inflow pressure for most organ systems. You will probably all agree that low blood pressure during surgery is common and can have several causes. So hypotension during or after surgery can be caused by vasodilation due to anesthetic drugs, intravascular hypovolemia because of bleeding, low cardiac output in patients with bradycardia or low stroke volume, can be caused by mechanical ventilation, causing high introthoracic pressure, or there can be other causes, including an impairment of the sympathetic nervous system or impairment of baroreflex regulation. So hypotension during and after surgery are common, and a reasonable question then is intraoperative hypotension important? What is the link between intraoperative hypotension and postoperative outcome? There are now numerous registry analysis, retrospective database studies showing that low blood pressure during surgery is associated with postoperative organ injury, specifically acute myocardial and acute kidney injury. I will only show you two of those retrospective registry analysis, and the first one is this one in more than 360,000 non-cardiac surgery patients, and I show it to you because the authors used 4 different measures to quantify the amount of intraoperative hypotension. The authors used the absolute maximum decrease in millimeters of mercury below specific mean arterial pressure thresholds, the total duration of hypotensive episodes in minutes, the total area under blood pressure thresholds, this is the sum of the orange-colored areas in the figure, and the time-weighted average mean arterial pressure. This is the area under blood pressure thresholds divided by the total duration of surgery. The primary endpoint was major adverse cardiac or cerebrovascular events. So it was a composite of all-cause mortality, acute myocardial infarction, or acute ischemic stroke. Low blood pressure during surgery was associated with an increased odds ratio for the primary outcome. And this was true for the absolute maximum decline below blood pressure thresholds of 55, 65, and 75, but also for time-weighted average mean arterial pressure below those 3 thresholds, the area under the thresholds, and the absolute cumulative time below the thresholds. Low blood pressure during surgery was also associated with an increased odds ratio for a number of secondary outcomes, and this included acute kidney injury and need for renal replacement therapy, delirium, 90-day mortality, and sepsis or systemic inflammation. The second retrospective registry study I want to show you is this one in more than 23,000 non-cardiac surgery patients. And I show it to you because it asks an interesting question. What is the population risk threshold for acute kidney and acute myocardial injury? As you can see, the probability of postoperative myocardial injury and acute kidney injury increased when the lowest mean arterial pressure for a cumulative 5 minutes was below 60 to 65. So at this point, it is reasonable to say that there is evidence from registry analysis that the intraoperative population harm threshold for organ injury is 60 to 70 millimeters of mercury for mean arterial pressure, and that we suggest that we keep mean arterial pressure above 65. Unfortunately, the perioperative blood pressure story is a little bit more complex. and it is more complex because, of course, intraoperative hypotension is important, but we also need to consider the patient's baseline risk. This is a retrospective study in more than 138,000 non-cardiac surgery patients that looked at preoperative baseline risk and the association between hypotension and postoperative acute kidney injury. The authors categorized patients according to risk quartiles in low risk, medium risk, high risk, and the highest risk patients. And as you can see, there is a relation between low blood pressure on the x-axis and the incidence of postoperative acute kidney injury on the y-axis. But this relation was only clinically important in the group of the highest risk patients. Something similar has also been shown in the study that I showed you before, the study on the absolute population risk thresholds. If you look at the paper and read the discussion, you will find this statement that adding blood pressure into the multivariable logistic regression models containing all baseline variables did not increase the discriminative ability of the models for myocardial or acute kidney injury. Or to put it differently, baseline risk is far more important than intraoperative blood pressure. But of course, we should keep blood pressure in focus because blood pressure is a modifiable risk factor and thus it's amendable to intervention. Blood pressure management in the perioperative setting is also complex because hypotension is not only a problem during surgery. We showed that there are different phases of intraoperative hypotension, namely post-induction hypotension after the induction of general anesthesia, early intraoperative hypotension, and late intraoperative hypotension. And this means that there is intraoperative hypotension even before surgery starts, and that there are different causes for intraoperative hypotension during different surgical phases. The colleagues from Cleveland looked at this problem in more detail, and they looked at the association of hypotension during non-cardiac surgery before and after skin incision in more than 40,000 non-cardiac surgery patients. And interestingly, about 1/3 of hypotension occurred before surgical incision, meaning that this hypotension occurred before, even before the surgeons entered the room, and this proportion of hypotension is only caused by anesthetic management during induction of general anesthesia. This hypotension after induction of general anesthesia and before surgical incision is also associated with postoperative acute kidney injury, and that seems natural because the kidneys do not care when hypotension occurs. Hypotension also is a problem after surgery on normal wards. And this has been nicely shown in this sub-study of the POISE-2 trial. And hypotension, defined as a systolic blood pressure of less than 90 millimeters of mercury requiring treatment, occurred in almost 35% of patients during surgery, in more than 30% of the patients on the remaining day of surgery, but after surgery. And it occurred also in almost 8% of patients on postoperative days 1, 2, 3, and 4. Interestingly, postoperative hypotension seems to be important with regard to the risk of myocardial injury and death. So what you can see here on the x-axis are the episodes of hypotension, and on the y-axis there is the odds ratio for myocardial injury and myocardial infarction and death. And as you can see here, there's the odds ratio for 10 or 30 minutes of intraoperative hypotension, 10 or 30 minutes of hypotension on the remaining day of surgery. And this is the odds ratio for any hypotension on postoperative days 1, 2, 4. So postoperative hypotension seems to be important, but the harm thresholds remain largely unknown. The harm thresholds are probably higher than intraoperative harm thresholds. The next important question is about targeted blood pressure management. Targeted blood pressure management is interesting because we need to know whether there is a causal relation between blood pressure and postoperative outcomes. And of course, we need to know what is the optimal blood pressure for the individual patient. There is one randomized controlled trial in more than 450 patients that was published just a couple of days ago. And the objective of the trial was to determine whether targeting higher intraoperative mean arterial pressures reduces the incidence of postoperative major adverse cardiovascular events. So adult patients at cardiovascular risk having major non-cardiac surgery were randomized to targeted blood pressure management with a mean arterial pressure target of 75 or higher, or to targeted blood pressure management with a mean arterial pressure target of 60 or higher. The primary endpoint was a composite endpoint of acute myocardial injury during the first 3 postoperative days and 30-day major adverse cardiovascular events and or acute kidney injury. Targeted blood pressure measurement with a higher blood pressure target reduced the amount of hypotension to a clinically meaningful degree. So there was less cumulative time with mean arterial pressure below 75 or 65 in the group with a higher blood pressure target. But there was no statistically significant difference in the composite primary outcome, and there was no statistically significant difference in the single components of the primary outcome, acute myocardial injury during the first 3 postoperative days and 30-day mean major adverse cardiovascular events, or AKI, between the groups. So the authors concluded that their findings do not support universally targeting higher intraoperative blood pressures to reduce postoperative complications. And they state that although they were able to reduce hypotension to a clinically meaningful degree, there was not a significant decrease in acute myocardial injury or 30-day major adverse cardiovascular events, or AKI, when they targeted higher blood pressures. One question that the study leaves open is very important in my personal point of view. So I think that a key development could be to move away from population-based thresholds to individualized definitions of hypotension, and this could open the door to personalized perioperative blood pressure management. From a physiological perspective, of course, blood flow autoregulation depends on individual normal blood pressure, meaning that in patients with chronic arterial hypertension, the blood pressure autoregulation, the blood flow autoregulation curve is shifted to the right towards higher blood pressures. And this is something that can be important when we consider that each individual patient should have his or her each individual blood pressure target during surgery. We looked at the relation between ambulatory blood pressure and intraoperative blood pressure in a prospective observational study in 370 patients having elective non-cardiac surgery with general anesthesia. So we performed ambulatory blood pressure management a couple of days before surgery, and were then able to look at personal blood pressure profiles and compare blood pressure before surgery to intraoperative blood pressures. So what we compared was the lowest nighttime mean arterial pressure, and we compared it to the population harm threshold of 65. Why did we choose to look at the lowest nighttime mean arterial pressure? Well, we assumed that the lowest nighttime mean arterial pressure to some degree reflects the individual safe threshold, and we aim to compare this individual safe threshold to the population harm threshold of 65. If you have a look at the histogram of the differences, you can easily see that the differences between the lowest nighttime mean arterial pressure and a blood pressure of 65 varied considerably among individuals, meaning that about 1/3 of the patients had blood pressures during night that were lower than 65, but 2/3 of the patients had lowest nighttime pressures that were well above 65. So we concluded from that the population harm threshold of 65 is not the individual safe threshold. Of course, there are differences between physiologic sleep and general anesthesia, but still we found that in 1/3 of the patients, the lowest nighttime mean arterial pressure was below 65. Those patients can presumably tolerate intraoperative pressures of less than 65, but that is not the main point. I think it's more important that 2/3 of the patients had lowest nighttime mean arterial pressures that were well above 65, and these patients may need higher intraoperative pressures. We have one randomized control trials on individualizing perioperative blood pressure management based on preoperative values. It's a relatively small randomized control trial in close to 300 patients. It's the IMPRESS study that was published in JAMA in 2017. The objective was to evaluate whether individualized perioperative blood pressure management tailored to individual blood pressure physiology can reduce postoperative organ dysfunction, and the intervention, individualized blood pressure management, aimed to maintain systolic blood pressure within 10% of the preoperative reference value, and that was the patient's resting systolic blood pressure. This personal baseline value was assessed with a single measurement, and this is a limitation, with a single measurement during preoperative anesthesiology consultation, or if that was not possible, it was recorded by a nurse on the surgical ward just the day before surgery. Another limitation is that patients in the individualized group and in the routine management group were treated with 2 different vasopressors. In the individualized group, blood pressure was maintained using continuous norepinephrine infusion, and in the routine management group, blood pressure was maintained using ephedrine boluses. The primary outcome was a composite of systemic inflammatory response syndrome and dysfunction of at least one major organ system within the first week after surgery. And if we have a look at the median blood pressure values during surgery, we see that median blood pressures were higher in the individualized management group, but it would be much more interesting to have data on areas under thresholds or time-weighted averages during surgery. Nevertheless, the effect of individualized blood pressure management was impressive. So the primary composite outcome occurred in more than 50% of patients in the routine management group and in only 38% of patients in the individualized management group. So that the authors concluded that in patients mainly having abdominal surgery, management, individualized blood pressure management based on the preoperative systolic blood pressure value compared with routine blood pressure management reduced the risk of postoperative organ dysfunction. If that is true, and if we should use individualized blood pressure management based on preoperative values, then the next important question, of course, is how should we assess baseline pressures? How should we assess baseline blood pressure profiles before surgery? And I would like to come back to the study that I showed you before, our study where we had ambulatory blood pressure values and compared it to intraoperative blood pressure values. What this allowed us to do was we also compared mean arterial pressure measured shortly before the induction of general anesthesia to ambulatory mean daytime mean arterial pressure. And we did that because, as you know, many anesthesiologists use the mean arterial pressure that is measured just before induction of general anesthesia to get an idea about the normal blood pressure values a patient may have. So we wanted to test whether this pre-induction baseline mean arterial pressure is a good surrogate for normal daytime mean arterial pressure. And if we have a look at the correlation analysis and Blond-Ortman analysis, we can easily see that the pre-induction mean arterial pressure, the mean arterial pressure that is measured just before the induction of general anesthesia, is by no means a good surrogate for normal daytime mean arterial pressure and should not be used to get an idea about a patient's normal blood pressure. This is also reflected in a consensus statement that was published in 2019, and there it reads that ambulatory arterial blood pressure measurements are probably the optimal method to establish preoperative baseline values. So there are some crucial open research questions in the area of perioperative blood pressure management. Still, the most important open question is, does targeted blood pressure management actually affect postoperative outcome? Then the next question is, what is the optimal blood pressure target for the individual patient? I'm quite sure that the optimal individual target is by no means the population harm threshold of 65. What therapeutic interventions should be used to treat intraoperative hypotension causally? So should we consider that there are different causes of intraoperative hypotension? And finally, what is the impact of those therapeutic interventions on autoregulation and microcirculation? So to summarize, there is now enough evidence to say that intraoperative and postoperative hypotension are common and associated with postoperative organ injury. The intraoperative population harm threshold is around 60 to 70 millimeters of mercury for mean arterial pressure. The population harm threshold is probably not the individual safe threshold. With regards to acute kidney and myocardial injury, we need to acknowledge that they are more strongly associated with baseline patient risk than with intraoperative blood pressures. But of course, we should absolutely try to avoid hypotension because hypotension is modifiable. We still don't really know whether there is a causal relation between hypotension and postoperative outcomes. And at the moment, we have one small randomized controlled trial that suggests that individualizing blood pressure management can reduce the incidence of postoperative organ dysfunction and complications. There are two large ongoing randomized controlled trials, and those trials will provide robust evidence whether targeted blood pressure management can actually improve postoperative outcomes and whether there is a causal relation between intraoperative blood pressures and postoperative organ function. Thank you very much for your attention.
Thank you, Professor Sogel, for highlighting the issue of intraoperative and perioperative hemodynamic management and opening up the questions related to how to individualize the targets. So we are going to go to the next talk. The next talk we have in this series of hemodynamic thematic is permissive hypotension in shock by Professor Jan Becker. For all the questions, we request you to type the questions on the chat box. All the questions will be taken up at the end, at the JAMA session. So the next speaker is, as I said, Professor Jan Becker is going to talk to us on permissive hypotension, the concept of permissive hypotension in patients with shock. He's a professor of medicine and vice chair of the Department of Intensive Care Medicine at Erasmus Medical Center, Rotterdam, Netherlands. His research interests include blood lactates, ethics, end-of-life care. Specialties are very broad, but primarily they are hemodynamics, end-of-life, and also issues related to cost management and quality of care. He is a scientific advisor for the ICM conference, and his key areas of interest are tissue oxygenation, hemodynamics, lactate levels, ethics, and end-of-life care. Over to you, Professor Becker.
Thank you very much for inviting me to present on this very nice symposium that gives you the highlights of the recent Brussels symposium. What I'm going to talk about is vasopressor therapy, and in that respect, permissive hypotension. I have no disclosures for this presentation. The interest in permissive hypotension, or even the interest in mean arterial pressure, is huge. And I recently had a discussion in the Journal of Critical Care where we discussed whether pressure is more important than perfusion, or perfusion is more important than pressure. And we had a few esteemed researchers in the field. Raul Gazmuri from the United States defended that pressure-guided, that perfusion-guided therapy is much better than pressure-guided. Then we had a pro-con debate on is there a minimal mean arterial pressure? It's all septic shock. And then Raul Gazmuri said, no, there is no minimal pressure as long as you have, of course, perfusion. Jean-Louis Teboul and Daniel de Backer said, yes, there is an absolute minimal pressure around 45 diastolic mean arterial pressure. 45 diastolic and 60 to 65 mean arterial pressure. And Jean-Louis Vincent and Glenn Ananda said, well, that's context dependent. And so I encourage you to read this very interesting pro-con debate. And basically the conclusion was, after you have set your mean arterial pressure as 65 with some fluids and vasopressors, then you have to individualize it. And some patients do well with much lower, patients may even need higher, but it's important to individualize, where 60, 65 is more a starting point than an end point. There are two elements when you think about permissive hypotension. In the consensus on circulatory shock and the hemodynamic monitoring, a task force from the European Society, we defined shock as a life-threatening generalized form of acute circulatory failure associated with inadequate oxygen utilization by the cells. As a result, there is dysoxia associated with increased blood lactate levels. So, refractory tissue oxygenation is thus a key element of refractory shock. Because if you're talking about refractory and your definition is tissue oxygenation, then that's the key element, tissue oxygenation. So we are talking about a failure of markers of tissue hypoxia to be corrected. What are the markers of tissue hypoxia? Well, traditionally we use lactate. From the beginning of intensive care, Max Hariwal already said, well, you cannot have shock, real shock, if you don't have lactate. And lactate is the key element to guide you to the opinion that there is tissue hypoxia. So that's lactate. And, well, that's it. That's the huge problem in clinical practice. We only have lactate. We have nothing, let's say, really fast at the bedside that will tell you that there is tissue hypoxia. We use lactate for that. And it stems from experiments like this, the ones that I did when I was in Brussels doing my PhD, when you decrease oxygen delivery by whatever means, blood flow, arterial oxygen content, so saturation, PaO2 or hemoglobin, by whatever means you decrease DO2, VO2, so oxygen consumption will stay rather stable. And so oxygen consumption, which here reflects oxygen demand, so oxygen consumption meets demand. But there is a point where if you further decrease DO2, oxygen consumption will start to decrease and lactate levels rapidly increase. And so this is, let's say, the laboratory element of tissue hypoxia, because if you do not consume the amount of oxygen you need, so oxygen demand here, you have by definition tissue hypoxia. And so that's how we use lactate because of these experiments. And even more interesting, the study by Haibo Zhang is when you induce low cardiac output with by tamponade, and you take away the tamponade, so you go like this by inducing tamponade, then when you go back, then when you go back, you get a reversal of the problem. And so first you go down and then you go up almost by the same, let's say, graph and line. And so you increase lactate, then you rapidly increase lactate in the shock state. You reverse lactate when you come out of the tamponade in an animal, and you're back at baseline when you have a completely normal cardiac output. If we look at tissue perfusion, then we have much more markers of tissue perfusion. So if we link, let's say, a decrease in tissue perfusion to the, let's say, start at some point of tissue hypoxia, then we could measure or follow tissue perfusion instead of only lactate. And that's much better because we have much more of them. Traditionally, and especially in the United States, they use mean arterial pressure. And please, as I always state, mean arterial pressure is not a marker of tissue perfusion. It may not even be relevant for tissue perfusion. So please go away. I don't care. I'm interested in tissue perfusion at a minimal mean arterial pressure and whatever that may be. And that's relevant because if you look at hypotension, so isolated hypotension in sepsis patients, and you look at patients with only hyperlactatemia, then there is an almost doubling of the mortality. So hypotension is not without mortality. It's still 12% mortality. But if you only have lactate, that's even worse. So lactate is a much more, let's say, important marker of something is wrong than the blood pressure in and of itself. And the problem is, of course, I mean, who sees patients in shock without a low mean arterial pressure? That's very early on, for instance, in hemorrhagic shock. You can have this adrenergic response, you can have an increase in blood pressure, but ultimately, these patients will always present with a low mean arterial pressure. So it's very connected. And if the mean arterial pressure doesn't increase while you want it to increase, that's very bad. If you think the patient needs a higher blood pressure and nothing happens when you increase norepinephrine, that's not a good sign. That's a very high mortality. And if mean arterial pressure decreases very rapidly, well, call the troops. If blood pressure drops like crazy, these patients are usually in rapid cardiac arrest. And so the connection between mean arterial pressure and bad things is very strong. The main problem is in normal physiology, we do not manipulate mean arterial pressure to regulate tissue perfusion. We never increase our mean arterial pressure to get more perfusion. From the early studies on, where they thought that if you correct hypotension, you would improve patient outcome, already Cohn in '64 found that, yeah, that's probably not the case. That's what they did in cardiogenic, in shock states. They gave these very strong alpha agonists to, let's say, increase the mean arterial pressure at the expense of a low cardiac output. And he found when you decrease the vasopressors and give fluids, these patients would have a much higher cardiac output and did much better with only 500 ml of, in this case, a colloid. Max Ariwal already said, the godfather of lactate, said that basic mechanisms underlying all forms of circulatory shock is perfusion, inadequate tissue perfusion, decreased delivery of oxygen into the capillaries. That's the main problem. Not as much as the blood pressure, but more the inadequate tissue perfusion. And if you look at the physiology of the microcirculation, that makes sense, because if you look at these two things, this is a patient where there is, for instance, a bleeding. You have an increase in mean arterial pressure. This is the drop over the circulation. This is the beginning of the microcirculation. In these cases, this mean arterial pressure results, due to the vasoconstriction, in a very low entry pressure into the microcirculation. And that's why these patients are cold and clammy and have this purple and mottled skin. If you drop the blood pressure due to hypotension, due to vasodilation, instead of having this low entry pressure, you basically increase your entry pressure to the microcirculation. And so basically arterial vasodilation is a beneficial state for microcirculatory perfusion. The caveat is if we start giving fluids and we increase the venous pressure, the beneficial effect of the vasodilation is limited because we increase the post-capillary pressure, limiting perfusion pressure over the microcirculation. And so hypotension in and of itself is probably good for your tissue perfusion, unless it's of course extremely low. Now, the pressure-flow relationship is not the same everywhere. And of course, that's the big caveat. We know that the kidney has limited potential to adapt to changes in arterial pressure. And that's why I always advocate, if you have kidney failure, and most easily seen by a decrease in urine production or even no urine production at all, and you're at a given arterial pressure, then challenge the system. Get this patient to a higher blood pressure, and if he or she starts peeing, then you know that the kidney is in problems, given the limited potential to adapt to changes in arterial pressure, and then it makes sense to keep the patient at this higher blood pressure. I think if you look at all the data, the context of hypoperfusion is very important. If you want to use lactate levels as a marker of is my hypotension bad or not bad, then if you have hypoperfusion parameters in the context of lactate and in the context of mean arterial pressure, that's bad. This is the study we did already some time ago, where we looked at lactate with or without markers of hypoperfusion. And as you can appreciate, patients that had hypoperfusion and lactate needed much more norepinephrine, had more rescue therapies, had a higher mortality, which was not statistically significant, and stayed on the ventilator for more time, where the p-value was almost significant. So hypoperfusion context adding to lactate levels gives you a much better, let's say, assessment of whether you have a problem or not. And I think this holds for mean arterial pressure as well. Mean arterial pressure with indices of hypoperfusion, like SCVO2, delta PCO2, the capillary refill time, that's a bad sign. You should not accept a blood pressure like that. If you have this abnormal peripheral perfusion, so the absence of vasodilation, also your organs are at risk. A study done in Austria, where they looked at the resistance index of liver, kidney, intestine, and spleen. And on the x-axis is the capillary refill time. And so this is more vasoconstriction. This is an increased resistance index. And an increased resistance index is a decrease in perfusion. And so increasing vasoconstriction leads to decreasing perfusion in the liver, kidney, in the intestine, and in the spleen. And so a non-vasodilated state even if you have this target blood pressure of 65, is bad for organ perfusion. Refractory shock is a state in which parameters of tissue perfusion in patients with abnormal lactate levels and initial hypotension do not respond to treatment. So that's your refractory shock definition if you focus on tissue perfusion. So then you have two questions. Is my treatment goal adequate? Do I need this blood pressure? Do I need this amount of norepinephrine? And is my treatment adequate? So do I use the right agents? Do I use enough volume or too much volume? Do I use a very strong vasopressor that basically vasoconstricts much more than the patient needs? That's questions you have to ask yourself. And if you think the mean arterial pressure is inadequate, then please trust the system. We showed in the Andromeda study that we published in JAMA that this is very feasible. It's very feasible to increase the blood pressure to 80, 85, measure your parameters of perfusion, and assess whether the patient benefits from this higher mean arterial pressure. And remember, this is not only relevant for patients with prior hypertension, as Arnaldo Dubin showed already long ago. Patients with abnormal capillary perfusion at baseline, they benefit from an increase in blood pressure. And so don't limit your stress, let's say, blood pressure test to patients with hypertension only. So in conclusion, when you think about blood pressure, you have to think about tissue perfusion. And when tissue perfusion endpoints, markers are normal, and we suggested in this editorial central and mid-venous oxygenation, when you have normal lactate, when you have normal capillary refill time, when the patient pees, when you don't have skin mottling, if all these parameters are normal, then the blood pressure is not that relevant. And especially if the patient is awake and can show you whether there is abnormal brain perfusion, which of course limits the use of very low blood pressures, especially in elderly patients. So please use a holistic view and not only treat a number of mean arterial pressure, thinking that you will optimize the patient by that. And so in conclusion, blood pressure measurements always need to be put in context of a patient's overall status. And this can be as simple as observing that the patient's overall function is normal, or by obtaining measurements of blood flow and metabolic indicators. Refractory shock is a state where you cannot correct tissue oxygenation, and by lack of very specific parameters of tissue oxygenation, we use tissue perfusion. And so persistent abnormality of flow-sensitive parameters are associated with a worse outcome. So capillary refill time, SCVO2, delta PCO2, STO2, whatever you want to use, these markers are very closely linked to perfusion. And if you're not sure, stress the system. So response to DAY in space is not following the rules exactly as written. So you would, let's say, you could argue, well, not following surviving sepsis campaign, that's probably bad. But another reason to DAY in space is following the rules exactly as written. And so be flexible and individualize treatment. Thank you very much for your attention.
Thank you, Professor Backer, for this wonderful talk highlighting the importance of monitoring tissue perfusion and not following the numbers. And in the continuity, now we are going to look at how to try to personalize the hemodynamic targets. In the next talk, we have Professor Alexander Houston, who is an Associate Professor of Anesthesia and Intensive Care Medicine at Department of Anesthesiology in Paris, France. He has worked as a leading member of a research team on goal-directed therapy strategies and how to implement this concept. His other interests include non-invasive cardiac output monitoring, fluid therapy, and many other novel perioperative technologies. His current focus is on testing the impact of perioperative hemodynamic optimization using a closed-loop automated fluid management systems on post-operative outcome of patients undergoing high-risk surgery, and is going to talk to us on artificial intelligence used in managing vasoactive drug therapy. Over to Professor Zusman.
Hello, everyone. So my name is Alexander Justen. I'm an anesthesiologist originally from Belgium, Erasmus Hospital, but I work now in Paris. And I'm going to discuss the use of automated system for vasopressor administration. Of course, I have some conflicts of interest that I have to disclose. Most importantly, I have a ownership interest in a company that we founded with other colleagues in California. What we know is that hypertension, there are a lot of papers showing that intraoperative hypertension is bad for the patient because it increases the incidence of postoperative complications. And this is true also in the ICU. The topic today is so hot that a lot of journals did the cover with this topic of intraoperative hypertension and also with postoperative hypertension. What we know is that when we maintain blood pressure within a narrow range close to the patient baseline value, we observe a reduction in the incidence of organ dysfunction. And therefore, today, the anesthesia and ICU community prone this concept of personalized hemodynamic management. However, it seems that this link between hypertension and complication is causal because today we have two studies showing a link between a blood pressure value and the incidence of postoperative complication. In the first study, this multi-center study done in China, they took more than 600 elderly patients with chronic hypertension and they randomized them in three groups. Mean arterial pressure between 65 and 79, between 80 and 95, and between 96 and 110. The primary outcome was the incidence of postoperative acute kidney injury, and this was lower for the patient who had the mean arterial pressure between 80 and 95. So what's the current practice today? So we observe in critical ill patient and in surgical patient under continuous vasopressor infusion that they spend less than 50% with a mean arterial pressure between 60 and 80, more than 10% of the time with a mean arterial pressure below 60, and 40% of the time with a mean arterial pressure above 80. To me, it means that blood pressure management today is suboptimal and that we can maybe try to improve its titration. That's why we developed some automated system, or what we call closed loop system, which is a system where you have a controller or regulator, which is going to monitor one or multiple variables, and then will adjust one or multiple drugs using the feedback process. In fact, physiology is based on automated and feedback controls with the regulation of hormones in our body, and life with the cruise control, the air conditioning. We all know the self-driving car that we may have in the future. And in medicine, we have a lot of examples of automated drug administration for hypnosis control, nociception, hemodynamic control, temperature, and we all know this FDA-approved glucose control. What we know, this has been shown for hypnosis automated system, is that this kind of system, when compared to human management, will better maintain a given target within a narrow range and will decrease over and undershooting of a given target. This is not a novel idea, automated system for drug delivery. The first paper arrived around the mid-80s. And today we can see that since 2010, we have an exponential number of publications using automated system in medicine. For vasoactive drug administration, the first patent was in 1978, as you can see in this slide. And today we can say that at least 7 main research groups developed an automated system for vasopressor administration. So we developed our own automated system and we tested this system extensively in silico and then in vivo. Here in the lab in pigs, where you have the system, you have the ventilator, you have the pigs, and you have all the hemodynamic monitor. We induce hypertension using sodium nitroprusside. high dose, low dose, high dose, low dose for 2 hours. And you can see this is 7 peaks where we did nothing. So blood pressure went down. Then for 30 minutes, then a lower dose of sodium nitroprusside, higher dose, lower dose, and then we stop the protocol. And the 7 other peaks, we start the system, and then the automated system manage blood pressure to keep mean arterial pressure around 80. Then we tested this system in clinical practice, but today we had only 2 teams, one in Singapore, the other one in Hong Kong, who developed an automated system and tested this system in clinical practice, but they use it in low-risk patients, mainly women under C-section with spinal anesthesia, and they use a combination of ephedrine and phenylephrine to titrate the vasopressor. So we decided to move on to high-risk patients and to use norepinephrine as the drug. And we did a first pilot study where we tested this system in 20 patients, and we observed 2.6% of hypertension and 2.4% of hypertension. You can see in this picture the automated system here for vasopressor titration during a major vascular surgery. We set the target in the computer at 70, and you can see that the patient spends 0% of the case time with a mean arterial pressure below 65. In blue here, you have the mean arterial pressure, and here the infusion of norepinephrine over time. Then we also tested this system in a patient undergoing cardiac surgery. And once again, you can see the system here where you have the senior anesthesiology who teach some TE to the resident. Then in robotic cardiac surgery and even in on-pump cardiac surgery. Then we also tested this system using, continuous and non-invasive blood pressure monitoring, and we did it in renal transplant surgery. Then we move on to the ICU also, and here you have a head trauma patient under deep hypothermia with the system and the EEG monitoring. This is a patient who was awake and needed a surgery because she was septic. And during the first 2 hours, I asked the nurse to maintain mean arterial pressure above 65. Then I put the system for 2 hours. And then once again, the nurse had to manage the system. Then I wanted to continue, but I couldn't because the patient needed to go for a surgery. But what we can observe is that the nurse is pretty good to correct hypertension. We have a little hypertension here, but the less correct hypertension under vasopressor, while the system still has some hypertension, but has a lot less hypertension under vasopressor administration. Same profile with a neurotrauma head patient, when you can see peak of hypertension when the system is not working. And here, when the system is working, we have less hypertension, but still some hypertension. Then we did a randomized control trial in the operating room. And once again, the control group here in blue and the closed loop group, you have significantly less intraoperative hypertension. Then we also tested this system in the postoperative period of patients who just underwent a cardiac surgery, with the system here in this beautiful picture, and the same profile, the percentage of time with a mean arterial pressure below 65 was the primary objective. In the manual group, where the ICU nurse titrate the infusion of vasopressor versus the automated system. It's obvious there is significantly less postoperative hypertension. Then we have also an ongoing study where we tested this system in neuro or brain injury patients. Finally, we use a combination of automated system to titrate vasopressor administration with a decision support system to help guide fluid administration. And we compare our institutional protocol, where the goal was to maintain mean arterial pressure and stroke volume index within 10% of the optimal value, versus in the other group, we had the combination, as I said, of the decision support system to help titrate fluid bolus administration and an automated system for vasopressor administration. Here you have the computer, the infusion pump, and the hemodynamic monitor. Here you have in purple, you have the closed loop group. You can see that most of the time the stroke volume index here is higher, and the deviation from the target is narrow than in green, which is the control group. Obviously, stroke volume index is rather on the left side, meaning with a lower amount of stroke volume and with a wide variability in the mean arterial pressure maintenance during surgery. Of course, the goal would be for us to combine automated system for fluid and for vasopressor administration, as did this team, but they are still in their experimental development. We already have shown that it was feasible to combine multiple automated systems together, as we did in this pilot study in the operating room. And even we showed that when we use multiple automated systems together, we may observe an improvement in cognitive function of patients undergoing major surgery. If you want to further your knowledge on this topic, I strongly recommend you read these recent review articles on automated systems for both fluid and vasopressor administration. But of course, you know, when everything goes well, using such system is pretty easy and will not be dangerous. But if you have an acute hemorrhage, of course, you can let the system work, but you have to override the system. That's why today we are trying to implement some machine learning safety issues on our automated system. You know, in 2015, we are convinced that machine can do better than human anesthesiologists. In fact, I'm not really a fan of this article, because why? It's because it opposes the human versus the machine. To my opinion, the machine should work together with the clinician for better, for optimal management. Otherwise, we may observe this kind of fact with this self-driving Uber kills Arizona woman with a car crash accident. That's why I believe that technology will never replace the presence of an anesthesiologist or of an ICU nurse at the bedside. We still need to be a good anesthesiologist, to have good nurses in the ICU to manage the patient. Otherwise, once again, we may observe this kind of problem where the pilots were not well trained on the automated system. That's why, once again, I strongly believe that automated system, it's just a way to help us achieve the goal we want to reach for our patient. Thank you very much for your attention.
Thank you for Professor Dustin for introducing us to the concept of automated systems for blood pressure management in OR, and at the same time highlighting that automated machines or automated systems can't replace the clinician at the bedside. So with this, we are concluding the session, thematic session on hemodynamics, and I request all the delegates to proceed to industry sessions. Yeah. Thank you.
Warm welcome and good afternoon all. We will start new exciting session now with ICU infection with an eminent speaker. The next topic is pulmonary aspergillosis by Professor Eliazodi. He is a present director of medical ICU of the St. Louis Teaching Hospital in Paris. His main fields of research are focused on acute respiratory failure in immunocompromised patients, hematological malignancies in ICU, non-invasive mechanical ventilation, severe infections, organ dysfunction in patients with the connective tissue diseases, systemic vasculitis, thrombotic microangiopathies, hemophagocytic lymphohistiocytosis, hemolysis syndrome, and other hematological emergencies. Professor is a professor of medicine in medicine, specialty of pulmonary medicine and critical care unit, and intensive care in University of Paris, Diderot, and Cibron Paris site, and faculty of medicine in St. Louis Hospital, Paris. We'll start now with the example.
Good morning, dear colleagues from India and from all over the world. I'm delighted to present in the virtual Best of Brussels Symposium, Aspergillus in ICU patients. I'm going to show you my disclosures. I would like to start by a case vignette in a patient coming to the ICU in our department 11 days after a septic shock coming from peritonitis. The patient was previously healthy, and he underwent a very complex diagnostic workup that was completely negative for a VAP, as he was developing RDS at day 11 after the initial peritonitis. The patient unfortunately died, and the postmortem biopsies provided evidence of respiratory tract invasive aspergillosis. For this patient, that was a very unexpected situation. Aspergillus is an ubicatory fungal. It's everywhere in the air, and it can be either colonizing the lower respiratory tract or providing in immunocompetent patients allergy or hypersensitivity. However, in immunocompromised patients, we can have invasive or sometimes sub-invasive forms of aspergillus that are associated with mortality in 50 to 70% of the cases when the patients are critically ill. However, in non-immunocompromised patients, until recently, this entity was almost unsure and controversial. In the respiratory tract in the ICU, aspergillus can either be found and growing from samples coming from BAL or tracheal aspiration when we are looking for VAP, or sometimes it can be an RDS from undetermined etiology, and we are considering the possibility of aspergillus. And unfortunately, in this situation, postmortem biopsies, autopsies are diagnostic in most of the cases. So we have two different situations. Either aspergillus comes to you and surprises you, or you are anxious about the patient developing RDS with nothing documented, and you consider the possibility of aspergillosis. How frequent is that a positive sample comes to you in patients who are receiving mechanical ventilation? This is a paper published more than 10 years ago by Matteo Bassetti and co-workers. And in patients where for 2 years, they were sampling in 2 ICUs the patients every week. And they found about 1% of the patients having aspergillus growing from the lower respiratory tract. Interestingly, in this cohort, patients receiving steroids were not sampled. In the other larger cohort from Professor Garnacho Montero, 2% of the patient had aspergillus in the lower respiratory tract, but in this situation, patients receiving steroids were not excluded. So let's say that between 1 to 2% of the critically ill patients can have aspergillus growing from the lower respiratory tract. In this Chinese very, very large cohort, it was even less. So let's say it's between 1 and 2%. In the EPIC study, we can find again the 1.4% of patients with aspergillus, mostly in the respiratory tract in the ICU. So these are consistent findings. Interestingly, again, when you look at an ICU department admitting 1,000 patients every year, you can consider that 4 to 10 patients will have aspergillus growing from the lower respiratory tract. Let's see now the autopsy data. How many patients dying in the ICU and having an autopsy providing the unexpected diagnosis of invasive aspergillosis. This is a paper from Spain with a large cohort of more than 800 patients having an autopsy. And you can see that, again, we can find that 1% of the patients have aspergillus growing from the respiratory tract. And the same group recently reported a slightly increased prevalence of invasive aspergillosis in autopsy, raising the hypothesis that this is maybe in the rise. Of course, we don't know how many patients were actually immunocompromised. In this latest series, half of them were. But the concept that 1% of the non-immunocompromised patients have aspergillus growing from the lower respiratory tract or in the postmortem data has not been challenged by these studies. Let's see now a situation where clearly there is more as invasive aspergillosis. And the first one is RDS. In RDS patients, because of what we call a paralytic immunology, where the alveoli is not able to really fight and to really have a fungicidal activity, we know that, and with many patients receiving steroids, we know that autopsy data, we report up to 15% of the patients with invasive aspergillosis. So these are the data from Brussels, and these are different data. This is not autopsy, this is sampling, and this is from France, where 8% of the RDS patients have an aspergillus growing from the lower respiratory tract. And clearly, 8%, it's eight times more than what we can expect in other non-RDS mechanically ventilated patients. This is an important work, trying to, from the ASPIQ investigators and Professor Blott as the first author, trying to adapt the ERTC criteria that have been developed for immunocompromised patients, mostly BMT recipients and AML patients, into the critically ill setting. And clearly, they made the difference between colonization, putative aspergillosis, and proven aspergillosis. And clearly, when there is one positive aspergillus with signs that are compatible with an invasive infection, with an imaging that is also compatible, we can then consider using BAL data or sometimes host risk factor, adding points to identify invasive aspergillosis. Again, the same authors were then to facilitate the diagnostic workup to let us understand who has actually more colonization than an infection. And these are before the era of the genomics and transcriptomic data that will come up soon in the next years, and that can make the difference between colonization and infection. Clearly, we can see here that the patients who are with classic risk factors didn't change. However, we have new patients with new risk factors, like those in the ICU with steroids, COPD patients, patients with liver cirrhosis, or patients receiving immunosuppressive therapy, but not in the classic, not using the classic drugs, but mostly with other molecules that are favoring invasive aspergillosis. Again, we need to understand better how we can raise the awareness for invasive aspergillosis to reduce the number of patients with unexpected invasive aspergillosis in autopsy data, and maybe more consider for those patients in the ICU, we can have direct and indirect markers of invasive fungal infection. So as you can see here, not only the clinical signs and the imaging signs are very suggestive of invasive aspergillosis, but recently data on BL with mostly the use of galactomannan on BL has increased sensitivity, maybe reducing specificity of these biomarkers, in patients who are critically ill with no classic source of immunosuppression. When we're looking at the patients who are the sickest in terms of RDS, again, we can see that in patients receiving ECMO, there are patients with aspergillosis, and we can understand that the number of patients is very high. Positive aspergillosis, 14% of the patients, with half of them having a putative aspergillosis, which is in the same ranges of severe RDS patients. Of course, in these patients, even colonization denotes a group of patients that is really at risk of dying, and this takes us to the need for developing more strategies for to identify patients with aspergillosis and make the difference between colonization and infection. So these are the patients with acute liver failure, and again we can see that aspergillosis is one of the major determinants of death. And here, what we call the patients with COPD with PIPA, which is a putative invasive pulmonary aspergillosis in patients with COPD, is another very important determinant of mortality, making very clear that now we need to balance those patients with COPD receiving steroids, because it increases the risk very much and is associated when there is an aspergillosis with very grim outcomes. In a recent effort that has been performed by the Dutch-Belgian mycosis study group in patients with influenza, they performed a very important, I would say even, major cohort study showing how invasive aspergillosis is not only occurring more frequently in patients with influenza as compared to patients with CAP, but also how patients who are not immunocompromised not only can develop invasive aspergillosis, but those who are immunocompromised are at increased risk of developing it and of mortality. So they use an operational definition, very acceptable, of invasive aspergillosis. And this is the flow chart. So when you compare patients with influenza to patients with CAP, you can see that there is more invasive aspergillosis in patients with influenza, 19% versus 5%. You could say that 5% in patients with CAP is a lot, but a number of them have actually RDS, so we are in the ranges that we mentioned earlier. And when we look at patients who are immunocompromised, of course, we can see that there is an increase in the number of patients with invasive aspergillosis, but of course, mortality is very high in patients with invasive aspergillosis as compared to others. The same effort have now been turned into making that the critical care community need to have a very high level of awareness of influenza-associated aspergillosis. And there are efforts that have been made on defining what is proven, and overall proven is not different when we compare immunocompromised and non-immunocompromised, but probable is really something where we need to understand who has a colonization and who has an infection. And the recent data and the development of galactomannan on BL makes clearly the difference. When we look at the data, you can see here that the definitions are operational, and they can be controversial, but they have to understand that patients, so by increasing the sensitivity and using galactomannan, we are actually increasing the awareness and then maybe help ICU specialists understand who has a colonization and who has an infection. So in a more recent effort to understand whether those patients had actually an aspergillosis, you can see that for invasive aspergillosis associated with influenza, the same efforts have been published in different journals, making clear that there are pro and con of increasing sensitivity and reducing specificity, but still we need to have more patients diagnosed and treated rather than patients found on autopsy. For Kappa, which is the COVID-19 associated aspergillosis, one major finding from this wonderful review article and actually expert statement in the Lancet Infectious Disease, the definitions of pulmonary aspergillosis have been reminded, but also the new important thing that came up from the COVID-19 pandemic is there are these clinical entities that are trachobronchitis that can be histology proven. So the use not of BL but the bronchoscopy and the direct examination of the bronchial tree makes the difference. So here again, the experts have provided this very, very interesting review in intensive care medicine, showing that in COVID-19, we need to make every effort to separate patients having colonization from infection, but also to detect those who need a treatment. They may be numerous, but the data I'm going to show you that are very different from one study to the other. As you can see here in this review, you will find that the prevalence of Kappa, COVID-19 associated pulmonary aspergillosis, ranges from 3 to 30%, making very clear that we need to have operational definition and standardized diagnostic workup, making us a low incapacity of really ascertaining that patients have either nothing or only a colonization, or sometimes a pulmonary invasive or a trachobronchitis related to aspergillosis, or sometimes a proven infection. So if I'm summarizing what I said, so 1% is the number of critically ill patients having a positive sample growing at Aspergillus. It can be 2% if you are not excluding patients receiving steroids. Liver failure is 3%. RDS, it's 8 to 15%. Severe RDS with ECMO is also 15%, but we can go to 20% with flu and the IAPA, influenza-associated aspergillosis, and I would say that we don't know really what's the actual prevalence of aspergillosis in Kappa. What are the number of patients in COVID-19? I would say that 30% is clearly very high. 3% can be seen as an actual prevalence, but we still need large data and cohort patients with aspergillosis. In COVID-19, however, we really need to stress out that these patients need to be detected. We have operational definitions. We use bronchoscopy. We examine the bronchial tree. We are sampling the patients. We use biomarkers. So we are able to say whether patients have nothing, colonization, invasive of the respiratory tract, invasive of the parenchyma, or sometimes something that is more documented and proven. So to sum up, invasive aspergillosis can be found in ICU patients who are not immunocompromised. We need to rely on a very strict diagnostic workup, and there are many efforts that have been made recently to raise awareness and increase sensitivity, knowing that we are decreasing specificity. Thank you very much for your attention. That was a pleasure to be part of the Best of Brussels 21.
Thank you, Miraj Professor, for amazing talk and informative summary of the aspergillosis in pulmonary aspergillosis. Having said that, I just want to summarize, given an unprecedented event of COVID-19, and it's a difficult diagnosis for aspergillosis, given that lung affected by COVID-19 and obstacles diagnosed by bronchoscopy in sick patients. So I would say that it would be high suspects of injection, index of suspicion should be there to diagnose and teamwork with the IDN pulmonologists. Thank you very much, Professor. So I will go for next talk. this novel talk about aerosolized microbial in ICU by Professor Tobias Welt. He's a professor of pulmonology medicine and director of Department of Pulmonology and Infectious Disease and Hanover University School of Medicine, Hanover, Germany. He's received his doctorate in respiratory medicine from Hanover University in 1994, and his habilitation is to 2000. Previously, Professor Welt held the position of Professor of Pneumology and intensive care medicine at University of the Magdeburg in Germany, and was also a specialist in infectious disease at that institute. Professor Welt leads a multi-center research group focusing on epidemiology, diagnosis, and management of respiratory infection and pathophysiology and treatment of the obstructive airway disease. So here is Tobias Welt in aerosolized microbial therapy in ICU. Here, I hand it to you.
Hello and welcome, and my best greetings to India. I want to give you an overview where we are with aerosolized antimicrobials in the ICU. I'm Tobias Welt. I'm the head of the Department of Respiratory Medicine, Infectious Disease, Intensive Care in Hanover, Germany. Here are my conflicts of interest. So first, I think I have to focus on the impact of nosocomial pneumonia on morbidity and mortality. And this is really high, and this is one of my most liked studies, a study by my dear friend Marin Kolev, demonstrating that in comparison to patients who do not suffer from nosocomial pneumonia, even these patients are comparable from the baseline data. A patient with nosocomial pneumonia has a 15-fold increased risk of mortality. And this is independent from the baseline condition of the patient. So as more comorbidities are present, as higher the mortality rate is, but the difference between those suffering from nosocomial pneumonia and those who did not is the same for all comorbidity status. One of the major factors which make nosocomial pneumonia so dangerous is intubation and mechanical ventilation. And always we have to point out, and this is a 10-year-old paper from Tony Torres in Barcelona and me demonstrating that in patients with ventilator-associated pneumonia, in comparison to patients with nosocomial pneumonia from the normal ward, which need intubation due to respiratory failure, there's no difference in mortality. And altogether, if you look to the difference between intubated and non-intubated patients, it's a twofold increase in mortality for nosocomial pneumonia for those who are intubated and mechanically ventilated. One of the major reasons for mortality in patients on the ICU is multi-drug resistant pathogens. And this is a problem which is increasing worldwide. It's different in some countries, so less resistance in Northern Europe, more in Southern Europe, less resistance, for example, in some of the Asian states, more in others like India. And this resistance leads to a twofold, threefold increase in mortality. And this is the same for gram-positives and gram-negatives. However, gram-negative multi-drug resistant infection is one of the major problems of the future. So which strategies do we use to overcome multi-drug resistant infection? And one of the major hypotheses is that if you are able to increase the concentration of the antibiotic in the tissue, which is the site of infection, there is a better outcome. There are different possibilities to increase the concentration, beginning with prolonged antibiotic infusion, using therapeutic drug monitoring to find the adequate dosage, and this is what I want to talk about in between the next 10 minutes, aerosolized antibiotics. Aerosolized antibiotics are widely used in intensive care units. This is a paper we did from the European Society of Intensive Care, looking to who is using inhaled antibiotics and which antibiotics are used. And as you can see, these are mainly aminoglycosides, tobramycin and amikacin or colistin in most of the units. The reason why we use inhaled antibiotics is, as I said before, the increase in concentration on the lung side. And this is from a primarily paper published by Michael Niederman, a paper which was the baseline for the inhaled amikacin study from Bayer. I come back to later on. And what he showed is the tissue concentration of amikacin in the lung compartment is by far higher than the serum concentration. And as you can see here, these are tissue tracheal aspirate concentrations of more than 6,000 microgram per milliliter, which overruns every resistance threshold. And the same had been shown in animal models here, a piglet model run by Jean-Jacques Rouby in Paris, demonstrating that lung tissue concentration of colistin after inhalation is much, much higher than after IV treatment. And if you look to the burden of pathogens here, the Pseudomonas burden measured in CFU per milliliter, it's much lower if you use aerosolized antibiotics than if you use IV antibiotics or in controls. And this drop down of the bacterial burden is more and more as higher the dosage of the inhaled antibiotic is, as it has been shown here, and I will come back to this later on. However, even you increase the concentration in the lung, you do not increase the systemic concentration. And this is something which is of major interest because aminoglycosides as colistin are nephrotoxic, and with higher systemic concentrations, there is an increase in the rate of kidney failure, and this can be avoided by using inhaled antibiotics. We performed, again, from the European Society of Intensive Care, a meta-analysis of studies using inhaled antibiotics for either ventilator-associated tracheobronchitis and ventilator-associated pneumonia. And first, I show you the data for ventilator-associated tracheobronchitis, most of them done by Lucy Palmer, and demonstrating that there is a twofold increase in clinical resolution and a remarkable decrease in length of mechanical ventilation in those who were ventilated together with inhaled antibiotics. And this is more as more resistant the bugs are. And here you can see the two studies from Lucy, both demonstrating a more than significant effect. I will show you one of these studies more in detail, a double-blind placebo-controlled study in critically ill intubated patients a well-characterized aerosol delivery system was used, and then inhaled antibiotics were administered. And as you can see, for all endpoints, there is a clear and significant increase in patient groups used inhaled antibiotics. And this is very important, the resistance pattern did not increase, but decrease when using inhaled antibiotics. And if you look to the endpoints, the clinical endpoints, like the CB score or something else, there's a clear benefit for inhaled antibiotics. So what is about ventilator-associated pneumonia? And this has been shown also in this meta-analysis, but the results are not so good as they had been for ventilator-associated tracheobronchitis. Altogether, there is a small benefit analyzing some of the trials together, but it's not so convincing than the benefit I showed you for ventilator-associated tracheobronchitis. And the mortality benefit is in tendency present, but it's also not really convincing. In another meta-analysis, which had been done later, more studies had been included. And again, clinical success and microbiological success had been shown, and there seemed to be a clear mortality benefit. And the difference from this meta-analysis to the one before is that more MDR pathogens had been included. So patients at risk for multi-drug resistancy were the main point of these meta-analysis. If you look to side effects of inhaled aerosol antibiotic treatment, and the main one is nephrotoxicity. As I demonstrated before, the systemic levels are low, and so it's not very unexpected that there's no difference in renal failure in comparison to placebo. The mess is that now two big randomized control trials are present. One, the so-called Bruce Montgomery study, using amikacin fosfomycin in patients with ventilator-associated pneumonia, in addition to intravenous antibiotics. On the trial failed in terms of the primary endpoint, but also the secondary endpoint, and in tendency, mortality was higher in the amikacin fosfomycin group than in the placebo group. In another trial, the Bayer amikacin inhaled trial, which is better than the Bruce Montgomery trial because it used a nebulizer which is really sophisticated, the Nexstar system, which allows to be connected to the ventilator and only administer the antibiotic during the inhalation phase and not during the exhalation phase, so increasing the dosage which is administered to the lung. And in this big randomized controlled phase 3 study, altogether there was no difference in outcome between the placebo group and the inhaled amikacin group, a really disappointing result. What is the reason for this? And the reason for this, in my mind, is the trial design. There are 2 points which has to be mentioned. First, it's a dosage of the inhaled antibiotic. In a current review by Jean-Jacques Rouby's group in Paris, it has been shown data coming out of a pig model that you need higher dosages because the ventilation patterns of pneumonia patients on the ventilator are different from normal controls and the antibiotic is not reaching the site of infection. And this is a reason why in this review we suggested to use higher dosages with regard to the resistance pattern of the patient. The second issue is you need multi-drug resistant pathogens. The advantage of inhaled antibiotics is only present if there is a resistant pattern for the pathogen, if the minimal inhibitory concentration is high. Then it makes sense. And I think that's one of the main issues for further studies. You need a standardized IV antibiotic regimen, which is in line with the guidelines and recommendations. Looking back to the inhaled amikacin study, in most of the patients, 5, 6, 7 different antibiotics had been used with 10, 15 different dosages. And then if you do so, it's not very surprising that the inhaled antibiotic cannot show any effect. So to summarize, inhaled antibiotics for pathophysiological and infectious reasons are a good option to overcome multi-drug resistant pneumonia. However, if you want to show this in well-done, well-designed clinical studies, you need to set up a very strict study protocol. If you do so, I'm convinced we will show that inhaled antibiotics are useful and they could be a new option to overcome resistance in clinical practice. With this, I wish you a very fruitful conference here, the Best of Brussels in Poon. I'm happy to be part of this and I'm open to receive your questions. Thank you very much and have a good day.
Thank you, Professor, for amazing talk and regarding this novel approach to deliver antimicrobials and its pros and cons. And I agree that we had to, having said that, it's a pros like decreasing the possibility of decreasing drug resistance and increasing the local concentration. However, as you said that there is, we have to be careful about the ventilator settings, which is probably flawed in the inner trial because spontaneous breathing patients and don't probably won't get proper nebulization type of nebulizer used, which in the exhalation part or influence part is being placed, type of nebulizer and laminar flow. So there are lots of factors playing success of the nebulization of antimalarial therapy. And thanks for nice talk. And we'll start another session with this. And with this session, we'll start another session. Thank you. So next session, we'll start talking neurology. First up will be ICT management protocolized or personalized, but focusing on strategy. Full professor anesthesia intensive care, Milan University, and director of the postgraduate school of anesthesia and intensive care, Milan University of Italy. He has many publications and author and co-author of 63 papers listed in Scopius, plus 226 book chapters, quotations, 9158 H index 48. His fields of interest are mainly in fact the physiopathology of secondary cerebral damage, intracranial pressure monitoring, intracranial pressure monitoring and control, coupling of the cerebral flow and metabolism in head trauma, subarachnoid hemorrhage, guidelines development, computer-based data acquisition and analysis, database design and implementation for head injury. So, Prof, I hand it to you.
Buongiorno. Good morning in Italian. So nice being with you, my Indian colleagues, even in this COVID era. It would be much better to be in person, but perhaps it's already something to share some ideas together through these electronic tools. I am recording from my hospital office, so please forgive me in case it will be noisy. Very often the hospital, as you know, is not a very quiet place where to record. As you see, the title of my presentation is Protocolized or Personalized as far as ICP management is concerned. I took the liberty of restricting the title to traumatic brain injury because ICP, so intracranial pressure, can be a problem in several neurological diseases, but I think more profitable to concentrate just in traumatic brain injury in adults. The second assumption that I would like to share with you, and that it is really the background of my presentation, deals with the meaning of personalized. Personalized, in fact, would mean tailor to the singularities of the patient, the treatment that we are providing. Think of a young boy without any relevant comorbidity or an old man with several comorbidities. Of course, the extent and the aggressivity of therapies should take into account the specific needs of the patient. But the second way of personalizing treatment, since we want to focus on ICP, is to deal with the identification of targets for treating ICP. And I would follow the second meaning of the definition, making a very obvious observation. It's much better to be able to strictly identify targets and to be able of hitting specific targets rather than being limited to, let's say, blind navigation when you don't know where to go or how to really hit your targets. So starting from this assumption, of course, it looks like a much superior approach should be to personalize, or in this case, to target treatment rather than using a protocol that may work under several conditions. So what the targets could be in managing ICP in traumatic brain injury? I think that we can follow different steps and different layers. Because as you see here, intracranial pressure may arise depending on increased volumes inside the cranial cavity. So the physiological starting point is ICP is simply the result of increased volumes that are harbored inside the cranial cavity. If we may identify which volume is increased and leads to intracranial pressure rise, then we may have targets. The first obvious situation is when you have, like in this case, an extradural hematoma. You see that there is a hematoma that is pushing the dura and compressing the hemisphere that herniates through the fats and goes to the contralateral side of the brain. In this case, we have a clear target because ICP is due to an increased volume of the extradural hematoma. And that applies to all, let's say, treatable surgical masses. So in this case, the volume is clearly identified. And we have the possibility of targeting the treatment to the cause. In this situation, you see that this is a very, very swollen brain. We call it swelling. We are not clear if this swelling is due to vasodilation, and I believe that is the most likely explanation. Vasodilation and an increased blood volume inside the intracranial cavity, or like in other cases, it could be to water accumulation that we call edema. Edema is much clearer when we have focal lesions, like in this case, we have a contusion. The blood-brain barrier has been pathologically opened, and water and proteins are accumulating inside the brain, and you can see an hemorrhagic necrotic core of the contusion surrounded by water. That is edema. Ischemia is another possible strong initiator of edema. It's part of the inflammatory response to ischemia, and also in this case, we may have a target, which is water, so we have edema. If we continue going up to the possible causes, we may believe that ICP is raised, like in this case, because there is water. Water is because contusion, but the reason why the contusion causes an accumulation of water is because of the BBB opening. So to have membrane leakage and to have the inflammatory response, we may think of other possible targets. So from this layer, we can go down, 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 down to the ICP rise. So in having this quite complex background, what is the practice that we have and what is really done? So the practice is that we may have a targeted management when surgery is required, because surgery is the proper intervention to correct the hematoma expansion. You remove the hematoma and you relieve the brain from the compression, and ICP is treated. That is very well, is very reasonable, and it has been very well proved. In this relatively old paper, I like this picture. You see, ICP in this case was very high, close to 40 millimeters of mercury, but when the bone has been opened, and much better, when the dura has been opened, the ventricular pressure went down, and when the hematoma has been removed, the intracranial pressure was totally corrected. The issue of correcting ICP has a very good physiological, let's say, explanation. And if we think at the perfusion of the brain, we may see that in these just two cases, but I think they are very eloquent and illustrative, when in these two cases, the hematoma, in that case, that were subdural hematomas, have been relieved and operated on, you see how dramatically the cerebral blood flow has been recovered. Before surgery, there was a strong, impressive reduction of the CBF, cerebral blood flow, both ipsi and contralateral to the hematoma, leading to a global ischemia. 18 milliliter for 100 grams per minute is really the ischemic threshold for the brain. But you see, as soon as that the hematomas have been treated, then CBF goes up, proving that in this case, surgery has been a physiologically sounded intervention. Surgery may also help in a more restricted way when the volumes that we want to control are more limited but can be drained by surgery, like in case of cerebrospinal fluid accumulation. So CSF drainage can be a physiological way to target the ICP and to correct the cause of ICP, like in this very simple paper that came from Cambridge in 2008. Our colleagues did, they put catheters into the lateral ventricle of patients, and they just described two populations. One population that was profoundly relieved, and ICP really was very well controlled in this group. And you see that from this perspective, draining CSF was the appropriate treatment of those patients, while in other cases that was not sufficient, and ICP remained a kind of a problem. And more recently, I just point your attention to other papers just representing the same concept. And I like this title, let's say, the mitigating effects of draining the CSF. So don't take me wrong. I am not praising CSF drain as definitive treatment of ICP in TBI, but it may help. The situation becomes much more complex when we have to deal with this swollen brain, because in this case, it would be extremely important, but it's also extremely difficult to understand clearly if we are dealing with swelling, so vasodilation, increased blood volume, or with edema, water accumulation. And many, many years ago in Edinburgh, where John Douglas Miller, one of the fathers of in neurointensive care, worked, the concept has been exploited, and they had just attempted to separate patients who were more suitable for mannitol to reduce the water content, or to hypnotic in order to deal with vasodilation. So the idea was very good. Unfortunately, only 17 patients in 4 groups, so the information was, by definition, not very convincing. We know that by using hypocapnia or indomethacin, barbiturate, or even hypothermia, we may regulate the vasculature into the brain, and we may somehow counteract the vasodilation, causing vasoconstriction. So very recently, my colleague Giuseppe Citerio has published this paper that came from the Center TBI, which is an international trial collecting patients in up to 66 centers in Europe. And I heard that even from India, now we have additional data that we merged with our data to build up probably the best and biggest database on TBI in the world. But for now, Giuseppe has analyzed some 1,100 patients, and what he did was to look at the use of profound hyperventilation in traumatic brain injury. I am not dealing with the pros and cons of every specific treatment. Hyperventilation is a vasoconstrictive treatment. It makes no sense if there is no vasodilation, and it may be dangerous if there is ischemia. But when vasodilation is the issue, it has to be used. And in this caterpillar plot, you see the centers. This is what on the average we do in Europe. And you see that there are some centers that have a very liberal use of hyperventilation, and on the contrary, centers staying on the opposite side. But my impression is that there is wide variation on the use, but the majority of centers are oriented in favor of using hyperventilation, I wish, when it's needed. Another possible approach to deal with excessive vasodilation is to use sedation, again, to counteract pathological vasodilation. And by using sedation, perhaps we have also a way of improving the physiological properties of the cerebral vasculature by using autoregulation. And in this paper, in this case, a few patients, but the research question was extremely, I think, refined. Can we use sedation to modulate cerebrovascular reactivity? And if you are interested, it looks like by looking at the depth of sedation, there is an optimal depth when autoregulation is much better, and there is a level in which autoregulation is not working as desired. It would be desirable. Of course, if the water accumulation will not be due by vasodilation, but will be due by an ischemic process, I mentioned the possibility of a contusion. It could be multiple contusions, or it could be ischemic consequences of brain injury. then ischemia that definitely will contribute to water accumulation has to be dealt with. And the target at this point becomes to control the water accumulation, something that we may try to do through osmotic or hypothermia. Hypothermia is a very difficult, complex, full of side effect intervention. So let me concentrate on osmotic. And that is the paper that is the result of a panel of colleagues from the USA and Europe. We need to have Indians with us. So next time, please join us. So that was a panel of experts, let's call ourselves experts, dealing with the use of fluids in intensive care. And we looked through some studies and a limited number of patients. But what I like is this plot that describes the changes in ICP that we may obtain by infusing mannitol. So let's say that by mannitol, we may reduce ICP. And that is true. You see, all over the papers, it is clear. What is fascinating to me is that the higher the starting ICP, the higher the ICP reduction. And if you think of the exponential shape of the pressure volume curve, as you probably recall, if you increase the volume inside the intracranial cavity, at the beginning, ICP doesn't increase much. But more fluid accumulates, the higher is the response in terms of pressure due to an exponential shape of the volume pressure curve. As I read this plot, that is a demonstration of the exponential relationship between volumes and pressure. When ICP was very high, the same reduction of water obtained by mannitol led to a very impressive reduction of ICP. On the contrary, when ICP was not very high, the mannitol moved some water from the brain, but that was not reflected in a big change in ICP. Very recently, which is this year, a French group published this paper that deals with the continuous infusion of hypertonic saline versus standard care. So we may use mannitol, or we may use saline, in this case hypertonic saline, and the conclusion is the continuous infusion rather than intermittent doesn't make such a difference. And it was, let's say, a likely result of the trial, but it has been interesting. And if you look at the results, you see that both for the intervention group and for the control, there have been changes in the blood sodium concentration. So patients have been treated properly. With intervention, they got more sodium, so they got an osmotic change, but the results in terms of intracranial pressure were not significant at all. So the conclusion is, and also the outcome was not really different between the two groups. The conclusion is, in practice, we have ways to deal with the water accumulation. It's up to you to choose how to manage it through hypertonic or mannitol. So much and so far for targeting a specific mechanism. What is done in practice is to use what we call protocolized escalating therapy. So rather than pointing at specific target, what we can do is to start with, let's say, a regular good basic intensive care, and then to use sedation and drain CSF if ICP requires to be managed. If that is not adequate, we may add mannitol or hypertonic, or use hypocapnia, or go up to more aggressive and dangerous therapies like hypothermia, barbiturates, or decompressive craniectomy. This is nothing new. when I was in the USA with Professor Tony Marmaru in Richmond, Virginia, to be trained in neurocritical care research, that is the protocol that they used at the time. So really, we are simply repeating a very old concept. We may escalate therapies. And to sum up, we can be, again, quite reluctant in choosing, because it looks like just the smartest way to have targets, to hit the targets, and to be able to personalize treatment rather than using, let's say, a dumb approach that is apparently blinded and not really well targeted. But I think that a balanced view of the two possible approaches should consider other aspects. The smart approach, personalized, targeted, is very complex, requires the clear identification of targets, and also requires to be able to have specific bullets to hit the target, or in this case, specific arrows to hit the target. The apparently dumb escalating approach has some advantages. It's simple, is standardized, and it requires that the more aggressive treatment will be strictly applied only in case of refractory intracranial pressure, because before escalating, you will use the less dangerous treatment. So I think that there are advantages and disadvantages in both approaches. And I do not like to conclude my presentation leaving you in doubts. So I would like to suggest you an additional reading. In 2019 in Seattle, Randy Chestnut, who has been the father of the guidelines in traumatic brain injury, convened this panel of international, in this case, experts, and finally we got also people from India, from Asia, in this case from Shanghai, and all these colleagues together tried to devise and to propose, and this guy comes from India, finally identified him. So we may say we were all together and we designed a possible algorithm for treating patients with intracranial pressure. This, I think, is the most modern version of a rational escalating approach. The algorithm has been subdivided in different tiers. So the first is tier 0, the basic, says that we have to really provide basic, reasonable, good, general intensive care. Fever is bad because it may increase ICP. Hyponatremia is very dangerous because it does increase intracranial pressure. If that is not enough, you can resort to tier 1, 2, or 3. And again, you can select the degree of aggressivity that is necessary in order to treat ICP. I will not go in details. I just suggest to you to download from the intensive care medicine website this paper. This paper is freely available for download, and it may be helpful in your practice. So it's, let's say, a much modern version of this escalating treatment. In conclusion, what I have tried to discuss with you is that there is a background that may justify the practice, that targeted approaches are possible, but may also be difficult. And for daily practice, if you're in doubts about the targets, you may use, I think, a clinically sound algorithm, as I have just presented. But I would like to finish with a warning that comes from our Jean-Louis Vincent, the organizer of the Brussels meeting, and I know he's working with you also for this Pune meeting. So he is one of our reference guy worldwide for intensive care. I totally share the concern of Jean-Louis, as he has published on his editorial in personalization and integration. And what he was saying is that there are some beauties in applying protocols, but simple protocols do not work for complex patients. And I think that that is the very wise conclusion of my talk. I propose to you to identify targets. If targets are too difficult or too ambiguous to be identified, you may use an algorithm, but don't forget that we are treating every single patient. Thank you for your attention.
Thank you, Prof, for this amazing talk on ICP management. And we all know that it's a most straightforward question for personalized versus protocolized. It's like a finding holy grail question. And we should be keep in mind that every patient is different, and we should be taking as a case as it comes. So thank you for nice talk, and we'll go for next talk. Next talk is post-cardiac arrest care in first 24 hours by Professor Marcus Skrivas. He's professor of the Department of Anesthesia, Intensive Care and Pain Medicine in Helsinki University Hospital, Finland. He has many, more than 170 publications in international peer-reviewed journals with 500 plus citations. Special skills and area of interest are critical care in emergency medicine, resuscitation, anesthesiology, cardiopulmonary resuscitation, and cardiac arrest. So, Professor, it's for you.
Many thanks for the invitation to present at Best of Brussels, Beyond India 2021. My name is Marcus Skrivas. I'm an intensivist and professor of pre-hospital emergency medicine working in Helsinki, Finland. And the topic of my talk is post-cardiac arrest care in the first 24 hours. I declare some financial conflict of interest, which are shown here. The topic of my presentation is very much about the what to do first in your cardiac arrest patient, how to determine the cause of the cardiac arrest, how to determine whom to admit to the intensive care unit, and then I'll briefly discuss the first 24 hours management strategies. So with a focus on targeted temperature management and your physiological targets, so targets of your mechanical ventilation and also blood pressure. So the setting that I'm thinking about and I'm describing here is the out-of-hospital cardiac arrest patient that has been admitted to the hospital and is in the emergency department where our task is to plan what to do next, what is relevant during the first 24 hours. And my talk will not so much cover prognostication, how to identify the patients with very severe brain injury. That should only rarely be done during the first 24 hours. So with regards to relevant guidelines, I urge you all to look up the European Resuscitation Council and European Society of Intensive Care Medicine Guidelines 2021 on post-cardiac arrest care, published in Resuscitation and Intensive Care Medicine. So these guidelines are evidence-based and include all the relevant information. So with regards to the immediate action in a patient after cardiac arrest, everything, of course, starts with A for airway. So we need to make sure that the airway is secure. And I know this is your bread and butter stuff, but nonetheless, we need to check that the intubation tube is in the trachea. It's not common, but it's happened to me that the EMS brings in a patient where the intubation tube is not in the trachea, but instead in the esophagus. Waveform capnography is definitely the best way to confirm that the tube is in the trachea. And also we need to make sure that the intubation tube cuff is inflated and the depth of the tube is optimal to avoid hypoxia related to only ventilating one lung. Subrachiotic airways are used more and more, and if the patient has one of those, we need to make sure that ventilation and oxygenation is okay, and we need to make a plan on how to change this to a regular endotracheal tube as soon as possible. Regarding circulation, make sure that you check also the IV lines. So this is a patient brought to our hospital on a very high dose of noradrenaline and receiving multiple doses of adrenaline. And despite that, the patient was hypertensive. And you can see the obvious reason here. So the IV line was not correctly placed, and all these drugs went not into the blood circulation, but into this peripheral tissue here. So that needs to be checked. How about immediate oxygenation targets? And I think it's useful to spend a few moments on brain oxygenation during and also immediately after cardiac arrest. So this is a schematic presentation of oxygen in the blood and brain tissue before, during cardiac arrest, during CPR, and immediately after return of spontaneous circulation. So here we'll focus on blue, the arterial oxygen, and green, the tissue oxygen in the brain. And as you can see, with cardiac arrest, the oxygen in the brain decreases, and also the oxygen in the blood decreases. Then when the patient is started with ventilation with 100% oxygen, slowly the oxygen in the blood starts to increase. And also, but much more slowly, the oxygen in the brain. And very importantly, this is because the driver of oxygenation in the brain during CPR is the quality of chest compressions. Then after return of spontaneous circulation, the patient experiences this massive increase in oxygen in brain tissue because the patient is receiving 100% oxygen, and also because the blood pressures increase to such high levels. So regarding oxygenation, adjust the FiO2. In many cases, the patient doesn't need 100% oxygen. So target a peripheral oxygen saturation of 94 to 98%. Obtain an arterial blood sample, or better still, insert an arc line in order to measure this multiple times during the next 24 hours. And target a PaO2 of 10 to 13 kilopascals or 75 to 100 millimeters of mercury. So what to do about the blood pressure? So with regards to monitoring, of course, monitor the ECG. Palpate the central pulses, the femoral and carotid artery. Keep also a close eye on the end-tidal CO2 waveform. Because if this happens, if you have a nice end-tidal CO2 level that starts to drop very quickly, the patient has gone into a new cardiac arrest and CPR needs to be started again. Very good idea, if possible, is to insert an arc line because it's so good with regards to following up the status of the circulation. What if the patient has severe hypertension? Well, in many cases, this is because the patient received adrenaline during CPR, and the half-life of adrenaline is about 5 minutes. So don't be too worried about the first very high blood pressure. In many cases, that hypertension will disappear after 10 to 15 minutes. Then with the admitted patient, I think it's very important to really make an effort to get a good history about the cardiac arrest and the treatment from the emergency medical service. And I personally always check also the rhythm printouts of the EMS. I like to look at the ventricular fibrillation waveform. Is it very coarse? If it's very coarse, it means that CPR was started quite quickly and the patient has a better outcome than compared to very fine VF waveform that actually approaches a systole. Then this written strip here was given to me, and the EMS stated the patient possibly had ventricular tachycardia. Well, after a few questions, it turned out that this rhythm strip was obtained while chest compressions were performed. So the patient did not have ventricular tachycardia, the patient had asystole. With regards to the most common cause of the cardiac arrest, I'm sure you're well aware that the cardiac causes are the most common: myocardial infarction, arrhythmias, or myocardial insufficiency, but other causes are also occur commonly. With regards to a strategy for this, it's all based on your assessment as a clinician. Is it likely that the cause is cardiac? Are there typical symptoms or a typical history? If that's the case, obtain an ECG. If there's ST elevation, the patient needs to have coronary angiography. If there's not, then it's more about determining the likelihood of a cardiac cause and coronary artery disease or myocardial infarction. Is the patient hemodynamically very unstable? Did the patient have chest pain? Does the patient have a history of coronary artery disease? In those cases, we need to consider angiography and PCI. If it's unlikely that the cause is cardiac, then we need to consider a CT brain or a CTPA, or in some cases, a CT of the chest or even the abdomen. Subarachnoid hemorrhage, I like to include that in my talks because it's not that uncommon and they commonly are not found on admission. We every year have a couple of patients who don't wake up and we do a CT brain and then 1 or 2 days after the arrest find that the patient had subarachnoid hemorrhage. So the incidence depends on the study but ranges from 4 to 8%. Typically female patients with a headache, perhaps a seizure, typically a non-shockable rhythm, and sometimes strenuous activity before the cardiac arrest. Unfortunately, the outcome is uniformly poor unless the arrest occurs in the hospital. Then I'd like to show you this. So this is a picture of the monitor of a 70-year-old female with shortness of breath who had PEA cardiac arrest. So at this point, the patient is on 100% oxygen and the PaCO2, so this carbon dioxide in the arterial blood, is elevated. At the same time, the patient is tachycardic, the saturation is definitely low, given the fact that the patient is receiving 100% oxygen. The end-tidal CO2 waveform shows quite a low end-tidal CO2 value, despite a very high blood pressure. So there's a huge gap between the arterial and the end-tidal CO2. So this leads one to believe or suspect pulmonary embolism, and we expected that. We suspected that, and we did an echo, and there was no real right-sided dilatation that could be a finding in massive PE. And the ED physician, in fact, said that that it would be unlikely for the patient to have a PE with this normal right ventricle, and thought that the CTPA would be a big waste of time. But nonetheless, we did a CTPA and the patient turned out to have a large pulmonary embolism and went on to have fibrinolysis. So after this, it's a case of admitting the patient to the intensive care unit. Are there any prognostic factors that we could use with regards to outcome? At this stage, well, it's quite difficult. We can't really reliably predict the outcome of the patient at this stage. So the absolute majority of patients need to go to the intensive care unit. With regards to outcome, a very important variable that we should document is the delay from the cardiac arrest to return of spontaneous circulation. And that will associate to a great degree with outcome. So this is some data from the TTH48 study published a few years back. So here on the y-axis, you see the proportion of patients with a good functional outcome at 6 months. And then with increasing delays to return of spontaneous circulation. And you can see separately the patients with a shockable and a non-shockable rhythm. And as you can see, clearly the outcome is worse with the long delay to return of spontaneous circulation. But even with these long delays, the chance of a good outcome is about 40%. So we can't really use this any time limit for admitting our patients to the intensive care unit. How about the frail and cachectic patient that looks like somebody with a fatal or terminal disease? In these cases, it's very good to liaise with the family to find out the family's and the patient's wishes in these cases. Important to find out how often does the patient leave the house? Is it weekly or monthly? Do they need help with daily activity? Or are they even bedbound? Are there any clues with regards to unknown comorbidities? And in these cases, it's a good idea to do a full body CT scan to try to identify possible terminal disease. With regards to ICU management, it's all here in a nutshell from this recent from the publication. And I'd like to focus first on temperature management. There are many studies and lots of experimental data showing an association between fever and poor outcome after cardiac arrest. And indeed, previously, therapeutic hypothermia was routine practice. But very recently, the TTM2 study was published, conclusively showing that hypothermia does not improve outcome after cardiac arrest. So this has led to a change in practice, and in our unit, we aim to avoid fever with target temperatures less than 37.8. In many cases, this mandates the use of a feedback control device, and if we need one of those, we target a temperature of 37.5. And importantly, avoid large volumes of cold fluid because that's not good for the failing heart. How about mechanical ventilation? Importantly, it's easy to hyperventilate these patients. So this is some data from about 10 years back, but I think it's very important still. So here on the y-axis, you see the arterial PaCO2 in kilopascals, and here you see the normal capnic range. And each of these white dots is a arterial blood gas analysis of the PaCO2. And here's time from admission to the intensive care unit. And you can see that in many cases, the patients were hyperventilated. So that should be avoided. And it's definitely the case that many of these patients need much less ventilation than you think. So the only way to identify hyperventilation is to check blood gases frequently. So with regards to oxygenation and ventilation targets, these are shown here. So we should target a PaO2 of 10 to 13 kilopascal, as peripheral oxygen saturation of 94 to 98%. So rarely the patient requires very high FiO2s. We need to target a PaCO2 of 4.5 to 6 kilopascals, and we need to use a lung protective approach. How about blood pressure targets? There are no large-scale randomized control trials. There are some pilot trials, but observational data suggests that perhaps the minimally accepted level is about 70. So here's, I'd like to show you this, one of our observational studies, where we looked at about 500 cardiac arrest patients, and we plotted their MAP values over the first 48 hours. And then we looked at different thresholds and calculated the area under these different thresholds, and then compared the poor and the good outcome patients. So this is what it looked like. So here we have the good outcome patients, and here we have the poor outcome patients, and we compare the areas below these different MAP thresholds. So with regards to statistically significant differences, you can see that the area is statistically larger up until 75 millimeters of mercury. So here, this statistically significant difference disappears. So providing us with a bit of indirect evidence that perhaps the minimally accepted MAP is around 70 millimeters of mercury. Other studies have found similar results. So this is some data from the United States, looking at the first 6 hours in the ICU. So here's the proportion of patients with good neurological outcome, and here's the time-weighted average MAP during the first 6 hours. And you can see here as well that the patients with a time-weighted average MAP less than 70 had a much lower likelihood of a good neurological outcome than those with higher MAPs. So the guidelines on hemodynamics in oxygenation and ventilation after cardiac arrest are to target a MAP of higher than 65 millimeters of mercury, target a decreasing or normalizing lactate level, and maintain a adequate urinary output of 0.5 milliliters per kilogram per hour. So noradrenaline is the recommended vasopressor, and also we can use crystalloids with regards to cases when the patient is hypovolemic. And why noradrenaline? Well, we've done some pilot studies comparing a higher than normal MAP after cardiac arrest. And the good thing with noradrenaline is that it nicely increases the diastolic pressure. So here in blue, you see if a higher MAP was targeted compared to a lower MAP. And you can see that with a higher MAP target, also the diastolic pressure increases. And this is without any increase in the heart rate. As you will be aware, the important thing is to perfuse the heart. So the circulation of the heart depends on the degree or the level of diastolic pressure and the heart rate. So we want to maintain a high diastolic pressure without tachycardia. And this noradrenaline appears to do that nicely in your cardiac arrest patient. If the patient has a circulatory disaster during the first 24 hours, I think it's important to have a plan B ready. So this is one of our cases that went in and out of ventricular fibrillation. So we had a mechanical chest compression device on the patient facilitating defibrillations. And we also made a plan that if the defibrillation is unsuccessful, the patient will be transferred for ECMO treatment. So in some select cases and in some select hospitals, this will need to be your plan B. With regards to prognostication, we need to utilize multiple prognostications of combining clinical examination, neurophysiology, EEGs, biomarkers, and also imaging. So conclusions. Post-resuscitation care is of great importance for the survival of the out-of-hospital cardiac arrest patient. Some patients require coronary angiography and PCI, mainly those with ST elevation on the ECG. We should avoid hypoxia, extreme hyperoxia, hypocarbia, hypotension during all stages of ICU care. We should aim for a temperature less than 37.8 using a feedback-controlled device if patient exposure or paracetamol does not work. And we should target a MAP of higher than 65 millimeters of mercury during ICU care using fluids and a vasopressor, such as, preferably in my mind, noradrenaline, because of its beneficial features. And with that, I conclude my presentation and thank you for all your attention. Thank you.
Thank you, Professor, for an amazing talk. I conclude this session. I thank you for listening. And I thank you, speakers, for an amazing session and amazing talk. Thank you very much.
So good afternoon, everybody. I'm Dr. Samir Zog, and my colleague, Dr. Bande, Dr. Balasaheb Bande. We are from ICSM Pune. We shall be conducting our second JAMA session. We had an excellent JAMA session yesterday. The JAMA is just ask me anything. It's not about the talks we had in last 2 days, but it's about asking day-to-day problematic questions to experts in the critical care field. Fortunately, we had an excellent faculty for today's JAMA session. Professor Daniel Dibakar, Bernd Sogel, Professor Jack Durant, Professor Jan de Wel, Professor Nina Stocchetti, and Dr. Valentine Fuhrman. And fortunately, all these have joined us in Pune in our physical best of Brussels in the past few years. So they know what the JAMA session is, and we shall be directly going to question answers. Welcome all. Welcome Daniel. Welcome Professor Stocchetti. Welcome Jack. Welcome Valentine. You had never been to Pune, but still we would like to have you in 2022. And welcome Jan for our.
Hello everybody.
So first question. Yesterday we had a plethora of questions about COVID because, as you know, India been largely hit by COVID. So we would like to start with one first COVID question is going to Professor Nina Stocchetti about management of ischemic stroke in COVID patient. Management of ischemic stroke in COVID patient. Is it any difference in management for non-COVID patient? Please unmute. Professor Stocchetti, please unmute yourself. Please unmute yourself. Hello. Professor Stocchetti, we could not hear you. Professor Stocchetti, we could not hear you. Can you unmute yourself?
Hey.
Yes, now we can hear you.
Okay, well. So, ciao, buongiorno to everybody. So, I am not sure I can answer your question. I was prepared to answer questions concerning my presentation, and I admit I have no experience of stroke-related COVID. So I am not qualified to answer you. Sorry to disappoint you from the very beginning.
That's fine. So can anybody take up this question? Either Professor Jack or Daniel, can you answer this question? Is there a difference in management of acute ischemic stroke in COVID?
If I may, I don't know if you see me and hear me.
Yes, we can see you and we can hear you.
Oh, perfect. So what the stroke in COVID is a little bit different because often associated with the inflammatory process, which is indeed also associated with some, let's say, procoagulant aspect on one hand and resistance to heparin on the other hand, and at the end also facilitation of bleeding at the ultimate point. So the usual stroke aspect of giving aspirin and other antiaggregant is of course relevant, but often when we have seen this patient, we have also treated this patient with anticoagulation. The major risk is, of course, the risk of bleeding that can ensure. When, of course, the patient are in time, you give thrombolytic agents, of course. This is a general management. And, of course, if you have a thrombectomy possibilities, you also will give it. But if in addition to that, I mean, the secondary aspect is really the anticoagulations that often we provided to these patients, but with a risk of bleeding that can ensure. One important aspect is to ensure there is no paradoxical embolization of a deep venous thrombosis, but we never found it in our patients, and in literature it seems not to be a major cause of thrombotic events in the brain at least.
Thank you, Daniel. We had an excellent talk from Alexander Justin from Paris about artificial intelligence in operative room. So this is really a provocative lecture, and we had a publication last year in JAMA about AI-based decision-making in operating room. So I would like to ask the question to Bernd. Is AI and machine learning going to replace all of us in intensive care as well as in operating room in maybe next 20 years?
Well, hello. First of all, hello, everybody. It's a pleasure to join you virtually. Of course, it would have been better to join you in person this year, but I'm more than happy to join you here virtually on the screen. So this is a very interesting question, and I know that it's a little bit provocative. I'm sure that we will not be replaced as anesthesiologists and as intensive care physicians. But I'm pretty sure that artificial intelligence and machine learning, deep learning, and stuff like this has the potential to change routine management of our patients. And I would say that in the operating room, it's even more likely than in the ICU that will happen during the next couple of, let's say, years. I'm not sure if it's 10 or 20 years, but as you know, case numbers in the OR are very, very high. So there is a need for automatization, and there's a need for kind of routine procedures, and a lot of things could be at least augmented by artificial intelligence. So I think, of course, of closed loop systems, of predictive monitoring, predicting respiratory or cardiocirculatory events, and stuff like this. And all of this has the potential to kind of make our life easier. So it's kind of a decision support, I think, more than machines taking over the control. And all of this is very interesting. I would say, just to give a few examples, you know that a lot of people now talk about predictive monitoring with regards to predicting hypotension. I think that it's an intriguing idea, but at the end of the day, it's still something that needs to be double-checked or, let's say, done by an anesthesiologist, because you cannot simply rely on a machine coming up with the diagnosis and triggering a treatment. And the reason for that is that the measurement can still be wrong. You know, if you compare it to airplanes, for example, everybody is telling us, okay, the plane is landing automatically. But the big difference between a plane and a person is that on a plane you have separate, and that is important, you have different and separate measurement technologies. So in a plane, if you measure the height of the plane, the altitude, the flying altitude, then you do this with at least 2 or 3 different devices. You cannot do that in a patient. So to really rely just on the machine, you would have to measure blood pressure, for example, at 2 different in 2 different arteries and stuff like this. And only if those 2 would agree, then you would really rely on the machine and trigger treatment. So what I would say is that machines and artificial intelligence can help us to make our treatment better, for example, because they give us early warnings, or they can kind of give us closed loop support, but they will not replace us.
Thank you. The next question is to Professor Jan de Waal. Today morning, we had 2 quite provocative lectures, one by Professor Mervyn Singer and another by Jolly Vesa about 1-hour antibiotic therapy in surviving sepsis campaign guidelines. And both of them criticized the approach of giving antibiotic to all within 1 hour of diagnosis of sepsis. So what is, so we are a little confused about the guideline and opinion of individual stalwart in the field. So we would like to ask the question, what is your balanced take, I want, on the issue of giving antibiotic within 1 hour?
Good morning. Well, good afternoon, everybody. Great to be here. That's a very nice question, I must say, Samir. The thing is, I think the critical thing is diagnosing with 100% certainty if an infection is present. And of course, once you are there, then I think it's fairly logical to give antibiotics upon diagnosis. And of course, the 1 hour concept means that you have to give antibiotics as soon as possible once you are sure about your infection. Now, we have to admit, in many situations, we are not so sure. We think the patient may have infection. And to be honest, in a lot of patients that come in with some form of hemodynamic or respiratory compromise, you always keep infection as one of the possible diagnoses. So in these situations, when you are not sure, and if the patient does not have shock or severe organ dysfunction, this is where the new surviving sepsis guidelines leave the opportunity to not immediately go to antibiotics, but just, well, not just wait, but investigate. See the patient clinically, do some additional targeted imaging if you think it's necessary, recheck on a patient maybe 1 or 2 hours later and see if maybe another diagnosis came up. It could perfectly be possible that a patient with respiratory insufficiency has pulmonary embolism. And then, of course, we need to do something else than giving antibiotics. So if you're sure about your infection, yes, give antibiotics within the hour, which is, I think, a logical time frame. If you're not sure about your infection and your patient is not in shock, does not have sepsis, but you're suspicious about an infection, then just take the time to further investigate and don't rush to antibiotics. I think that's more or less the new take on early antimicrobial therapy.
Thank you, Jan. The next question is to Professor Jack and Daniel. This is about use of vasopressin. Jack gave an excellent lecture on vasopressin compared to norepinephrine in septic shock. So somebody, one of our delegates is interested in asking as, can we use vasopressin alone as a vasopressin agent in few cases of septic shock? So Jack first and then Daniel. Vasopressin alone in septic shock.
Yes, I think that also a great pleasure to be with you. I think that first, right now, in the study where they try to use as a first line vasopressin, there is no difference in terms of acute kidney injury. But what is very interesting is that when you look at all the studies, vasopressin has a beneficial effect on acute kidney injury in the less severe patient. So I think that there is clearly for me a room as a first-line therapy for vasopressin, maybe in the less severe patient, because even if we need more study, but it's maybe in this patient that maybe by the fact that we decrease the use of norepinephrine, we can have a beneficial effect on acute kidney injury. So for me, we have to, it's possible to use it as a first-line therapy. And the second point is in hemorrhagic shock. In hemorrhagic shock, right now, it's used in addition to norepinephrine, or when we observe that norepinephrine was inefficient in a very severe hemorrhagic shock. And it's very impressive that when we are at a very high concentration of norepinephrine and with a very severe hemorrhagic shock, and we add a vasopressin, we have clearly a very clear effect on restoration of arterial pressure. So I think that we need more study to know exactly the place for vasopressin, but in septic shock, I think it's an interesting alternative to norepinephrine as a first-line vasopressor.
Daniel, I'll just come to you, but before that, a sub-question has arisen, and I think Valentine would like to answer this question. If the patient has got significant variceal bleed and he has developed bacteremia and septic shock, would you like to use vasopressin alone in such patients with liver dysfunction, with variceal bleed, with septic shock, instead of norepinephrine, vasopressin alone? Your comment?
Yeah, of course. From a hepatologist's point, first of all, hello everybody. I'm happy to be here and join you. Thank you very much for the invitation. First of all, from a hepatologist's point of view, in case of variceal hemorrhage, the vasopressor agent of choice is recommended terlipressin usually because it lowers the portal pressure. Some data several years ago, so it's the first agent of choice in this selective situation. For sure, if the patient has severe hemorrhagic shock, usually we add also norepinephrine in this patient, in addition for sure for fluid resuscitation and so on, to stabilize this patient. But in this special circumstances, terlipressin usually is recommended as yeah, that's correct. And then in addition, I would add norepinephrine.
Okay. Then Daniel, your comment on use of vasopressin alone in some cases. We
have a few data on this, and in septic shock, at least the most important one was the Gordon trial, where indeed they used vasopressin almost as the first agent there. And by the way, the signal was not for an improved outcome in that trial. There was different in outcome, but the small difference was in favor of norepinephrine compared to vasopressin. I think that these patients, and these were the less severe because the total dose of norepinephrine in the control group was very similar to the dose in the low dose in the VAST trial. So it counterbalanced a little bit the effect of the subgroup of less severe patients in the VAST trial. The fact is that I think the norepinephrine is much more adaptable for patients in septic shock. I mean that the half-life is very short. You can very fine-tune this and prevent having overshoot in blood pressure. And I'm a little bit afraid that with vasopressin as a first agent, we sometimes will have a little bit too much pressure because we have less possibilities to really fine-tune this rapidly. So I don't say it's a bad idea, but we need first to be sure that cardiac output is really elevated in these patients. In the less severe patients, often it is, but we need to ensure this. And without doing measurements, it becomes to be much dangerous. And second, we need to prevent overshooting and not going too high with vasopressin if you use this. For the liver, I totally agree with Valentin with what he mentioned. It's really a very good point. And I think that for some hemorrhagic shock, especially when you have bleeding in the liver, vasopressin may be a very good alternative because then it may also promote somewhat the aggregation of platelets, which is of course good in trauma, and second, decrease portal blood flow, which is also good if you have liver laceration. But the last point I want to make is just a rough comment on the recent Surviving Sepsis campaign about terlipressin. I mean, I do not understand at all this recommendation against terlipressin, because all the thing is that there is no difference in outcome with terlipressin compared to norepinephrine. So, okay, there are a little bit more digital necrosis, but if you have no difference in survival, this means that you have other advantages, and the advantage may be on the kidney and other things like this. So I think that the recommendation against is totally unsupported and a little bit biased by some aspects which may be financial, difficult to find in some areas, whatever. But at the end, based on scientific reasons, you have exactly the same aspect of a little bit less good for splanchnic perfusion for both terlipressin and vasopressin if your patient has poor splanchnic perfusion, and the fact that you have a little bit more digital necrosis, but this is true for the two. But at the end, if there is no difference in mortality, this means that it is counterbalanced by some beneficial effect elsewhere. So globally, we need to remember that vasopressin and norepinephrine are globally equivalent. no difference in outcome, some beneficial effect on arrhythmias, some beneficial effect on renal perfusion, but of course, some other detrimental effects, so that the balance is no change in mortality.
Just to add a point, completely agree with Daniel. It's very important to monitor this patient to be sure on the effect of cardiac output. The second point is that terlipressin is in my point of view, tricky to use. And vasopressin is largely more adjustable to achieve the goal, for example, of mean arterial pressure that we want. So it's, I think that it's easier to use.
There is another interesting question to Professor Nina Stocketti. Hello. Yes. Since a lot of Indian ICUs do not have the facility of ICP monitoring, there are very few ICUs in India who are actually doing intracerebral, either parenchymal or ventricular pressure management. So a lot of us are interested in management of ICP syndrome in absence of monitoring, actual monitoring, either parenchymal or by ventricular drain. So what will be your guideline for us?
Thank you for this impossible question. It's really a challenge. It's like to ask my colleagues treating sepsis if you can do something without measuring arterial pressure. So no, that is really very challenging and demanding. I think that in general, you may suspect, even through, let's say, non-invasive approaches, if intracranial pressure is a problem for the patient. We have experience in South America, and they have tested the CT scan approach to it. So you can look by imaging if there are signs of increased pressure into the skull cavity. If you look at the basal cisterns, they are not normal, they are effaced or they disappear, or you can measure if there is a shift in the ventricular system when you have unilateral intracranial pressure pushing the brain toward the other side. Another possible approach is by looking at the diameter of the optic nerve sheath through sonography with the bulb, and you can check in the patient the diameter enlarging in this situation. But I think that as a rule, as in general, there is no substitute for now for invasive pressure measurement. So I have a possible comment to this impossibility of measuring intracranial pressure, because it may happen that the patient has been operated on. If that is the case, you can have a probe put into the brain, or if you don't have the resources for an intraparenchymal probe, you can just put a probe under the dura, so it's a subdural measurement. It's not as accurate as the intraparenchymal or the ventricular, but it's very cheap. It's a normal silicone tip catheter. It could be a few euros, and you can still measure pressure if surgery has been done. In the absence of the measurement, I think that the rule should be to prevent the intracranial pressure rises. So to keep the patient quiet, to stabilize arterial pressure, to provide good oxygenation, to avoid the patient fighting against the ventilator, keeping CO2 in the normal range or possibly a little bit lower than the normal range. But I would be quite reluctant in proposing treatment, active treatment against intracranial hypertension, like using hypertonic saline or mannitol, or even worse, extreme therapies like deep hyperventilation or barbiturates, if you don't have a measurement of intracranial pressure. So I think that the prudent approach should be, one, try to have a direct measurement as possible. Look at the CT to have an indirect demonstration of what is the situation inside the skull. And if you don't have this kind of approach, just try to prevent increases of intracranial pressure.
Thank you, Professor Stocchetti. Meantime, Professor Massimo and Dr. Alexander Joosten have joined us. So we'd like to welcome you on our session. Massimo, this is, yesterday we had planned this question for you, but would like to answer this question. Since the vaccination drive has significantly very high in our country, so the patients who are now coming to hospital or some patients coming to intensive care unit after vaccination, would you like to treat them in some different aspect after vaccination for COVID, or would you like to treat them in the same way which you were treating last year in unvaccinated patients? Is there any different strategy for those patients who become sick after vaccination?
Thanks a lot. Very, very interesting question, and I think a hot question at the moment in countries with a lot of patients coming in the hospital after vaccination. First of all, I'm really sorry. I just some problem with my connection to the net. My phone was dead, so I'm sorry. The answer. Difficult to say. At the moment, one of the most important points that we are trying to manage is the problem of antibody monoclonals, because for after EMA and FDA recommendation, in patients arriving in the hospital with high values of IgG against NTS, you can't use monoclonal antibodies, but many of these patients have not any really immune response to the new infection. But the NTS are only an expression of reaction of the immune system to vaccination. So we are trying to solve this problem, measuring in the patient the NTN against COVID-19. And if the patient is negative in terms of IgG NTN, we decide to provide antibody monoclonals. This is one of the aspects in patients vaccinated arriving in the hospital, and particularly in the intensive care unit. The problem is that around 70% of the patients admitted now in Italy in intensive care unit are now vaccinated patients. The remaining part, 30%, are double vaccinated. Most of the patients are with AstraZeneca, and the other is usually with Pfizer. For the majority of these patients after vaccinated, fully vaccinated, are patients with some other illness, particularly patients with hematological diseases, patients with chronic immunodepression, elderly population. So at the end of the story, I think that we provide the same therapy in terms of steroids in the patient with a high profile of inflammatory response. So we also provide anti-IL-6 therapy. Then the only difference may be the use of monoclonal antibodies than before, than in patient non-vaccinated.
Thank you, Massimo. Since Alexander had joined us, I would like to ask the same question in your absence to Professor Bernd Sogel answered actually, but we would like to have your take on this. In next 15-20 years, is machine learning or artificial intelligence going to replace you and me in ICU and operating room? What is your take on that?
Absolutely not. I think that all kind of technology, automated or semi-automated system will never replace the presence of a clinician at the bedside, but will help him achieve a higher competence. So the goal is not to replace, but to help the clinician achieve the goal he or she wants to reach for the patient. So it's not an opposition, as I said, between man and machine, but it's man and machine versus today human alone.
Thank you. This next question is for again Jan de Wel. This is about diagnosis of aspergillosis in COVID patients. you might have heard that we have got significant number of mucor patients as well as aspergillus patients in India. Especially in post-COVID, we had almost a surge of mucormycosis in India. To my best of knowledge, in other countries, I have not read a literature about a surge of mucormycosis in post-COVID area. So there are two sub-questions. One, is there any difference in mucormycosis in post-COVID patients? And first question is diagnosis of aspergillosis with COVID.
Thank you, Samir. This is a challenging one, I have to be honest. But first of all, regarding mucor, I have to be honest, we haven't seen a case in my hospital. And as far as I know from informal contacts with other colleagues in Belgium, this seems to be not a universal problem. So it's very hard for me. The cases that are described are quite straightforward. But it doesn't seem to be a global issue. Now, the other one, aspergillosis, is something we know much more from other settings, of course. First of all, the immunocompetent patients that may develop aspergillosis. Yes, so that definitely is something that could happen. We know it from influenza as well. But also there, if you look at the literature, the incidence is quite variable. As far as I'm concerned, this is something that we need to be aware of, that we need to monitor. But I think it's very hard to give general recommendations, and certainly not things as starting prophylactic therapy, unless we have a better understanding of the exact problem, the extent of the problem, the contributors to the issue. It's a difficult one, but I do agree that as a strategy, we use the same strategy as we do in other patients, in immunocompetent, what we think are immunocompetent patients. It's a very dynamic field. We use steroids now much more, of course. We use other immunomodulators, and it's going to be very challenging and interesting to see how this develops. But I have to be honest, we've seen again in the last few weeks an increase of patients in ICUs in Belgium, despite very high vaccination rates in some areas. But I don't see the numbers of aspergillosis yet so far as we did in previous waves. So it's a very interesting, challenging, but very difficult issue at this point. So be aware of it. If you encounter it, use your normal strategy as a diagnostic approach. But no room yet, I think, for prophylactic therapy at this stage.
We had a very provocative lecture by Professor Jan Bakker, who talked about permissive hypotension in shock. And he stressed upon that blood pressure may not be a good idea to measure. Tissue perfusion is important to measure. And last 2 days, few faculty talk about the mean arterial pressure of 65 and questioned the idea of keeping the blood pressure around 65 or 70. So I would like to ask the question to each of you, because the blood pressure is the single thing, the first thing I think most of us look at in intensive care medicine. With regards to management of shock, first to Professor Daniel de Bakker, then to Jack, then for neurological, Professor Stockady, and then for liver patients, Valentine. So Daniel first, about blood pressure management. A target of 65.
Well, I mean, I think that 65 is definitively too low. And we have issues with some, at least in observational trials, we see even at higher levels than 65, you begin to have a decrease in organ perfusion, which is translated into an increase in organ dysfunction with lower values like 75 or even 65. The problem is the price to pay to try to recover a higher blood pressure. And for this, we need to give vasopressors, and vasopressors have adverse events. So if you look at the balance between the two, it's quite complicated. And so I'm sure that you may find a couple of patients who may perhaps benefit from blood pressure lower than 65, and that still will preserve somewhat the perfusion for most organs. It's very cautious to have these patients awake. So indeed, you may ensure that the brain is not suffering in this patient, because in sedated patient, it will be much more complicated. Remember, in brackets, that the ASFAR trial, a sub-study of that, the sepsis-PAM, they look at the length to awakening, and it was much longer in patients in the low pressure groups than in patients with high pressure group. So it may have some impact on neurological function. But admittedly, at this stage, we do not have data that globally support a higher pressure for everybody. And so I think that individualizing the pressure is a much better way. And so when the patient say 65 is more or less a global satisfactory pressure for most of the patients. In some patients, perhaps we can do lower, but we have to be very cautious, ensure by measurements that these patients are tolerating this lower pressure. And for many other patients, you may also test a higher pressure, but also measure things, ensure that we improve something for the kidney, for the whatever, and then keep the higher pressure if the patient respond. But then if the patient do not respond, go back to the previous one, because the price you pay again will be that you will have more adverse events due to your vasopressors.
Professor Jack, your opinion on the magic number so-called as 65 for shock?
The magic number is difficult to define. First of all, arterial pressure, it's not only pressure, it's also flow, and it's also cardiac output. So it's very important to monitor this patient, not just to have a goal in mean arterial pressure, but also to have a goal in stroke volume. So you can deal only with pressure. We have to deal with pressure, and we have to deal with flow with stroke volume. After, there is, during operative period, there is a nice study, randomized controlled study, showing that for hypertensive patient, it could be important to increase the mean arterial pressure. So I think that we have to go to more individualized strategy in terms of target of arterial pressure. And the third point is that I think that independently of the mean arterial pressure, in a very severe shock, as we have alteration of endothelial and microcirculation, there is still a black box where we don't know really what is the perfusion at the level of organs. So in the future, I think we have to solve this problem.
So Valentine, your take on blood pressure monitoring in acute liver failure, is any different, or would you like to again personalize the blood pressure?
I basically would also recommend for sure to make an individualized decision, but basically just want to mention liver patients. I always have to separate patients with acute liver failure and patients with acute and chronic liver failure, the cirrhotics one. Yeah, cirrhotics are usually more hypotensive, and we did on a European level a study that was initiated from Belgium, from Leuven, the so-called Scotch trial, assessing effect of hydrocortisone in patients with acute and chronic liver failure. And the main discussion was which patients should be included and which is the level of blood pressure that should, where the patient shouldn't be above to be included, and everybody was not sure. and therefore, many say in cirrhotics, maybe a little bit lower blood pressure of 60, but this is basically just a feeling, and we do not have the evidence. And otherwise, I totally agree. And in acute liver failure, in contrast, the main issue in the acute setting is the raised intracranial pressure, and I think we should have to consider in this population mainly on the cerebral perfusion pressure, and maybe in this population there might be a slightly higher blood pressure approved, but for sure we have to assess the parameters, and we should base it on an individual basis, also incorporating metabolics like lactate and so on. Yeah.
So Bernd, you talk about perioperative management and monitoring, and you stressed upon the blood pressure measurement before surgery? What is the baseline blood pressure, the nighttime blood pressure of individual patient? It may not be feasible for all patients to take blood pressure 2-3 days before surgery. So what you would suggest as a number to be targeted? 65 is your starting point, or 65 is your reaching point for blood pressure?
Well, in line with what was said previously, I would say that you need to differentiate between what is the population harm threshold, so what is the harm threshold on your population level if you look at thousands of patients in retrospective database studies, and what is the individual harm threshold in a patient. So for the perioperative period, it's quite sure from many, many retrospective studies that the population harm for acute kidney and acute myocardial injury starts somewhere around 60 to 65. So what I conclude from that is you shouldn't go below 65 in any patient during surgery. If you look at the literature now, we have 2 randomized controlled trials on targeted blood pressure management in the OR. One that was just published a couple of days ago in the cardiology journal is showing that just targeting higher pressures in all patients does not reduce postoperative organ function. So increasing the target for every single patient then for the study population does not do any good. On the other hand, we have one small randomized control trial showing that individualizing targets may be beneficial, that if you look at preoperative values and target your intraoperative blood pressure management based on this, then you can reduce postoperative organ dysfunction. And then, of course, the question is, what is the baseline pressure? And I'm very confident to say that the baseline pressure is not the pressure that the patient has just before induction of anesthesia. So that is what many anesthesiologists do. They measure blood pressure when the patient just arrives to the induction area. That blood pressure is not his normal blood pressure. That is sure, and we have shown that in a nice observational study. So the gold standard, the best way to go, of course, would be to have a look at personal blood pressure profiles just as cardiologists do. That means that you take several ambulatory measurements. The best would be continuous ambulatory pressure measurement during day and nighttime, but this is of course not realistic. So what I would do, I would say if you see a patient on the ward before surgery or during the pre-anesthetic evaluation, take a couple of measurements in resting position with 5 minutes in between, and then that may give you to some degree an idea about his normal daytime pressure. And what you can also do, you can go back to his medical records. What blood pressures does this patient have on the normal ward? Are there values from the general practitioner? So the long answer to a short question is just get as much blood pressure information as you get, and don't take the one preoperative measure that is just taken before induction.
Professor Berndt, I have 2 sub-questions in this regards. One is regarding hypertensive patients, because we do accept higher BPs preoperative, like up to 180, 110 nowadays. And second part is those who do not have a overt systemic dysfunction and likely to have subclinical renal or cardiac dysfunction. Is the MAP going to be different for these 2 categories, or even some vulnerable groups?
Well, the first question about hypertension, I'm not so much worried about hypertension during surgery because it's simply not an issue in daily business. I'm of course worried about a patient with untreated hypertension who's presenting for a surgery, because, well, there are patients, and we know that from our studies that we did doing ambulatory measurements, who never have a mean arterial pressure below 120. So if you have patients who have untreated chronic arterial hypertension, those patients will never have pressures below 120 as a mean arterial pressure. And of course, this is not something that I would feel comfortable to now proclaim that they should have those pressures during surgery. So it's just, I'm sure that they need higher pressures than 65, but of course you need to consider that the therapeutic interventions that you use to increase blood pressure per se also can affect microcirculation, organ function, stuff like this. So you cannot simply just titrate up the norepinephrine perfusion until this patient has his normal very high blood pressure. So it's it's unsolved. It's something that we just don't know what the best target in those patients is. And I would say the same is true for the second patient population that you mentioned.
Professor Stokety, in neuro cases, often neurosurgeon drives us to maintain a particular MAP and all that. So, what is your idea about maintaining? Is there any different approach in neuro cases?
Yeah, thank you for the question. To this question, I can answer because I think that the goal 65 or just in general to accept lower levels of arterial pressure should clearly differentiate if there is a problem into the brain or if there is no problem in the brain. As you all know, cerebral perfusion pressure is mainly due to mean arterial pressure minus intracranial pressure. So even if we can discuss and make theories about the appropriateness of lowering the arterial pressure, that will not apply in the case of a patient who has a raised intracranial pressure, because in that case, the perfusion pressure will be excessively low. We have, let's say, 40 years of data on how dangerous is low cerebral perfusion pressure when the brain is at risk. In general, the brain needs perfusion. ICP is an issue. CPP, cerebral perfusion pressure, is crucial. And if you lower it, then you have big problems. I think that there is also an experience, because you mentioned the surgeons, that came from the, let's say, the 80s, when for aneurysm repair, it became fashionable what we called controlled, deliberate hypotension for exactly a bleeding aneurysm to be repaired. The concept has been totally abandoned because perhaps you may have some advantages during the surgical approach to the aneurysm, but then the patient pays a price. So in general, I think that we should be extremely careful before accepting reduced levels of arterial pressure as far as the brain is concerned.
As we are coming to the last few minutes of our section, there are a lot of questions on empirical antimicrobial coverage in COVID, because in India, you might be knowing that antibiotic resistance is significantly high, and especially the situation has worsened in the last 18-19 months because of use of steroids and immunomodulatory agents. So would like to ask this question of broad spectrum antimicrobials, especially in COVID and in liver failure patients. First to Professor Massimo Girardis about empirical use of broad spectrum antimicrobials in very sick COVID patients.
Another important point, from the beginning, we know that probably for different reasons, patients with COVID-19 are patients with high risk of secondary infection, particularly patients in the ICU, intubated and ventilated. The rate of infection, VIP, is on average around the world is around 15-30%. So the doubt to start a prophylactic therapy is high. But at the moment, we have no clear any indication that prophylaxis could be helpful in this population in terms of prophylaxis against the antibacterial infection. So at the moment, I think I don't know Jan. I know that Jan have a lot of experience and a lot of data to discuss. The same is for Daniel. But at the moment, for my knowledge and from the science, I think that we have no indication for starting anti-prophylaxis therapy for bacterial infection. The same as Jan said before is for Aspergillus. I have just a different opinion for viral reactivation, particularly for herpes viridae. This is another story. I think that the only thing that we can just think to do, but we have to have more research on that, is probably to use selective digestive decontamination in ICU units where the risk of infection is higher than 15-20%, and particularly for VAP. For MDR, you know, Italy is famous for MDR, XDR particularly. The risk of introducing prophylaxis with new antibiotics or antibiotics with high performance against MDR is may have a further risk on new infection, new strain with high resistance. So, conclusion: no prophylaxis for bacterial infection, and particularly, please not use new antibiotics or antibiotics who are effective against MDR bacteria. This is my vision now. I don't know the others.
Jan, your take, and would like to clarify this. Even if patients is on immunomodulation like steroids and tocilizumab or any other immunomodulatory agent, it's difficult to diagnose infection in such patients because you already have leukocytosis because of steroids. These patients do not develop new fever because of steroids, and oxygenation may worsen because of primary disease worsening, new diastolic dysfunction of the heart. So in such cases, it's difficult not to start a new antimicrobial in sick patients.
I couldn't agree more, Samir. This is a very difficult situation. Now, I see two different entities. First of all, there is the problem of co-infection, that is infections that are present at admission and that are allegedly sometimes the reason why patients would present to the ICU. So co-infection early on is a very rare thing, and roughly 5 to 10%, probably around that, have co-infection when they come into the ICU. It's clear that we don't give antibiotics to all patients who are coming in. Now, the other thing is the nosocomial infections, the secondary infections that occur typically in ventilated patients, because we tend to ventilate these patients for weeks quite often. So they absolutely are an important problem, these infections, up to 40-50% even in some series of secondary infections. And as you say, with steroids, with tocilizumab, very difficult diagnosis. Also the biomarkers, also CRP, also procalcitonin. In fact, recent data from the Netherlands show that they are suppressed in patients who receive these drugs, and they rebound once you stop steroids, for instance. So you see CRP going up after stopping steroids, and it's very important to know this and not immediately rush to antimicrobials in that situation. And you're left essentially with clinical evaluation alone. Look at the radiography, of course, look at the FiO2 that a patient needs, but it's a very difficult, increasingly difficult diagnosis. I fully agree.
And the same question to Valentine about not in the context of COVID, but in the context of acute liver failure. In your lecture, you suggested of antimicrobial coverage for potential bacteremia in these patients. So in India, it's little difficult to implement because our infection rates in the ICU are quite high as compared to Northern European countries like Germany, Belgium, and Netherlands. So in this context, would you like to give us some suggestion about use of antimicrobials in acute liver failure patients?
Mm-hmm. So first of all, the liver disease patient is for sure at higher risk for infections, and in the subpopulation of patients with acute liver failure who are on the waiting list for organ transplantation, the high urgency list is usually a matter of 1 to 4 or 5 days, and for sure in this time frame we try to avoid an additional complication as hard as possible, and one of the main issues to put this patient off the waiting list for high urgency liver transplantation is usually infection. So therefore we are very liberal in building a bridge until the opportunity of transplantation and to avoid any additional complications. So in this population, the usual approach is in case of deterioration, hypotension, progressive hypotension, or increase of organ failures, you usually initiate early and antimicrobial therapy, and also repeatedly assess usually on a daily basis, blood cultures and the microbiological assessment. On the other hand, patients with cirrhosis are for sure also at a dramatically increased risk of infections. And in this population, international guidelines usually recommend, for instance, after varicose hemorrhage, you should always initiate antimicrobial therapy as early as possible, because the risk of the most feared complication is infection after bleeding, and this occurs quite frequently. And there are other combinations, like after spontaneous bacterial peritonitis, usually it's recommended to perform a long-term antimicrobial prophylaxis because these patients have a dramatically increased risk for reinfection during follow-up. So usually in the liver disease population, we are quite liberal compared to other populations to initiate antimicrobial therapy, sometimes also on the long term, for instance, in cirrhotics after spontaneous bacterial peritonitis. This is also
Professor Valentine, another question regarding autoimmune hepatitis. We don't have too many cases, and once in a while we do search for it when other causes are probably ruled out. So how often do you get these cases, and do you find fulminant hepatitis with autoimmune as an etiology, and how is the liver transplant appropriate in such patients?
Excuse me, can you just, which kind of hepatitis?
Autoimmune hepatitis.
Autoimmune hepatitis, yeah. Autoimmune hepatitis. Autoimmune hepatitis can occur also as an acute liver failure, and usually it's one of the exceptions. It's patients with a new onset of acute of the autoimmune hepatitis can be considered as, in the term, acute liver failure if the diagnosis is not older than 6 months. So in some circumstances, these patients can develop acute liver failure. In some circumstances, you cannot stabilize this disease with immunosuppressants. Usually you use corticosteroids in the initial phase and after other ones. It can be possible that you treat these patients also by liver transplantation. Many cases can be stabilized by corticosteroids, but in some cases it can be necessary to perform high urgency liver transplantation. Yeah.
Thank you very much, all of you. So we are coming to an end for our JAMA session. The last question everybody would like to ask is not regarding to critical care, but this is regarding the third dose or the booster dose of COVID vaccine, because in all parts of the world, the policy is different. Some countries have started third dose, some countries are reluctant to start. So what is your opinion, or what is the practice guideline by your hospital or your institution about a booster dose? When should we take, and what is your policy? We'll start with Daniel, and we'll ask the same question. Be as brief as possible about the booster dose of COVID, because all of us would like to meet again in 2022 in July in Pune for our 10th Best of Brussels. So this is important for all of us.
So I think the first aspect is that we do not master this. This is just based for most of the countries on a regulatory aspect. And so either the governing bodies decide it is feasible or it is not feasible. For many countries, I mean, we just have to wait until the government gives a green light to have access to these doses. And so based on some data published and from our recent experience, it's quite clear that what we observe is that we have the few patients that are coming in the ICUs whenever they are vaccinated are people with quite minimal antibodies and or immunosuppression to prevent having a good immunity to respond to the virus. So I do not recall having seen somebody with very good antibodies and severe COVID in the ICU. So this is a little bit the issue. So I think that because there is also no very good reason to delay this after 6 months, I think that whenever it will be allowed to have vaccination, at least for myself, I will take it.
In France, Jack, what is the situation in France about booster dose?
In France, we have the green line for nurses and physicians to do the third dose. So we try to push everybody to do this in our units. So I did it.
Yeah. So Massimo, in Italy, what is the situation? Is it advised?
It's similar than French. We started more or less 1 month ago with the frail population. We have population older than 80 years old and all the healthcare personnel. I received the third dose in the booster 15 days ago. So I think that Daniel explained very well the knowledge that we have at the moment. So
did you receive AstraZeneca or did you receive Pfizer?
Sorry?
Did you receive AstraZeneca vaccine or Pfizer vaccine?
Just Pfizer now in Italy. For all the others, we have some hybrid solution. All the subjects who received the AstraZeneca, Johnson & Johnson or Moderna now are receiving Pfizer.
So Jan?
I think it will be essential to control the pandemic with what we see now, with very high first and second dose vaccination rates. We see still a lot of virus circulating. So now in Belgium, the 65 plus population is now being vaccinated. So far, about 1/4 of one third is vaccinated, but also for healthcare workers, it will start very soon. And it will only be mRNA vaccine. So either Moderna or Pfizer will be used in Belgium.
In Germany, Bernd and Valentine, what the situation in Germany?
I think the evidence is clear. Everybody will need a third dose sooner or later. And at the moment, it's 6 months after your second vaccination, you can get vaccinated if you are a medical caregiver or you are of older age. And our hospital already started to give the booster shots.
The same in my
Thank you very much. Thank you for joining us for this excellent JAMA session. And we hope in 2022 in July, we'll all meet in person. So thank you very much.
Thank you.
Thank you.
Thank you. It was a pleasure. Bye-bye.
Great discussion. Thank you so much. Thank you.
Bye-bye. See you in Pune.
So thank you very much. So I'm Dr. Samir Zok here for a vote of thanks on behalf of ISSM Pune and Erasmus University Hospital, Brussels for this virtual Best of Brussels. And I sincerely hope that this is the only one virtual conference that we will have in future. And in 2022, all of us are eager to meet in Pune again for our 10th Best of Brussels conference. So on behalf of organizers, ISSM Pune branch, we would like to thank all the delegates. We have more than 500 delegates registered with us for this virtual Congress. This shows your connect and affection towards Best of Brussels Symposium. So thank you delegates for attending this symposium. Thank you all the eminent faculty from all across the globe, because every year we have got limitation on inviting number of faculties. Since this was a virtual Congress, we could invite top class faculty from all the countries, and we had 27 faculty members for this Best of Brussels. So we sincerely thank our faculty members. We sincerely thank our sponsors, irrespective of this being a virtual Congress. The sponsors were generous to support this venture of virtual Best of Brussels. So we sincerely thank all our sponsors for this virtual Best of Brussels. We thank our support staff, Medvent Conferences, for doing excellent and relentless job of recording the presentations, collecting the presentations, communication, and organizing this excellent audiovisual feast for all of us. We thank ISSM staff members for helping us in the last 1 month in the organization. And here I declare the virtual Best of Brussels Congress being successfully conducted. And we'll see you soon in maybe July 2022 in person in Hayat, where we meet every year. So thank you very much. See you in July. Thank you.